हेलो, वॉल्यूम बढ़ाना इधर। वॉल्यूम बढ़ाना इधर। हेलो
Sir,
सर, गुड मॉर्निंग।
morning. How are you?
फाइन फाइन, थैंक यू, सो नाइस टू सी यू।
Sir, we are waiting to see your legendary work in ENT, sir.
अरे
Really.
सर सर, थैंक यू एंड सो नाइस टू सी यू कमिंग ऑल द वे फ्रॉम उज्जैन टू भोपाल।
You have visited Ujjain in 2018.
आई रिमेम्बर व्हाट अ ट्रिप इट वाज। महाकाल दर्शन, इट वाज मेमोरेबल। थैंक यू सर।
We are waiting for you. What is the first case?
So we have a list of cases, as you must have seen. To begin with, we are starting with a stepidotomy. Probably it's a exploratory tympanotomy. Patient is having a middle-aged female with a moderately severe conductive hearing loss with intact drum, likely to be otosclerosis. Let's explore what it turns out to be, but most likely should be otosclerosis. Clinically, see, otosclerosis is almost always diagnosed initially on clinical grounds, with particularly females, mostly bilateral, conductive hearing loss. Sometimes you get a classical Carrat's notch with proper intact tympanic membrane. The audiogram is reinforcing your finding, but tympanogram also sometimes adds to your diagnosis, though it is not diagnostic, but it reinforces your diagnosis. So on all these basis, you can assume otosclerosis as a likely diagnosis. But the final diagnosis will be intraoperative on the table when we explore how the ossicles are. But clinically, patient has a conductive hearing loss. On tuning fork test also, we always confirm with the tuning fork our audiogram findings. And as I mentioned about the Carrat's notch is something classical for this or any ossicular fixation. You can say as the inertial component of the bone conduction is lost, which is maximum at 2000. So we get a good morning, sir.
My question:
So
do you counsel the patient for
pardon, sir.
how you are going to advise or counsel the patient for this stepedotomy when feel that the diagnosis,
Yes,
because it's only a clinical diagnosis, as you said.
yes. So your point is valid, and the counseling is very important, particularly for this surgery.
Recording in progress.
क्या हुआ यार?
Record.
So, am I audible now?
Sir,
Hello?
you are audible, sir.
बार बार क्यों जा रहे हैं? इधर इधर आओ. Hello?
Sir.
So your point is valid regarding counseling, and this is particularly very, very important in this particular surgery. This surgery is considered all or none sometimes.
Yeah.
The reason being, patient comes with a conductive hearing loss, and you ultimately open the inner ear to insert your piston. And opening an inner ear is always, full of surprises. You never know what is happening behind the foot plate, what is the pressure behind, what are the, what is the anatomy of the membranous labyrinth behind, how your piston is going to behave inside. So lot many things beyond your control. So many a times you are always at a risk of, giving sensorineural hearing loss. So your point is valid about the counseling, because you have to give patient both the options, either to go for surgery and the final diagnosis will be established on the table, and accordingly you will take a call. Most of the time it is otosclerosis and you get away with a regular surgery of stepidotomy, and the results are excellent, over 90% you can say. But you always have to give patient the option of hearing aid. That the final call has to be taken or borne by the patient itself. The reason being, in 1% or less situations, particularly in the experienced hand, even less, there is a possibility of giving sensorineural hearing loss. And worldwide, See, we all know a patient coming with conductive hearing loss, getting sensorineural hearing loss is never acceptable. So you have to counsel the patient very, very well. You pick up the list of otologic litigations worldwide. The maximum falls into otosclerosis surgery category.
Yeah.
This invites lots of problem as patient, because even the dead ears have been reported in the
Yeah.
literature, and it can happen with anybody in spite of the best surgery done. One
Yeah.
can have dead ear, and that is beyond control, because you open the inner ear, you open
Yeah.
the labyrinth and how it behaves. Even the smallest suction falling on the opening can
Yeah.
create general hearing loss. So there are certain do's and don'ts which we have to follow to prevent this complication as much as possible. Otherwise, it's a disaster if it happens to occur. A patient coming with conductive hearing loss and ultimately gets a dead ear. Secondly, your CT scan, what we believe is very, very important to give you a smooth surgical course to prevent surprises.
Yeah.
I'm Sharma sir and Professor Ajmesh Vishwas sir. This is Shubhra from Sri Lanka.
So it's CT scan. You
Good
were.
morning, Sohail. Sir, Vishwas sir, it is my great honor to co-chair the session with a dignitary like you. Thank you, thank you. Thank you very much for your compliments.
Yes, sir.
So,
CT scan.
to add on to your diagnosis or to prevent misdiagnosis, the thing which can help you most is CT scan.
Yeah.
Though it is never, I would say, considered mandatory to have a CT scan before otosclerosis surgery. We don't use such term mandatory, but what I would always say, it is very, very useful if you get a CT scan done,
Yes,
because
sir.
otherwise it can give you a lot of surprises, and many a times it happens. CT
Yeah.
scan will help you, preventing misdiagnosis.
Yeah.
The reason being, this conductive loss behind an intact tympanic membrane could be attributed to many reasons.
Yeah.
You assume otosclerosis as a commonest one,
Yeah.
and most of the time it is otosclerosis, but in certain situations this could be anything else, and your CT scan definitely helps you. I will take you quickly through the CT scan, that
Yes, sir.
what all things you need to touch upon the CT scan, particularly when you think of otosclerosis. So HRCT, temporal bone fine section, is very, very important. If you have a cone beam, it is most important. That can give you sections below 0.1 millimeter even, which is
Yeah.
very important when you deal with such a smallest bone in the body.
Yeah.
Anatomical, abnormalities you can pick up easily on CT scan, and that is very important. Otherwise, sometimes you call for appointment of the surgery
Yeah.
if you have such, difficult anatomical abnormalities. So you can have an idea pre-op. If you are experienced enough, you can still take a call. Otherwise, you can tell your patient and give a hearing aid. So
Yeah.
third is assuming any complications like inner ear complication which might happen to occur if you are not prepared to. CT
Yeah.
scan can tell you those findings. I am going to tell you what you need to look at regarding preventing complications. So CT is useful, I would say, and we must know how to.
Professor Shah, that the videos will be uploaded. Okay. From the management, from the organizers, and there are the 8 minutes we have given the time for each video and 2 minutes for the question answer. Right. So total 10 minutes. Total 10 for each one for 10 minutes. Oh, no.
So we last year we did a stapes surgery workshop wherein we did a lot of live surgeries and discussion. It was a 7-8 hours workshop wherein we discussed the CT scan in detail. So
Yeah.
once it comes to, ये blink कर रहा है गुरु, इधर आओ, तुम blink कर रहा है बार बार. So once it comes to CT scan temporal bone, यार ऐसे नहीं यार, ये सब काम पहले क्या करो, पता है तुम्हें लूज हो रहा है. So once it comes to CT scan temporal bone, you have to look at CT scan differently when you think of different pathologies. Like, for example, you have a chronic ear today, cholesteatoma. Will look at the CT scan differently on different aspect into the CT scan. When you have
Yeah.
a cochlear implant, like yesterday we demonstrated, you have to look at different things on CT scan regarding cochlear implant.
Yeah.
Autosclerosis is altogether different, and you have to look at different aspects. So, and third is, you need to know how to look at CT scan. You need to know how to read CT scan, because your radiologist is never going to give you all those fine details which are
Yeah.
required surgically.
Yeah.
Radiologist, in a simple term, when you get a HR CT scan done, temporal bone done, will give you one line inference: normal steady HR CT scan temporal bone. We
Yeah.
know this. What we know is the anatomical variations which can have a significant impact on this outcome of this surgery, and that we have to pick up. Anatomical abnormalities which can make your life difficult intraoperatively, you can pick up those on CT scan and take accordingly your call. So, can you share my laptop?
Sir, have you got any special consent for the stepedotomy?
Yes, always. Always you must have a full consent of sensory neural hearing loss and even a dead ear.
Okay.
In this era of cochlear implantation, यार ये blink कर रहा है गुरु यार, कुछ करो यार. It's irritating. In this era of cochlear implantation, even the dead ears caused by stepidotomy can be rehabilitated very well with a cochlear implant.
Yeah.
But that is something extreme. You are
Yeah.
not supposed to think, but there are situations. ये सब काम पहले करने थे. ये blink कर रहा है ना. So, in situations where you have a bilateral sensorineural hearing loss, you can still rehabilitate those patients. Profound sensorineural hearing loss, you can still rehabilitate those patients with cochlear implantation. Earlier, people used to avoid taking unilateral, only hearing ear for stapes surgery. But now
Yeah.
in this era, after counseling, you
Yeah.
can take a call of stepidotomy. You can give patient option of stepidotomy, hearing aid. If in any unfortunate situation this sensory loss happens to occur, still the patient can be rehabilitated very well with the cochlear implant.
Yeah.
So that is something we need to know. And thirdly, in the far advanced autosclerosis, when you have autosclerosis which has involved the cochlea, given profound sensory hearing loss, diffuse autosclerosis involving cochlea, still can be rehabilitated with cochlear implant very well.
Yeah.
So, quickly before going to the case, let me take you to the CT scan finding easily. Now, how to look at CT scan quickly
Yeah.
regarding autosclerosis? What all things, important things you need to touch? This is coronal section. You can see here 0.6 mm, and I am coming from upside down. Every movement is 0.6 millimeter down now. You can see going 0.6 millimeter down. That is the top part of the temporal bone in view. You see, this is little tilted. Right side is our concern. We are operating on the right side. This is the superior semicircular canal. This is very important to see, particularly in autosclerosis. Let me tell you,
Yeah.
many a time, patient may have conductive hearing loss, though it has its own feature of superior canal dehiscence, but
Yeah.
it gives a false picture of conductive hearing loss
Yeah.
because of the third window phenomena.
Yeah.
We have two windows in the inner ear. The sound preferentially is conducted through the ossicular chain to the stapes foot plate, and from there, the fluid movement is like that. The one window goes in, the whole window goes in, round window comes out. That baffle movement gives us the movement of the cochlea and electric signal propagation. If you have a third window in the entire labyrinth anywhere, that can lead to sound leaking.
Yeah.
That particularly manifests as a conductive hearing loss on audiogram. That is actually the inner ear hearing loss.
Yeah.
That can't be rehabilitated with stapes surgery. The stapes is mobile.
Yeah.
Gives you a false picture of autosclerosis. And how you can pick up? See, on axial section you can't pick up this semicircular canal dehiscence. How you can pick up? Let me reconstruct to coronal here. There are certain special sections of the you know, superior canal. See, this is the labyrinth. Can you see here?
Yeah.
This is the labyrinth from where all the three canals emerging. Can you see?
Yeah.
This is lateral canal, posterior canal, and this is superior
See.
canal.
Yeah.
Now I am following superior canal. See this. See this superior canal.
Yeah.
See all the way with my cursor.
Yeah.
There's a thick bone over it. There's a thick bone all the way. It is not descent to the intracranial space.
Yeah.
That rules out the superior canal dehiscence, and it is the first thing you need to rule out to reach to a misdiagnosis. To avoid a misdiagnosis, you must rule out superior canal dehiscence. That is one thing. Okay. Now,
Yeah.
as we go down, we must see the dimension of the intra-aortic canal to see any possibility of gusher.
Yeah.
See this, the cochlear aperture, diameter of the cochlear aperture need to be seen. It should not be too big. This cochlear aperture deficiency, like happens to occur in IP3,
Yeah.
can lead to gusher. The moment you perforate the foot plate and you get a gusher.
Yeah.
So all those surprises you can, presume if you have any possibility. So intra-aortic canal dimension is important. You have a CT scan, you have your own software, you can measure the diameter even.
Yeah.
See this? You
Yeah.
can exactly measure the diameter of the intra-aortic canal, the cochlear aperture, see the cochlear turn or normal. This is vestibule, the lateral canal, the posterior canal here. This is the posterior canal. That's the vestibule, posterior canal, lateral canal, superior canal. So inner ear is by and large normal. Then
Yeah.
most important is the facial nerve.
Yeah.
Look at this. This is facial nerve emerging
Yeah.
superiorly in the intra-aortic meatus, going to the first genu. This is first genu. Then the facial nerve, horizontal facial nerve. You can see very well.
Yeah.
That's the vertical facial nerve. And
Yeah.
see, as you go down immediately underneath the facial nerve, this is the stapedial, crura.
Yeah.
And see the faint picture of stapedial crura. Let me enlarge. Can't you make out the stapedial crura sitting on the foot plate? This
Yeah.
is vestibule. This is vestibule, and this is stapedial crura. You can see, and this is the incus which is joining the stapes there. You
Yeah.
can see the incudostapedial joint there. That is malleus there, and you
Yeah.
can see all these ossicle very nicely. This is the foot plate. Now, to measure the foot plate accurately, the cone beam is the investigation of joints. If you have a cone beam CT scan, you
Yeah.
can measure the exact thickness of the foot plate in fraction of millimeter.
Yeah.
That is so important. If you know beforehand their foot plate is 0.4 mm thick, 0.3 mm thick, you are quite happy with that. If you have a very thick foot plate requiring drilling, that is something need experience that can give sensory hearing loss. If you're not experienced, that needs a lot of good micro drills, lot of
Yeah.
things, and you have to counsel the patient little extra in that
Yeah.
situation that you may need that. So that is one important thing. Now, this facial nerve is very important because many a time this facial nerve arching over the over window may be dehiscent, may be prolapsing.
Yeah.
How to get to know? Again, coronal. Going to the coronal. Let me show you facial nerve whether it is. See this. This
Yeah.
is the vestibule here
Yeah.
with all the canals. This is the intra-aortic meatus.
Yeah.
This is the vestibule. This is the ossicular chain.
Yeah.
See, this is malleus, incus. You see incus where my
Yeah.
cursor
Yeah.
is,
Yeah. Yeah.
and then stapes is going to the fine stapedial crura going to the oval window,
Yeah.
the foot plate. And see where the facial nerve is. Facial nerve is here.
Yeah. 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 I can see.
If the facial nerve is prolapsing and covering the foot plate, it would have been lying low.
Yes, sir.
See the facial nerve above there. This dot is the facial nerve.
Yeah.
And this is not lying low and covering the oval window. The oval window may be a little narrow, but it is not covered by the facial nerve. You can see the facial is not distant and a little superior without covering the oval window. You can see very well. I hope you can pick up.
Yes, sir. Yes, sir.
So this is important again to look at the axial section. We need to know what structure to be seen. Can be more informative in which sections. So this is important. Again, coming back to the what are other structures to be seen. Now, coming from the otosclerotic point of view, see, otosclerosis is never diagnosed on CT scan. You
Yeah.
can't pick up the otosclerotic foci. It
Yeah.
starts from the fistula antefenestrum.
Yeah.
Sometimes you get an if you get an inverse autosclerosis imaging, you can find something, you know, the distortion in the bone, a different bone, more, you know, a spongy bone as compared to the thick otic corp. See the otic capsule bone, how thick it is.
Yeah.
So if you find any change in thickness in the otic capsule bone, particularly
Yeah.
anterior to the anterior crust, you can
Yeah.
assume could be autosclerosis, but that is something can't be picked up on CT scan so easily. Now, other thing, what other diagnosis which can give conductive hearing loss and you can pick up? Number one, see, this is malleus,
Yeah.
this is incus. And see what is this? Anterior malleolar ligament.
Yeah.
Can you see?
Yes.
Can you see? Though it is ligamentous, sometimes it gets ossified.
Yeah.
If it is ossified, you can pick up very well on CT scan if anterior malleolar ligament is on. See on the opposite side also. See
Yeah.
the thick ligament.
Yeah.
This could be, causing little resistance or decrease in mobility. We will check thoroughly, but it is not definitely, bony. Sometimes we have seen the anterior malleolar ligament completely bony and fixing the malleolus, giving
Yeah.
conductive hearing loss, and you can pick up very well and
Yeah.
can reach a correct diagnosis. If you ignore that and go ahead with a stepidotomy, you are not likely to get benefit at all.
Yeah.
Second thing, we have seen in couple of cases the malleus fixed in the atic superiorly. How
Mm.
can you get to know? Say this is malleus. Again in the axial coronal picture.
Yeah.
Superior inferiorly. This is malleus. If you have a superior malleolar ligament fixation, bony fixation of the superior malleolar ligament in the atic, you can pick up very well on
On CT.
coronal CT scan.
Yeah. Yeah.
Yeah, you will find a bony spicule that is, ossification of the superior malleolar ligament, which is not there, fixing the, malleus in the atic. And we have seen couple of such cases. Surprises and intraoperatively, we had to change to a different approach, drilling away that bone to release the ossicular chain. So that is important. So these are fine points we need to know during, when you look at the CT scan for the autosclerosis. It was a misbelief that a enlarged cochlear aqueduct can be a cause of gusher. It has been disproven, almost
Yeah.
disproven now. It is always the enlarged, intraocular meatus or the cochlear aperture which is responsible for gusher, never the this cochlear aqueduct, because it is generally closed by the fibro meshy tissue. Then other thing, you can also have a look at the round window. See the round window region?
Yeah.
Open, it is not ossified. You can look at the bone of the cochlea. If it is destroyed, the bone of the cochlea is destroyed by the, see the bone of the cochlea, I'm changing the intensity. If any autosclerotic foci giving demineralization of the bone of the cochlea, you can pick up very well. See the cochlea turns very well, the basal turn, middle turn. So anything which can affect the surgical course, you need to look at the CT scan and you will find the answer, just to avoid misdiagnosis. Another
Yeah.
thing, a lot of people talk about, the persistent stapedial artery. Let me tell you, persistent stapedial artery can't be picked up directly by the CT scan, but CT can give you indirect clue for the possibility of persistent stapedial artery. And we have seen couple of cases. How you can see this persistent stapedial artery means during fetus, the stapedial artery comes from the internal carotid running over the promontory through the stapedial crura into the facial canal and through the facial canal into the bone.
Yeah.
It doesn't get absorbed. Generally, it gets absorbed and it is taken over by the middle meningeal artery.
Yeah.
If it persists, you will not find middle meningeal artery, and that is the indirect clue you can get, on CT scan whether there is persistent stapedial artery or not.
Mm.
Second indirect clue is if it is persisting, it passes through the facial canal and the dimension of the facial canal is more than usual. See the facial canal.
Yeah.
The dimension is normal. This is a
Yeah.
normal dimension. So if persistent stapedial artery is there, how will you pick up? See this. What is this? Foramen spinosum. That is the
Yeah.
foramen spinosum. And if you have a foramen spinosum intact, you don't need to bother about anything, that your persistent stapedial artery is most likely not there. So these are all indirect clues. let's go into the surgical part. Any questions? You can please, we can go ahead. Any point
Yeah.
of time, feel free to interrupt me.
Yeah. So you will be doing under local anesthesia or general anesthesia?
Almost always local.
Local.
Almost always.
Anything special about your local anesthesia using any concentration of adrenaline or the plane which is available, dialogate adrenaline you use or you prepare some?
Regular 1:2 lakhs, and I would never advise any higher concentration of adrenaline,
Yeah,
which can, it can lead to flap necrosis if you use too high a concentration of adrenaline. Should be regular one. Give 10 minutes for the effect to come,
yeah,
and it works well.
okay.
See, these are non-infective ears.
Yeah,
Inflammation invites more bleeding. This is non-infective situation. 1:2 lakh adrenaline giving 10 minutes is good enough to get good surgical field. And still, in case required, you can use pure adrenaline cotton balls in between.
okay,
Topical.
right. Any use of fluoride before and after the surgery?
Yes, that is very important. The role of fluoride, and now mostly taken over by bicarbonates,
Yeah,
is for the maturation of this bone, spongy bone. The otosclerosis, how the normal, enchondral bone is replaced by this spongy bone, giving this kind of picture, and that maturates, sclerosis, all these things happen. It involves the ossicles, the foot plate preferentially. So, in order to prevent further progression of the disease, the fluorides have known to have effect. They have their own disadvantages, sometimes adverse events, intolerance, so many things there.
yeah,
So now, as compared to the fluorides, bicarbonates have come up as a better choice.
okay,
Alendronate and now Jolindronate. Now even the bicarbonates have come in the doses, weekly doses, even 6 monthly injection.
okay.
So that is much safer and much feasible. I would say the compliance is much better. But required in certain situation, we always, I know my teacher, Dr. Ibia Desai, would always give fluoride to every patient almost 2 years, and
Yeah,
he would find good results. There are no studies as such to define any, length of period of bicarbonates use or anything. But yes, it is useful and should be used in certain cases like extensive otosclerosis involving inner ear, mixed hearing loss, and all those things. So, can we go ahead with the surgical part? In
yes,
a
sir.
couple
We
of
are
minutes,
ready.
I'll be with the microscopic picture.
Yeah.
Meantime, or any time, I would say, you can feel free to interrupt me for
Okay.
any question or suggestions. Oh, yeah, उठाना. लेजर चेक कर ली और लेजर चेक करेंगे. और लगा इसको इधर ले आओ, उसको बोलना. Hello.
Yes, sir.
What?
We can see the microscopic picture.
Okay, that's what I want to know. And
Already injected local?
then, sir?
Have you injected the
Yeah.
local?
Already. While I was running the CT scan, and what I can see, the injection cleaning was done.
Yeah,
Little narrow canal, and I can see some blab. See this hematoma little bit
yeah.
because of the local injected by your colleague.
One more thing, whether you use anything special to wash the canal for the sterilization.
Yes, povidone iodine.
Okay,
Line down. That is, leave the pour the povidone iodine for 10 minutes. Leave it for 10 minutes. And
yeah,
see, this point is valid. This should be assessed from the day you fix the case for surgery. If there is
okay,
any external otitis or any canal inflammation or anything, you
yeah,
can tackle it before the patient comes for surgery.
okay,
Little narrow canal and some
yeah,
trauma on the entry canal you can see.
yeah,
Now, this is our posterior superior region you can see.
yeah.
That
This
is
is
the handle of malleus you can see.
this is right here.
Yes, right here, that's the handle of malleus you can see.
Hmm.
That is the posterior superior region. That is our area of interest.
Yeah,
And let me do something to reduce the glare. Okay. I hope the picture is okay.
yes, it's okay, sir.
Now, that's our posterior part and the posterior superior region. That is our area of interest in this surgery.
Yeah,
Basically, not inferiorly
yeah,
to begin with. And our diagnosis will be established once we raise the flap and
yeah,
look the ossicular chain in the middle ear, check the mobility. Then
yeah,
only our diagnosis of otosclerosis will be established.
yeah,
Now, see, that is the level of the annulus.
yeah,
My flap incision is very simple, a horizontal one.
yeah.
See, I'm not going in one go
Okay,
to avoid the tears. Go in multiple, goes. And this is few millimeter, 5 to 6 millimeter lateral to the level of the annulus.
okay,
See, this is simple horizontal incision.
okay.
And since our area of interest is superior,
Yeah,
what I will do, inferior release incision
okay.
to prevent my flap to tear.
It is at the level of 7 o'clock or 6 o'clock.
Yes, you can say exactly.
Yeah,
Okay. Halka. Yeah. So now, what I will do at this point,
yeah.
see my incision?
Yes, sir.
This is a release incision inferiorly where I can elevate my flap to some distance.
Okay.
That's the horizontal one.
Yeah,
Since anteriorly or superiorly, you may have to raise or further extend your incision later. You may have to go far anteriorly sometime.
yeah,
Like I mentioned the situation to inspect the anterior malleolar ligament or
yeah,
to see some handle to do something to the malleus or something like that to the ossicular chain anteriorly. I always keep the option of extending the incision anteriorly. So
Anytime, anytime you felt like using an endoral incision for a sepidotomy?
yes, yes, mini and oral. Some for narrow canals.
Yeah,
This canal is not also very big, I would say,
yeah.
and oral certainly helps you. You can
Because,
use your retractor also with that.
yeah,
So if you are, it depends upon your comfort, your ease, the
yeah,
size of the canal,
yeah,
and mini endoral is acceptable to the patient very well. Hardly
yeah,
any incision visible later on.
yeah,
Our friend Dr. Ashim Desai has been using liberally the
yeah,
mini endoral incision for all autologic surgery.
yeah,
He removes even the most extensive cholesteatomas with the mini endoral.
yeah, yeah,
And he has demonstrated in our workshops a couple of times
yeah,
the same thing.
yeah. So now you have raised the flap up to the annulus.
Yeah, all around together so that it doesn't tear. See this? This is
Any
in.
use of cotton balls here?
Yes, people do use to,
Yes, I've seen many people
to
just
prevent,
using,
your section falling directly onto the flap, to
yeah,
control the bleeding, to get into the plane, many things.
yeah, yeah,
It depends how you are used to.
yeah.
See now, that's the annulus,
Yes, sir. We can
and
see.
I've opened the mucosa to enter into the middle ear.
Yeah,
See that?
yeah, it's visible.
Inferiorly, and raising this annulus a little more inferiorly so that I can push my flap all anteriorly.
So first you raise the flap inferiorly and then you go on the superior side.
Yeah, inferiorly you get a good, angle,
Yeah,
sharp angle to get into the middle ear.
yeah.
You can go vice versa also, no issues. Now see superiorly and you can see the glimpse of the ossicular chain.
Yes, sir.
You can see good incudostapedial joint,
Giant is
good
sapid.
exposure, the stapes, the tendon, even
Yeah,
the
we can.
pyramid well without drilling
Yeah, yeah,
anything.
yeah. We can see. Yes, we can see it.
So that's the initial exposure after. See the value of the inferior extension of the flap.
Yeah,
Your flap you can push anteriorly to
yeah,
prevent it coming again and again into your field.
yeah,
Now, once it comes to exposure, we always talk a lot about exposure, how much exposure one should need, how much this bone, overhanging bone, need to be removed to get
yeah.
adequate exposure.
So how much you remove from
Yeah.
in,
So,
in,
see why
incus to,
exposure is needed. Why exposure is needed? You
yeah,
need to have a look at the complete oval window
yeah,
to perform surgery over there in a better way without giving complications, to minimize complication, number one.
yeah,
Number two, you should have ample of space to maneuver your instrument and piston.
yeah,
So by and large, posteriorly, what we believe, see from the canal wall, this is your incus
yeah,
and this is your canal wall. What we believe, we should be able to see the pyramid well.
yeah,
So now we can see pyramid here and see we have from this to this ample of space posteriorly to maneuver our space. So
yeah,
practically in this particular case, I don't need to do anything as far as the exposure is concerned
yeah,
posteriorly. You have
yeah,
already ample of space, you can see.
yeah.
Now, what we need to improve our space little superiorly, a little more accurate. Superiorly, I want some more space to see my long process of the incus
Yeah,
to the level that it starts broadening into the body of the incus.
yeah,
That is the level. We should not overexpose the body of the incus. If you try to overexpose the body of the incus,
yeah.
can lead to problems, can invite retractions.
Okay.
See
So,
now, see
yeah,
now the structure what I See inferiorly is the cauda. Can you see?
Yeah.
And your movement should be away from the cauda.
So it should
Situation
be,
of cauda is a very important step in this surgery.
yeah,
In chronic ear, the situation is altogether different
different.
because the cauda itself develops neuritis because of the ongoing inflammation, and
Yeah.
resection or sacrifice of the cauda doesn't really give symptoms in the
Yeah.
after the chronic ear surgery. But
Yeah.
in otosclerosis surgery, it can, because it
Yeah.
is absolutely sterile situation, no infection at all,
Yeah.
and sacrifice of the cauda gives symptoms. Pick there. See, I removed a little bit of the bone, not much.
Yeah.
And now you can see the cauda very well.
Yeah.
See this cauda well.
Yeah.
See the glimpse of the facial canal below. The exposure. See the broadening to the body of the incus.
Yeah.
See the long process broadening into the body. Can you see?
Yeah.
We don't need more exposure of the body of the incus than this. See the fallopian canal very well.
Yeah, we can see.
So even my superior exposure in this situation is good.
Yeah.
Can you see very clear or not?
Yes, we can see.
Now the next is to establish the diagnosis.
Yeah. You have to check the mobility.
So we will check the mobility of the ossicular chain first.
Yeah.
Another match. See the exposure is such you can see even the round window there
Yeah. Yeah.
without drilling or curating from behind. See,
Yeah.
if I mobilize the malleus, you can see the movement of the incus.
Yeah, we can see.
See, incusostapedial joint.
Yes. Yes. Yes.
I mobilize the stapes now. Focus at the foot plate. Foot plate is fixed. Can you see?
Yes. 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 Yes.
So that confirms your diagnosis of
Otosclerosis.
otosclerosis, most likely.
Yes.
Many times you assume it as an otosclerosis.
Yeah.
This foot plate fixation could be because of many other connective tissue diseases.
Yes.
You never know, but by and large, the treatment is same. That's the bypass surgery now.
Yeah.
That we are bypassing the stapes to propagate sound to the inner ear. Because the stapes is the main part of the ossicular chain connecting to the inner ear is fixed.
Yeah.
So now, the stapes surgery most of the time has fixed steps. You have to remove the suprastructure, make a fenestra, and put a piston directly onto the incus. Now, this surgery, we are dealing with the smallest bone in the body. This what you see is a very high magnification.
Yeah.
Any untoward movement to the inner ear by means of manipulation of the foot plate can lead to or can invite sensorineural hearing loss.
Yes.
So, the goal in the surgery to prevent sensorineural hearing loss is certain aspect. Number one, no untoward movement at the level of the foot plate should be happening. And to avoid that, we use a tool called laser. We've been using for more than almost 15 years now, going to 15 years. Since then, I've been using this luminous laser for two critical steps in stapes surgery, only for two critical steps.
Yeah.
One is while doing corotomy, particularly the posterior crus.
Yeah.
Posterior crus, see underneath the tendon how thick the posterior crus is.
We can see.
While fracturing the posterior crus, if your foot plate is not completely fixed, not adequately fixed, your movement, it is such a gentle movement. If the movement is not appropriate, if it is a jerk or more than required movement, it can destabilize the foot plate. And that sudden movement of the foot plate may bring the foot plate out, may fracture it, may make it flutter or whatever, will definitely invite some degree of sensory hearing loss, depending upon how fortunate you are, from
Yeah.
mild to even profound.
Yeah.
So we don't want this disaster, and that can be almost certainly avoided by the laser. You know,
Yeah.
I would show you, will vaporize this, foot plate, this crust in no
Yes.
time
Yeah.
without mechanically handling it, without any movement. And the anterior crust we can easily fracture. Most of the time it is fragile.
Okay.
Though
So you,
unfortunately, sometimes the anterior crust we have come across a thick anterior crust.
yeah.
That is again a big problem. And your anterior crust is sometimes not visible with your angle. Your
Yeah.
laser, the aiming beam doesn't reach the anterior crust, and you need a fiber beam for that. And the luminous has introduced the fiber beam as well.
Yeah.
So you have to be careful. Or you can use a micro drill, you can use a carotid scissors. Nowadays we don't use carotid scissors anymore.
Yeah.
But here the laser is the answer. And the second step, I will show you, where again there is a possibility of unwanted movement transfer to the inner ear, that is fenestration.
Yeah.
So during fenestration, if your movement is not absolutely matching the required force,
Yeah.
can lead to again disaster, can submerge the foot plate, can lead to floater, can fracture anything, and then so and so sensory hearing loss. So for these two steps, we use this luminous laser, which gives you a traumatic, access to the inner ear by means of removal of the
It's
stapedial
it's
crura and fenestration. That is
it's
what I'm going to demonstrate here.
it's a
So
CO2
yes, sir.
CO2 or argon or oleum. What which laser you are using?
Yes, sir. Your question is again very important. There are many lasers,
Yeah.
introduced for this purpose.
Yeah.
And argon was introduced way back,
Yeah.
and it is a good laser, I would say. But the problem is the possibility of sensory hearing loss,
Yeah.
as it gives to the inner ear fluids. See, out of all lasers, the safest one by all means is the CO2,
Okay.
and it is invisible laser, which is
Yeah.
made visible by adding this helium laser to it as an aiming beam.
Yeah. So how
And
much?
the laser energy is absorbed by the bone itself, and it is absorbed by the fluid as well. So whatever remaining laser energy passing to the inner ear is absorbed by the inner ear fluid, which acts as a shock absorber
Yeah.
rather than transmitting to the membranous labyrinthine structures.
What will be the depth of the penetration of laser?
It depends upon the power used.
Okay.
That's why the power is very, very important. So what I have done, I have disarticulated the inclusostapedial joint.
Yeah.
Now let's take the rehearsal of the laser. Let me show you the rehearsal before we go to the critical steps.
Yeah.
I will do some rehearsal.
Okay. This is the red light coming up.
Yeah, I am focusing. What we check in this rehearsal, that everything is falling in place. See this laser beam?
Yeah.
Yes. See why I am focused on the yes
Stapedius.
stapedius. Though I can cut the stapedius without any problem with the scissors as well.
Yeah.
On करो ना यार. हाँ ठीक है. See this?
Yeah.
See one shot and the tendon vaporized.
Yeah.
See?
Yes, we can see.
Now ये बढ़ाओ, इसको बढ़ाओ, एक एक करके बढ़ाओ. बस अरे बहुत जल्दी में है यार. हाँ? एक मैं बोलूं जब next. Now we are going to vaporize the crust, posterior crust.
Okay.
See how stout is the posterior crust.
Yes, we can see.
I don't want to give any mechanical movement to the posterior crust at all.
Yeah.
And how I can easily vaporize? Give me a cotton gel form. I will soak I will push a gel foam behind onto the foot plate
Okay.
and towards the facial nerve. The facial nerve is nowhere in the vicinity. It is not dehiscent also, that is good. Sometimes you have a prolapsed facial nerve and really we are scared of using laser on that situation. See this wet gel foam.
Yeah.
As I told you, this laser is absorbed by the fluid.
Okay.
See that?
Yeah, we can see. You made a spot on the posterior crest.
Yeah, I will. See, I place my gel foam covering the areas where I don't want a laser fire. Can you see?
Yeah.
And now my laser is focusing on the posterior crust. Okay?
Yeah.
Ignore bada. Ignore bada. अरे इधर इधर बस. Now look at the laser beam.
Yeah. On.
Can you see the
Yeah.
hollow posterior crust?
Yeah, we can see.
See, it has been hollowed out.
Yeah.
See this. Can you
Yes,
see
we-
the posterior crust now?
Yeah, we can.
It has been hollowed out.
And then
See this?
yeah.
छोटा जल फॉर्म ये पतला था. See, little bit of the thin bone of the posterior crust is still remaining. I can fracture it easily without any problem.
Yeah.
I will use a gel foam again there. See the gel foam behind.
Yeah.
By smaller piece of gel foam this time. दूसरा दे. है ना? This is a very critical step. So there is a fluid behind now.
Yeah.
Even the fluid is good. Brother. See, even the bone thinned out.
Yeah.
Thick. See, broken?
Yeah.
Could you see the posterior crust fractured? And with a gentle movement, I fractured the anterior crust.
So the suprastructure is out.
Yes. See, this is out with no movement transferred to the foot plate at all.
Yeah.
By vapor, had I fractured like this without using laser, it could have destabilized the foot plate, and that would be a disaster. See now the foot plate very well.
Yeah, we can. So now what will be your strategy if you find out the facial dehiscence covering the foot plate?
Yeah, see the foot plate is very well, exposed.
Yeah.
The
So
patient is nowhere onto the foot plate at all.
what will be your strategy if you find out facial nerve?
Okay, facial nerve overhanging, prolapsing on the foot plate.
Yeah.
Then number one, you have to use laser very, very cautiously. Sometimes you avoid using laser.
Yeah.
You can use your adrenaline soaked this thing gel form, and even if your facial is prolapsing, many a times you get a space between the facial and the promontorial, prominence, a
Yeah.
little bit of the space.
Yeah.
And there, if you push your gel form a bit, decongest, and you can little bit push your facial up, you can get some space, 0.3, 0.4 mm space, and then you can make your sinestra mechanically.
Mm.
Many a time we get through, many a times. But once you have a facial prolapse, number one, we always go with a CT scan before.
Yeah.
It is very, very important to tell you. Then you take a call telling your patient before that you may take a call of abandoning the procedure. In
Yeah.
spite of all, precaution, you may still get a facial paralysis or something. If the
Yeah.
patient gives consent, then only. If you have a huge prolapse and you want to go ahead, intraoperatively also you can inform your, patient relative that this is
Yeah.
the situation and we think we can go ahead, but there is a possibility of some problems. Now see the foot plate nicely.
Yes, we can.
Now, since I'm using the titanium piston, this is the
Mm.
time to gauge the required length of the titanium.
Yeah. Yeah.
And what I'm using is a Kurz prosthesis. I'll
Yeah.
tell you the advantages of that. See this. This is the measuring gauge.
Yeah.
Beauty of the measuring gauge is, see the mark?
Yeah.
Start from 1, 2, see 1, 2, 3, 4 millimeter, 4.25, 4.5, 4.75, 5, 6, 7, like that. And see how much it projects to coincide with the middle of the length of the incus. See this?
Yeah.
Accordingly, you look at the mark, it is 7 millimeter.
Okay.
Like this. This is 4.25. 4.25, this is 4.5, likely. See this?
Yeah.
So, this is to keep on the foot plate. This takes care of the rest of the parameters. You just have to, place it on the foot plate and see the level
Yeah.
coinciding the long process of the incus. Let's see. Okay. See when I put on the foot plate, can you see?
Yeah.
It's quite long.
Yeah.
It's projecting over the incus. And this length is, let's see, this is 4.5. Okay. Now let me reduce a little bit and see again. Suction. This is a very, very important exercise. The reason being, this is one of the, I would say, most important factor determining the outcome. The adequate length of the piston projecting into the vestibule.
Yeah.
If it is an overlong piston, I call this as a disaster. All piston related problems are mostly due to overlong piston or a loose fitting piston. Let me put 4.25 now.
You said with the cone beam CT, you can measure the this length of the piston beforehand.
Not only length, the thickness of the foot plate.
Okay.
Yes, required length also you can measure between the body of the incus and the foot plate. Yes, this looks nice now.
Yeah.
Let me tell you, focus it. This is 4.25, and this is most often we get this length, required. You know. Can you see now?
Yeah. It's fit.
See, coinciding with the middle of the thickness of the incus.
Yeah.
See this now.
Yeah.
So 4.25 is the desired length, and this automatically this includes the 0.3 mm of the piston going inside the vestibule.
Yeah.
Okay.
Okay.
So this way you can ensure that your piston is never going to be overlong.
Yeah.
Now the most important part is fenestration again. बढ़ाओ इधर 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 बढ़ाने को नहीं, एक ही चीज बढ़ाएगा बस. Now let us focus our beam onto the
Foot plate.
Can you see?
Yeah.
Match the focal length. ये क्या कर दिया तूने? 0.3 क्यों कर दिया? 5 यार क्या खड़े खड़े करता है क्या? Can you see the beam?
Yeah.
Now question number 1, which area
To be.
we should fenestrate?
Yeah.
Central part inferiorly, as it is farthest from the membranous labyrinth.
Yeah.
But as the piston goes in, the chances of trauma to the membranous labyrinth are relatively less. It is far away from the piston tip.
Yeah.
Central part inferior. Now, with laser, how much laser energy to be used? एक side पर. So we have, studied. There are a lot of publications. We have done in our thousands of cases. The 20-watt single shot
Okay.
gives you adequate. भाई इधर यार एक ही चीज देखा कर. खड़ा कर दिया तूने यार. बस. Ready. Can you see the laser?
Yes, sir.
Laser beam?
Yeah, yeah.
I am giving single shot at the right place. Can you see the fenestra?
Yeah, we can see.
See the fenestra? I can just यार मांगना पड़ता है. This is 0.5 mm fenestra.
Yeah.
See the discrete margins?
Yeah, we can see, sir. Here comes the question, the perilimb fistula, perilimb gusher, when you do a opening stapes.
Yes.
Stapes, foot plate.
4.25 बोला ना? Yes. So perilimb gusher, first of all, you can, predict by means of a good CT scan the likelihood of getting a perilimb fistula, number 1. Number 2, if it happens to occur, suppose you don't have a CT, you don't know what is happening, anatomy there, and if it happen to occur, the first thing is to have a patient and allow this is not perilimb, that is basically CSF.
Yeah.
Patli de, forceps, piston forceps. That is basically the CSF
Yes.
which drains. So
So,
wait for few minutes, allow the CSF to drain.
okay.
Nothing is going to happen. No drug is going to work. You can give a shot of steroid as the manipulation happens, sudden gush.
Yeah.
And when the CSF pressure decreases,
Yeah.
must put a piston. I would always say
Okay.
put a vein graft and put a piston, and then in that situation of gusher, it is must to put a piston to keep your seal in place.
Okay. Any use of mannitol?
It doesn't work much, sir. Mannitol is basically to reduce the brain edema.
Yeah.
It has nothing to do with the CSF pressure practically. Now see, the
Yeah.
most important thing is my piston. I
Okay.
love this piston for many reasons because what ideally need, what should be the ideal piston? See, this is my simplest part of the surgery now.
Yeah.
Simplest part, loving this piston. This is a Kurz titanium clip piston.
Okay.
See, it has three parts. See this, you can see the three parts. The first one to take on the long process.
Yeah.
Second one to hold incus like a clip. And
Yeah.
third is you know, the bar to push the piston. See that?
Yeah, we can.
All the piston on the fenestra, put it, all the incus and just push. That's it.
Yeah.
It holds the incus so tightly. See this like a clip.
Yeah.
So what all you expect from an ideal piston? What all you expect? Number one, it should be extremely biocompatible, which the
Yeah.
titanium is.
Yeah.
The weight of the piston is similar to the weight of the stapes.
Yeah.
Very, very sleek, slim piston. Number two, it should not require crimping.
Yeah.
See the first part which takes on the incus, it opens like it is little you would say um, like a spring. It opens up, and as
Yeah.
you push it, the middle part takes over the long process of the incus.
Okay.
Tightly holding the incus with no play between the piston and the incus. That is most important.
Yeah.
Whatever sound energy coming to the incus is transmitted to the vestibule now without being lost at all by the play between the piston and the incus. And to prevent that play, what you need otherwise if you don't have this piston? Crimping.
Crimping, yes.
Crimping by a human being, adequate crimping by a human being to hold the piston tightly onto the incus with no scope of, under or over tightening is next to impossible.
Yeah.
Though we have been able to do it with a Teflon piston very well with a good results, I don't say it can't be,
Yeah.
but there is no control. And many a times we assume that the piston has a memory in itself crimps over it. Generally, the pistons do not have memory, generally.
Yeah.
But in good hands, in the experienced hands, you can use Teflon very well. I've seen Ashim Desai using a Teflon crimping with both hands.
Yeah.
Introducing both hands at a time, what he does, and that is simply amazing.
So
But
chances
here,
of long process incus getting necrose after this kind of piston.
yeah. So that is very important, valid question, sir. So in crimping, why that happens? In crimping, when you crimp, under crimping is disaster as well as over crimping.
Yeah.
If you leave the piston under crimp, this piston will keep on hitting the incus because of the loose piston.
Yeah.
And that is the biggest cause for erosion of the long process of the incus. Another cause of the long process erosion is piston fixed at the margin of the fenestra, fixed without mobility,
Yeah.
and can erode the incus above. Number two, over crimping. If you try to do over crimping, it can disarticulate the malioinguinal joint, and that's a disaster.
Yeah.
Or too much of over crimping, 360-degree on the incus can hamper the vessels which are running along the long process anteroinferiorly into the core of the incus, and that can happen to lead to long process necrosis.
Yeah.
So the crimping is such an delicate procedure, calculated movement, and ideal crimping is difficult to achieve most of the time. And I'm scared of all these complications in spite of doing a good surgery. So we use this titanium. The beauty doesn't need any crimping.
Yeah.
See my piston, I have done a hanging test. You just pull out a little bit of the incus and you will see the long process of the end of the piston, you know, swimming
Yeah.
at the margin to ensure that it is not over long. See this, I can see that, the end of the piston. That shows me that it is not an overlong piston. That is something I want from piston side. The piston should be biocompatible, so easy to use. See, how long did it take to place my piston? Few seconds.
Yes.
With Teflon, I have seen people struggling for half an hour or more even.
Yeah. So
This
now
is so, just take on to the long process and just push it gently and it takes on. That's it. It's like a video game, you can say.
yeah. Now you are going to put some connective tissue around the.
Not really. Now we believe in pouring a drop of blood. That's it.
Okay.
See that?
Okay.
Now the misbelief people might ask, this blood might enter into the vestibule. Never.
Yeah.
See, what all required for this is the vestibule should not be sucked. No
Yeah.
suction should be directly placed over the vestibule.
Okay.
If you suck the perilymph, you are going to give complications for sure. And that
Yeah.
is the most common reason inviting sensorineural hearing loss when you put suction on the fenestra.
Yeah.
What's my point?
Yeah.
That is one of the biggest reasons that and one must avoid that. If the vestibule is full of perilymph, we know the pressure inside the vestibule is more than the pressure inside the middle ear. If vestibule is full of perilymph, this blood is never going to enter into the vestibule. So don't worry. Got my point?
Yeah. Yeah.
This blood is never going to go inside the vestibule at all.
The blood has been taken out from the patient during the surgery.
Just now.
Yeah. Okay.
The beauty of the,
No gel foam, nothing.
pardon?
No gel foam or anything around.
Nothing, no foreign material at all. See now, we didn't use any cotton ball or anything. We'll just replace our flap and come back. And the advantage of this, this surgery performing under local anesthesia was
Patient,
yes,
patient
yes,
can
the
hear.
here you can check the hearing and you can get the patient feedback.
Yeah. Yeah.
If your piston is too long, impinging on the membranous labyrinth, the patient will perceive vertigo.
Yeah.
And that is something, an important warning sign from the patient that we must appreciate and do something as something has gone wrong. We must bring out the piston immediately, check the size again, and then put.
Okay.
That kind of a feedback is completely lost when you do under general anesthesia.
Yeah.
Secondly, if you have a doubt of, mobility of, in spite of having done a good job and doubt on the hearing improvement, which is not, patient is not perceiving as much, you can go back and check the entire mobility, the anteromalleolar ligament, any other thing which can affect.
Yeah.
So that feedback is always very, very important in this surgery from the patient side.
Mm.
And that concludes this first session with the stepidotomy.
Yeah,
Though it was the only challenge in surgery was a canal, which was little narrow, but we could overcome. Otherwise, rest of the things were as we expected, as we saw on the CT scan.
Yeah.
It went off smoothly that way. And laser has been the main tool. Laser made our life so simple.
Yeah.
Otherwise, there is always uncertainty in the mind that I might displace the foot plate and patient may get sensory hearing loss. If you have a laser, you have a confidence that you are not going to, give such kind of complication.
Yeah,
So,
thank you. Thank you very much, Dr. Satish Jain, for such a very nicely shown your work, the use of laser and discussion. One question, if there is too much of the anterior overhang, what you are going to do it?
Too much of the anterior overhang.
Yes, this
Yes,
patient, you said,
yes,
yeah,
yes, yes. If it is too much, you can make a separate incision over it.
yeah,
Drill with a diamond the
yeah,
overhang part and replace the flap over it. Just a small flap at the part of the overhang you can raise and drill it. Because yes, this is important point. Sometimes we come across and we
yeah.
can easily overcome.
Thank you, sir. Thank you very much. What is the next case?
The next case is adenoidectomy.
Okay.
The next case is a child who is mouth breather
Yeah,
and allergic as well.
yeah.
And the reason is very, very obvious when we got the X-ray done. And this was the enlarged adenoids, which is responsible for all these issues.
Yeah,
So adenoid is a big problem.
yeah,
We all know.
yeah,
Enormous. So adenoid is something in children need to be addressed if they obstruct the airway,
yeah,
because in this is the age of growth wherein a mouth breather child, if adenoids not removed, can lead to adenoid facies.
yeah.
And this is something preventable. Secondly, along with the adenoids requires treatment of allergy, because adenoids and allergy are,
You go to,
associated.
yeah,
Allergy, you know, leads to adenoid hypertrophy. Adenoid is basically lymphoid tissue.
yeah. So do you offer any medical treatment before advising for surgery in adenoids?
Pardon?
Do you advise any medical treatment before going for surgery in adenoids?
Yes, yes. Always we give steroid nasal sprays. If any
Okay,
associated infection, we give even a course of oral steroid for a few days, antibiotics, all that to reduce the inflammation. Then month-long trials of nasal sprays. That is the
okay,
only thing which is known to have effect on the lymphoid hypertrophy. Montelukast has a role on lymphoid hypertrophy. So you
okay.
can give trials, Montelukast and nasal spray, mometasone,
Yeah.
and it works. But if you have extremely hypertrophic adenoids not working, you have to take a call of adenoidectomy.
This was an antibiotic ointment soaked gel foam, or is this
Hmm?
gel foam? This gel foam
Or
which
the
you,
ciprofloxacin dexamethasone.
okay,
So the allergy and adenoids are, part and parcel to each other. Adenoid allergy enhances lymphoid hypertrophy. In response to the allergy, the lymphoid tissue gets hypertrophied, and allergens reaching to the nasopharynx further enhances. So it is very common among allergic children.
yeah,
And this hypertrophic adenoids, you know, itself further exaggerates the allergic response. So it becomes like a vicious cycle sometimes.
yeah, yeah.
So even after adenoidectomy, you must counsel your patient to, give anti-allergic treatment always. थर्मस ला के रख ले उसमें, वही करना कब करेगा, सारी जिंदगी निकल जाएगी कब। तो देखिए किसी बात Hello? Hello? Hello?
Hello.
Yes, sir. Yes, sir. In couple of minutes, we are moving to the next case. It's all set in the other OT. And then we'll take other cases like endoscopic sinus surgery with navigation, some cholesteatoma, and a massive angiofibroma. Angiofibroma with intracranial extension, the huge one, and
Okay, sir.
thyroid as well.
You'll be using a microdebrider for adenoidectomy?
Yes, both microdebrider and coagulator at different times. I will show you when to use what for the regions. Correct.
So there are some online questions which have come up.
Yes, please.
One was, can we fix the piston without removing the stapes suprastructure?
Yes, that is a technique described by Hugo Fish, proposed by him as a reverse stepedotomy. You know why we use laser to avoid foot plate manipulation while coronotomy and fenestration. So the proposition from Hugo Fish was when you have adequate space to put a piston before with the entire stapedial arch intact, inclusive arch intact. His proposition was to make the fenestra that time to prevent displacement. Make the fenestra and put a piston first and then dismantle the suprastructure.
What about the incudostapedial joint? That has to be dislocated or it has to be kept
later? It has to be intact.
Everything is later.
Everything intact, so that you take the advantage of the integrity of the entire chain and make a fenestra and put a piston without displacing anything. And then afterwards, you can remove the suprastructure. So if you don't have a laser, you can try that, provided you have,
Most of us are not having lasers, so that is why this question came up.
Yeah, provided you have ample of space to, negotiate the piston and make the fenestra and all that.
Wouldn't the posterior crura hamper our manipulation?
Yes. Yeah, that hampers, and sometimes even if there is a posterior crura, thick posterior crust, what you can do is to use a micro drill and thin out the posterior crust.
Use what, sir?
Use a micro drill to thin out the posterior crust.
Okay.
To acquire more space on the foot plate, and then you can put a piston. When they make a fenestra and put a piston, this has been demonstrated several times by our dear friend Dr. Ashish Bhumkar in our workshops. He loves, drilling the posterior crust to get more space, to make it more fragile. You can fracture it without laser more safely. So this is something you can modify. Use a micro drill to thin out the posterior crust and then get more space. You can fracture the posterior crust more, safely as compared to fracturing the thick, stout posterior crust.
Yes, sir. So this was the question by Dr. Hakim from Bahrain. Now the next question is from Dr. Deepa of Kannur, Kerala. And she wants to know how to deal with a submerged foot plate.
Yes. So first of all, convey my regards to Dr. Hakim, is our dear friend from Bahrain.
Yes, sir.
And coming to Dr. Deepa's question, if the foot plate has gone submerged, believe me, it's a disaster. Now, to add on to the disaster, we keep on retrieving the foot plate. More you try to manipulate with your instruments inside the vestibule, more you are going to traumatize. The best way safely is putting a your angle hook close from the edge of the fenestra to retrieve it. That is the best attempt you can make and put a fascia over it. So that is now important. Once it is submerged, if the fluid is there, if you have not sucked the perilimb completely, still it will, swim and you can retrieve it easily. But if it is completely sunken, don't manipulate too much to traumatize further. This is very important. So this submerged foot plate, it happens to occur mostly during fenestration. Uncontrolled fenestration. You are putting your drill or you are putting your perforator with a sudden movement and it takes the foot plate deep inside.
So should we leave the foot plate there?
Yes, if it is too deep, it is going to swim up once the perilymph is there. That's why I told you, take your angled hook. The fish has designed a special hook along the edge of the foot plate, and you can manipulate it laterally, bring it laterally. If the perilymph is dry because of the suction over the vestibule, you can push in some steroid, some ringer lactate, and allow the foot plate to swim over. It comes back. And then
Okay,
pull your
so
graft onto it.
Dr. Hakim is saying that our dear greatest teacher Satish, how can you help a young patient in early otosclerosis suffering from bad tinnitus?
Bad tinnitus, yes. And early otosclerosis. Both the questions are valid.
The emphasis was great. Our greatest teacher Satish.
Oh, nothing like it. I would say we are all learning from each other. The science is always evolving. No one is perfect, and it's a great opportunity to interact with you all. So, first of all, tinnitus. Tinnitus, is something which you don't have any control over, with the stapes surgery. No control over tinnitus, but mostly the low pitch tinnitus, because of the conductive hearing loss, settles. It improves most of the time, but you can't guarantee your patient regarding tinnitus improvement. That is something important. Picture? Are you getting the endoscopic picture of the adenoids?
Yes, sir, we are getting it, sir.
See this child. This is after complete decongestion.
Yeah.
Decongesting the nose. See this nose after decongestion, and this nose. This purely after decongestion. Okay?
Yeah.
30 Mangal. So, coming to your question before move on to the second part was the early fixation of the foot plate. Early fixation is something you have to handle it very, very carefully. How early fixation happens to occur, let me tell you. That's why the dictum is, if you don't have a conductive hearing loss more than 20-25 decibel, don't operate the stapes unless you have a laser. Laser you have seen, that is atraumatic without any manipulation. Then you can handle any degree of, minimal degree of hearing loss without mobilizing the foot plate. But if you don't have a laser, then wait for the foot plate to fix completely. You know what happens in the earliest phase? This otosclerosis starts at the fistula antefenestrum as a small focus and pushes the foot plate behind. And foot plate gets fixed at the posterior vestibulo-stapedial joint because it is pushed from behind because of the focus starting the fistula antefenestrum. So that pushes the foot plate behind, giving it fixity. That is not true fixation of the foot plate to the oval window by the otosclerosis. What my point? That is not true fixation of the annular ligament. It is the false fixation of the foot plate as it is pushed behind by the otosclerotic foci, which is arising earliest in the early phase at the fistula antefenestrum, and it pushes the foot plate behind, which gets fixed all around at the oval window, but not true fixation. In such situation, if you are using a mechanical instrument, you are likely to make it floater. When there is no complete fixation of the foot plate all around, not true fixation, if you are using your mechanical tools to make a fenestra or anything, you are likely to get a floater. You're likely to get a submerged foot plate, which we discussed just now. So allow the foot plate to fix completely, otherwise use laser. I
What
can
if
see
there's a
on screen. I can see on screen the big boss, Dr. Sanjay Agarwal, sir.
Good morning, Satish bhai.
Sir, good morning. Nice to see you.
I was there from the start.
Oh, thank you, sir. So kind of you.
No, no. It is a treat to watch you, dear friend.
Thank you, sir. So now coming to the next case, the adenoids. See, adenoidectomy has been, described by various techniques in the past, even with a, adenoid curate or any other things to blindly curate out the adenoids or by mopping the adenoids, by anything has been described. The best technique nowadays, since the endoscope has been introduced, is to remove the adenoid under vision. Patla, bilkul patla.
Sir, how difficult is it to manipulate the endoscope in a child, sir, especially having so much of hypertrophy turbinate as well as deviated septum?
Yes, yes. So most of the time, even this was
Even this
having a
one
hypertrophic
on this side, when you see
turbinate.
on the opposite side when you're putting it,
Yes,
we can see the deviated as well as the hypertrophy.
yes, yes, yes. So sometimes it's a problem, but most of the time after decongestion, you come. Come over all these difficulties. So now, if you have a less space, you can use a 2.7 mm endoscope. You can decongest the nose well for two reasons: to get more space, number one, and number two, to prevent trauma and so on, the bleeding from the traumatized surface. See, this is 2.7 mm. Can you see?
Yes, sir.
Most of the time, we use 4 mm, but in extreme situation, in very, very young children, we have operated adenoids in 1-year-old child as well. Then you need a 2.7 mm. It has less fibers. The vision is not as good as 4 mm. But yes, you can use in difficult situations.
But
See the 2.7 mm.
the question of the delegate is, just in case we are unable to do it, then what is the option?
Then the option is to go from behind using 70 degree.
Okay.
You can take the help that as well. So now with the 4 mm, now see, there's a young child and I am with a 4 mm scope. Most important thing in narrow spaces is to prevent the trauma by the instruments and the endoscope, because these children, if you traumatize the nose, it will invite crusting later on. And
Yes,
you can't expect these children to cooperate in douching and other things. So, most atraumatic technique you have to adopt, you have to be very, very careful while introducing and bringing out the instrument. See now, after the decongestion, how did we decongest? Let me tell you again. We have already done once. It was otherwise, this decongested to the level that we have the coin eyes opened up. It was ultimately blocking otherwise. See this. This is adrenaline soaked gauze from behind, and then we put from front as well, like this. On the surface. And this helps reducing the, congestion and opens up the space and minimizes the bleeding as well. Can you see this?
Yes, sir, we can see.
So you can apply for a couple of seconds and it really works.
This is pure adrenaline?
This is pure adrenaline. And तुमको बोला ना? See now?
Yes, sir.
Now, various techniques have been described to remove these adenoids. We need to understand while doing adenoidectomy the surrounding anatomy. So the anatomy is, the adenoids are lying on the posterior superior surface of the nasopharynx over the muscle, the longissimus capitis muscle, and the separating tissue from the muscle is the perimysium of the muscle, the fascia of the muscle. So when you remove adenoids, you are supposed to preserve the muscle, preventing unnecessary injury to the muscle to give morbidity, and that perimysial plane helps you prevent entry into the muscle. Number one. Now on both sides, what you see is the torus tuberous, the eustachian tube orifices. Laterally, you have to respect the eustachian tube to prevent injury and further pathological problems. And third important thing is, see, this adenoid is not a tumor. This is the lymphoid tissue. This is the lymphoid tissue, Patlol. Lymphoid tissue which hypertrophies in response to allergy and infection. We hear the term recurrence in adenoids. Adenoids cannot recur. See, it's not a tumor. They can again get hypertrophied in response to allergy and infection, and particularly when they are not adequately removed. That's why I mentioned in the beginning, we must treat the ongoing medical problem, the allergy and all that. Number one, simultaneously and post-operatively for long. And number two, adequate clearance of the adenoids. If you leave the tissues behind, too much of tissue, it can come back. So in surgery, the goal is to remove the adenoids completely, at the same time preventing complications to the surrounding structures as well. How is the picture, sir?
Good, sir.
So in order to achieve this surgery, I will, for our convenience, divide into 3 steps. The first step, the fastest one, we'll be using the microdebrider to debulk the adenoid tissue, just to debulk, so that we can, in the second stage, remove the complete adenoids in the plane, perimysial plane. And third is to remove the adenoids from the lateral aspect, wherever they are going, behind the eustachian tube, in the fossa nasal molar, anywhere, to give a complete clearance. So in first step, since we are using microdebrider, not the cobblator, because cobblator unnecessarily gives charring, and that prevents us getting into the right plane. I'll be using microdebrider. That may invite a little bit of the bleeding, which is acceptable, but that helps us to identify the planes all the time. So this step, the negative aspect is a little bit of the bleeding. The proponent of the cobblator may say that we do bloodless, but that is never in the plane. I'll show you how you lose the plane with the cobblator. You can char the perimysium, char the muscle. That is unwanted. So here, see this 60-degree red 60 blade coming from behind. Can you see?
Yeah.
This is sinus surgery blade. And see now, as quickly as possible. This is gross removal. In first phase, I told you we'll just do gross removal, nothing else. And it invites little bit of the bleeding, so we have to go little fast. You have to protect all structures which are not our enemy. We have to remove just adenoids, nothing else. We are not supposed to traumatize the torus. We are not supposed to traumatize the palate. It should be under vision. Your constant irrigation, you can see while my assistant, the constant irrigation that helps you, get the better view. And this is just, first step. What is this? Gross removal. Can you see?
Yes, sir.
Not complete removal.
The scope is held by you.
Yes.
You're holding the scope and the debrider.
Scope and the debrider by me.
Yeah.
My assistant is pouring the saline from one end. The other end is keeping the suction in the oral cavity. See this? See this? What I'm doing now? Pushing this adrenaline pack. See this? Simple.
Yes, sir.
Just for a couple of seconds, not much. Just for the couple of seconds. and then we'll see what we have done in the first phase. So first phase is the first one with debrider with little bit of the oozing, which is acceptable. And then the second phase will start. That will ensure complete removal. Second phase will start with complete removal in the plane, and this debrider with no charring, then only will get into the plane easily. With the cobbletter, had we done with the cobbletter with a lot of charring, identifying the plane is difficult. You can identify, but at the cost of charring the unnecessary structures. See this now? Watch the video. See this now?
Yes, sir.
A lot of people end their surgery here with the adenoids removed and the airway opened up. See this?
Yes.
But that can invite problems further. See now my next step. Using the same 60-degree blade. See now what I am doing. See the mucosa in the oropharynx. Can you see there? Using my adenoid blade tangentially. Can you see this?
Yes, sir.
At a very, very controlled speed, tangentially, to scrap off the adenoid to get into the perimycial plane. Can you see the perimycial plane behind coming up?
Yes, very nice.
This is the mucosa and this is the perimycial plane.
Yes.
And see what above there is? This is all adenoids. See that?
Yeah.
See my blade. This is not rear facing blade. Can you see? Had I been using the adenoid blade, the classical adenoid blade, which is rear facing, I would have traumatized everything behind. See? We condemn using the adenoid blade for the adenoidectomy. Can you see the perimycial plane beautifully?
Yes, sir.
If you are in the right plane, that is a guarantee that no adenoid tissue is left behind. Got my point?
Yes, sir.
Now this perimycium doesn't extend all the way to the skull base. Doesn't extend high up. See, this is the muscle. Can you see the movement of the muscle behind? See, this is muscle. Where the perimycium is.
How did you distinguish the muscle from the perimycium?
No, muscle is behind.
No, I understand.
I'm saying this is the level where the muscle is.
Okay.
You can see the movement. Push, I can push. But see here, what is there? Nothing you can push. There is bone over.
Right.
Occipit.
Right.
What my there? See, there is no muscle behind. And here I can be aggressive enough. Once there is no muscle behind. See this? Higher up, when there is no muscle behind, I can be aggressive enough to take away the adenoids. This is like combing into the depth now. See this? Literally combing. Because now I have no fear of damaging the muscle behind. What is there behind now is the periosteum.
Correct.
And the adenoid, the periosteum is very thick, resilient. It doesn't easily cut by the adenoids. As this blade, you can easily comb. You can comb hard into this region to take away the periosteum. See that?
Yes.
This is hard combing into this. I'm using literally hard into this region. See this combing to take away all adenoid tissues.
This is the place where you are feeling the bone?
Yes, I can feel the bone with my blade. I told you this is hard combing.
Yeah.
See, until here is the muscle.
Yeah.
And from here onwards, this is periosteum.
Okay.
With the bone underneath. See that clearly?
Yes, sir.
Hard combing. Now, I have not used the cobbletter yet. We never use the cobbletter for dissection or anything. We use the cobbletter for hemostasis.
Okay.
At the right time. See now, so far using the cobbletter, debrider and invited little bit of the bleeding, hardly any bleeding. Okay, now I will again, this is my second phase over. I will do hemostasis after this. And this is how my again pack coming into the place. Okay.
Yes, sir.
What we achieved in this second phase?
The complete removal.
Removal in the plane. We could see the perimysium bright without any charring of the perimysium at all. If you spare the perimysium, you can assume your muscle is 100% spared. If you traumatize the muscle, if you char the muscle, the complications are, invited. So, we hear of complication like nasopharyngeal cicatrization, stenosis, even sometimes this muscle, leads to infection, muscle injury leads to infection, inviting abscess and all other things. You can certainly avoid by getting into the muscle, by avoiding charring, straight, all those things. So just apply this for a moment. And now I'm going to remove this. That completes my second phase. And after this, we'll do some hemostasis and then move on to the last phase. So far, purposely didn't use the coabulator to prevent charring. See that? The field is good?
So how much of hemostasis can be achieved just by the pack?
A little bit. Now, see, there was hardly any, significant bleeding.
Hardly any significant bleeding, yes.
Now, coming to your question is again very important. See, as long as you preserve the perimysium, got my point?
Yeah.
No muscle exposed, there is hardly any bleeding from the perimysium site.
Correct.
There are no vessels there. Got my point?
Yeah, correct.
If you happen to injure the perimysium,
only
the
then
muscle
there will
would
be.
keep on bleeding and that will invite a lot of cautery, charring and the so on problems. So avoid perimysium injury is key to prevent problems in the adenoid most of the time. See this, now my coabulator comes. See? Hello?
Yes, we can see it.
I will not use too much of the coabulator on the perimysium because it is not required, it doesn't bleed. See that?
Yes.
Perimysium is very clear, it doesn't bleed. Now, and I don't want to char anywhere on the perimysium too much to avoid, to give charring to the underlying muscle. Where can I use the coabulator? So, what my point is, as long as perimysium is intact, forget about the post-operative bleeding from this region. Got my point? Where can the bleeding come from? The periosteal bed. Can you see there?
Yeah.
And there is no muscle underneath. So what I will do to prevent, ensure to prevent bleeding in the post-op from the periosteum bed, I will completely, coagulate the periosteum thoroughly to prevent post-operative bleeding. This is the point. Whenever you hear of bleeding from the after adenoidectomy, it is always from the periosteum side or from the muscle if you expose. Since we don't expose the muscle with this technique, see this periosteum can be the site of bleeding and we purposely, see this is carpet coagulation, you can say.
Yes, sir.
This is intentional to prevent any post-operative bleeding from the periosteum bed. That is the site of post-operative bleeding in adenoid after adenoid surgery. And the second side is if you have gone into the muscle. Find out. See that? This is called carpet coagulation of the periosteum. So we have achieved two things out of this. Number one, see this perimysial plane and the plane up with no adenoid. Do you see any adenoids in the center anywhere?
No, none.
That is how you can ensure, and the coagulation doubly ensures avoiding a post-operative bleeding. Okay?
Yes, sir.
So this is my second phase over. Still my adenoidectomy is still left. Where? Laterally. See in the center. The
yes,
flushed
beautiful
picture.
Yeah. Very good, beautiful. Yeah.
Absolutely flushed. without injury to the muscle, without injury to the perimysium, without injury to any underlying structure. Using the microdebrider. Suppose, had I been using the cobbler at this point of time, what would happen? I would not see this flushed out perimysium. It would have been charred. And in that situation, it would have charred the underlying muscle as well. There is no control. You can't control the charring then. Here the perimysium, as long as it is intact, now I can say 100% that my muscle is not charred at all. Intact perimysium is a guarantee that your muscle is very, very safe. All those complications are going to happen once the muscle is injured. Agreed?
Yes, sir.
Now the third phase.
The hemostasis you are doing is very, very meticulous.
A very light coagulation. You know? See, no charring of the coagulation, you can see. Now the third phase is calls for little safety. And see, I tell you, see where the adenoids are. See, I'm pressing on the muscle behind. And what you see the bunch of adenoids. Can you see? Can you see all this?
Yes, sir.
All the bunch of adenoids in the fossa of Rosenmuller. Now, the number one, the challenge is to avoid injury to the Eustachian tube. A lot of people are scared of injuring the carotid artery in the fossa Rosenmuller laterally. Carotid artery is far off. It is separated from the nasopharynx by two thick layers of muscle beside the periosteum. And see the movement, what I'm doing. I'm not poking my microdebrider inside under. I'm just pushing it, pressing on the muscle. See this. Gently allowing the tissue to fall in the blade. Not poking the blade inside. Can you see this?
Yes, sir. Seen.
Scraping out little bit of the adenoids from the torus as well. See my blade, I can see my opening of the blade and I am allowing the adenoid to jump inside the blade, not poking the blade indiscriminately inside and giving a possibility of complication. See that? Had you not done this phase, how much of the adenoids you would have left behind? Can you see?
Yes, sir. Very well.
See, my blade protects the underlying tissue itself. Shaft of the blade. That's the beauty of red 60. You can't do this to the adenoid blade. Never use the adenoid blade for adenoidectomy. That's a disaster. Rear facing blade will traumatize everything. See this entire fossa bundle. Entire fossa of Rosenmuller opened up.
Yes, sir. Very.
No adenoids at all. No damage to the Eustachian tube. Nothing. Now what I will do, time being for the hemostasis, and then we'll move to the opposite side for the fossa of Rosenmuller. We'll leave the small pack for a minute and then we use cobbler in case required. See that?
Yes, sir.
Suction. Niche. What's that? See, I left a pack in the fossa of Rosenmuller after complete adenoidectomy from there. Wash. This saline irrigation itself helps in hemostasis.
Yeah, there was a question yesterday in this yesterday's session. What is the theory behind this hemostasis with washing the saline?
The theory is it helps activating the coagulation cascade.
Okay. But then
it washes away the clots. It washes away the clots. If any bleeder behind it opens at the same time, so you can handle it rather than allow it to get unnoticed and opens up later on.
Whether it is warm or it is normal, normal.
Warm is better in certain situations when you are dealing with a cancellous bone with a lot of, you know, venous channels inside. See now the opposite side.
Yes, sir.
See my plane. My blade is protecting behind and see allowing the adenoid to jump inside. I am not poking anywhere. Got my point?
Yes, sir. Yes.
This is a very, very calculated movement. See, adenoid is jumping. Don't worry about any vessel coming and jumping into it. That cannot happen. Don't poke inside and forget about every possible thing in your mind. Can you see the fossa Rosenmuller opened up?
Yes.
Behind, see the fossa Rosenmuller.
Yeah. Yeah.
See, it's selectively the adenoid tissue, the lymphoid tissue which was there, it jumped inside the blade and the entire fossa is opened up. Can you see clearly?
Yeah. Yeah.
You can see the depth of the fossa Rosenmuller from here.
Yes, sir.
Again, we'll leave just this pack for a while, like we did on the opposite side, and that completes my adenoidectomy. The last part, I will show you the final picture after a little bit of this hemostasis, and that will be over. See my both Eustachian and tube orifices, torus absolutely protected. My soft palate absolutely protected. My muscle behind absolutely protected. And a complete adenoidectomy. Probably remove the solution. Now see. Remove this pack. Can you see the fossa Rosenmuller?
Yes, sir.
What I can do, see this. Now the time for the final hemostasis. Gently, without any issue. See this. If you are not injuring the muscle, hemostasis is never a big concern. Problem occurs when you injure the muscle, underlying muscle. And that's, something which invites a lot of people, patient complaint of nasal twang. Why nasal twang after adenoidectomy? Temporary, it can be because you opened up the space, but the persisting nasal twang is because of the muscle scarring. And that is very frustrating. So respect the muscle most. At one end, you have to be radical in terms of adenoid resection. Radical doesn't mean you damage anything. On the other end, you have to prevent every possible complication. So that's a calls for a very calculated, movements every time. Can you see the fossa Rosenmuller this side?
Yes, sir. Very nicely.
Is Dubey sir there in the auditorium?
No, sir, I cannot see him. I'll just trace him out. So there was one question from a delegate, just in case we do not have a coagulator, but we have a microdivider, then what should we do?
Then bipolar, some specialized bipolars which are curved and all that. The coagulator is something unmatchable, believe me. But this tool, see, in one hand, you have irrigation, the most important thing. You have suction to precisely use the coagulator there, to precisely show you the bleeding point. You have a irrigation to, keep the area cool, to prevent collateral thermal damage. So all these qualities you can't get by any other tool than coagulator. But yes, if you don't have, then the coagulator is something which gives many advantages which are otherwise. See the preventing. Had I been using cautery over here, I could have given a lot of thermal trauma to the underlying muscle as well, which you of course never want. See, this is the time to spend 5-10 minutes on the hemostasis part. These are children. I want the smallest bleeding. They are never going to cooperate. The parents become very, very, they can become psycho sometime with the bleeding.
So another delegate question. If we are doing tonsillectomy, should we do this in the same way which the way you have done adenoids? Use the microdebrider followed by coagulator?
Different. Tonsil is a capsule.
Yeah.
Tonsil is different story altogether. Tonsil is a different story. You can't compare with the adenoid because it is a capsule. And what we believe is, tonsillectomy, we use, this gallbladder only for hemostasis, not for any dissection or any cutting or anything. Just for final hemostasis. Otherwise, we believe in dissection tonsillectomy. Because in tonsil, the post-operative slough is a big problem. Like,
Yes, sir.
so in tonsillectomy, you can't take a chance. So before putting I'll just leave a pack for a while. Now, additionally, just in case required, let me show you something. To be, doubly sure that you don't give any bleeding anywhere laterally, particularly laterally, central part you see very well. What you can see, you you can put a layer of Surgicel in the fossa of Rosenmuller. Layer of Surgicel to prevent any possibility of bleeding in the post-op period. See this?
Yes, sir.
That is only in the fossa of Rosenmuller laterally, doesn't get dislodged. Section. This you can leave. As a layer to be, doubly sure that you don't give any bleeding in case you have. Wait for 10 minutes for any bleeder to open up. Even the slightest of the bleeding, we are not going to leave. Because these are, after all, children. So this phase spend 10 minutes on the final hemostasis. The best way is to push a layer of, just for the peace of mind. Touch peace. Just leaving this pack for a minute to keep the surgical pressed. Same thing on the opposite side. This is just to add on to the peace of mind, Surgical is sufficient. and suction niche. And now is the final inspection. नीचे नीचे की तरफ कर. हमेशा नीचे रखो. नीचे कर. Yes. See the final hemostasis, final picture.
Beautiful, sir.
Before we come out, I'm just irrigating the surgery cell even. It works very well. This is just an extra, maneuver to add on to the peace of mind. No bleeding, not even a capillary bleeding you can see.
Actually.
That's all about this adenoid. Thank you.
Thank you so much, sir.
Thank you very much for your patience. We can take questions anytime. Hello.
Yes.
So, hello, camera. वो switch off कर दे. वो disconnect करो. So now moving on to the next case. Hello.
Yes, sir.
Moving on to the next case, and that is a endoscopic sinus surgery, and we'll be demonstrating the navigation system as well, as we had, request to use the navigation, show something about the navigation. Though we generally, don't need navigation for every case, but this particular case we are using to show you. Can you connect to the laptop? So, any question or do we go ahead?
No, sir, I think we can go ahead.
Okay. So the situation is patient having bilateral pansinusitis who had been under medical treatment for long in spite of many courses of steroids, antibiotics and everything. And I'll show you the picture, and the diagnosis is established endoscopically, reinforced by the radiology. And this is a steroid dependent disease, we all know. And the goal of surgery nowadays is two-pronged: to reduce this, remove this inflammatory load what patient is having, requiring steroids to control the symptoms, and at the same time giving opportunity for the topical steroids to penetrate inside the sinuses for future to avoid the need of oral steroids. That can happen if you do a complete good full house fast for this particular situation. So the situation is clear, and we have a CT scan, and let me tell you what CT scan we have. What CT scan we have is a 0.6 mm coronal section CT scan. Can you see? And with our software, because CT is I would say the Google map for the sinuses, for the anatomy of the three-dimensional anatomy of the sinuses. It is like a Google map. So the CT scan, now see, in the three planes reconstructed with the software, gives you every fine details of the entire paranasal sinus labyrinth in 0.6 mm slices. So every time when we move by 0.6 mm in all planes. See that? So that is so, fine sections we can reconstruct it. So the CT is shot in the axial plane, and then you have to reconstruct. So now, by and large, what we see on CT scan, complete whiteout. Can you see?
Yes.
Complete whiteout. So when you send this to the radiologist for scanning, the report is very simple. The opacity is involving all paranasal sinuses bilaterally, suggestive of pen sinusitis in one line. They have nothing to do with giving anatomical details. And this is why we get the CT scan done, to get more and more anatomical details, three-dimensional details, and relationship with the surroundings. The aim of CT scan is not to establish a diagnosis only. The main aim is for surgical planning, to get anatomical details, to prevent complication, to see the surrounding structure, relationship with the critical structures, all that. And for that, you have to look at the CT yourself. You have to, learn how to read the CT scan in different planes, and every plane of the CT scan gives some useful information. There are certain areas where the axial plane gives more useful information than other planes. There are certain areas where the sagittal plane is useful, like mostly for the frontal and the skull base. And most of the time, since we operate in the same plane, this coronal plane gives us anatomy in the plane which we operate. So we can easily get used to understanding the coronal plane well, and it gives most of the information as well. So, and with this three-dimensional, anatomy through this software, you can learn anatomy much better. Like, for example, if you see something on the coronal plane and want to learn how to read on the axial plane, you can easily read by means of bringing your cursor onto it. See this. Let me show you. If you see in coronal plane like this, what is this? Anybody? This is onod cell.
Onodi. Yeah.
Now you can see onod in the coronal plane inside the sphenoid as a horizontal septa. This is the sphenoid, and this is one of the cell of the postsphenoid over and above the sphenoid, going behind. And this optic nerve here is the optic nerve coming in relationship to the onod cell rather than the sphenoid itself. You can make out in coronal. Now how it looks like in the axial and sagittal, see this. You can make out this cell, the ethmoidal cell. This is the sphenoid sinus. This cell, the postsphenoid, is not ending at the anterior edge of the sphenoid.
Correct.
Postsphenoid is growing over and above the sphenoid all the way. And that's how the optic nerve has come in relationship with this cell rather than the sphenoid. We should know this fact during surgery to avoid a disaster. Same thing, you can know better on the axial section. See this, my cursor is on the onod cell. What I want to show is, see this. See, this is the onod cell, and see where is my optic now. See my optic now there?
Yes, sir.
This is in relationship to the onod cell. This is onod, not the sphenoid. And the interface of the optic nerve to the onod is best visible on
Axial.
axial. So, by reading the CT scan in all planes on this software, improves your anatomical orientation about every structure three-dimensionally, and you have to sit together always with the scan for hours and hours to learn this art. And that can, believe me, improve your surgical course much better. See this? This was onod, and this is the optic now. Let me bring on the optic now right over there. See the optic now in axial. There is the optic now, and this is in relationship with the onod. There is the bone is still intact. Can you see?
Yes, sir.
Sometimes the bone is dehiscent. See the optic now here in the relationship with the onod. So see all structures 3D with the software in all planes. It gives you complete information. See, in one plane, it was shot in axial, and 185 slices were, taken. Now 185 in axial, 185 in coronal and sagittal. Around more than 550 slides, patient cannot carry in printouts, and that too you cannot run dynamically. So most or the complete information you can get only on digital format, only on DICOM only on your DVD or pen drive, that you must ask patient rather than getting a printout. Always write fine section in a DVD and then you reconstruct to get complete information. More
Is the
than that,
relation of the internal carotid with the ONOD?
yeah, internal carotid is below, ONOD is above. See this on axial plane. See this internal carotids, petrous carotid. This is the foramen lacerum carotid. See the bone intact. Can you see?
Yes, sir.
And this is the cavernous carotid with all sides bone intact. So this gives you information that the carotid is not dissect. See, you can see dynamically so well. So the bottom line is to acquire this on digital format. Ask the patient always to bring on digital format. And then you can change the window settings, soft tissue window. You can ask for the bony window, soft tissue windows, different windows on this format. This is soft tissue window. See what is soft tissue window? You can see surrounding soft tissues much better now. Can you see? All the muscles and everything. Let me reconstruct. See this soft tissue window? You can see the details of the structure inside the orbit much better than the previous bone window setting. So
A question with not relevant to this case. What about the pituitary adenoma? Can we identify in this plane, in this soft tissue window?
yes, you can identify something abnormal, something enlarging, something like adenoma, but you can't differentiate into the soft tissue because this requires a lot of sequences from MRI.
Right, sir.
So you can have an idea, but that is not the investigation of choice. See, this is the sella. What will you find in a macroadenoma? You will find the sella is enlarged. There's something ballooning, but this could be anything else. By means of MRI, you can differentiate exactly whether it is pituitary adenoma, it is not craniopharyngioma, it is not chordoma. There could be lot many pathologies there. And with the signal intensity differences on various sequences, you can identify on MRI very clearly. On MRI, you can almost always differentiate from adenomas to chordomas to craniopharyngiomas. Every pathology has a distinct characteristic features of MRI on different sequences, but the CT cannot. So this is soft tissue window, this is bone window. Now, about getting the details of the paranasal sinuses of this particular patient, let me quickly take you. I'm not going into the fine details of the CT scan. You can see our previous videos on YouTube. But yes, some positive findings. Coming from anterior to posterior frontal bone, frontal sinuses, intersinus septum, this is beak, the frontonasal process going behind. See this, this is the intersinus septal cell. Can you see far anteriorly? How it is opening? See, it is opening into the right frontal sinus. Can you see?
Yes, yes.
See, this is intersinus septal cell. Let me take in all planes. See this. You can see everywhere the intersinus septal cell. Now you see how it is opening. This is opening in the right frontal sinus. See, the left intersinus septum is different. So, going behind, now some cells are appearing in the frontal sinus. This is important peculiar finding which I wanted to share with you for this particular patient. See this frontal sinus hardly had any cells before. Can you see?
Yes, sir.
When we were coming from anterior to posterior, all the way there were no cells. Now, as we go far posteriorly, still now no cells. See this? As we go far posteriorly, some cells are appearing. Can you see?
Yes, yes.
What is this? We know there are number of cells described in relationship to the frontal sinus. Commonly, Aganese cell, frontal cells, Kuhn cells, type 1, 2, 3, 4. But those are attached to the anterior wall. Far anterior cells may be projecting into the frontal sinus like described as type 3 and type 4 cells. This is not anterior cells. See this? Anteriorly, all frontal sinus is clear. Can you see?
Yeah.
Cells appearing posteriorly where the frontal recess is starting. See this? When the frontal beak has gone, frontal sinus started, and that is the cell. See this cell ascending into the frontal sinus. So what is this? frontobular cells. Got my point or not?
Yeah.
These are two different group of cells altogether. See on the sagittal plane. This cell, which is a frontobular cell far behind, see this, into the frontal recess, and it has narrowed the frontal sinus outflow. Can you see?
Yes.
This cell has narrowed the frontal sinus outflow as compared to the opposite side. And this cell is a frontobular cell, and you can see on the sagittal as well. See this cell. And see, if you see this particular cell in the sagittal, now see, this is the cell which is attached behind. See this? It is not the anterior cell. See, this is the frontobular cell. It is not the anterior cell. Type 3 or type 4 cell would have attached over here anteriorly. What's my point?
Yes, sir.
Anteriorly only this small organage, and see posteriorly this is frontobular cell. Can everybody see this? Very
Yes, sir,
clear.
yes.
This cell is
Yeah.
attached to the posterior wall. If you try to, what is the difference? Why it is so important? Because if it is type 1 to 4 cone cell, which is attached to the anterior wall, you are supposed to go behind the cell and fracture it out.
Correct.
But this cell, in contrast to that, is attached behind. If you try to go behind the cell, it would be a disaster, as it would breach the skull base. So, this anatomy clearly differentiates how you have to tackle this cell. Otherwise, it can be a disaster if you don't have this anatomical information. So this is frontobular cell. We'll deal it differently. We'll show you as we deal with the frontal sinus how it is attached there, not to the anterior wall, and how it is handled to widen the frontal outflow. Okay. Then see, as we go behind, this is a frontal sinus. As we go behind, as the beak goes, then the frontal recess starts. Everything white out. There's the bulla. See, even the turbinates are white out. Can you see?
Yeah.
No aeration. There's something like cells in the turbinate concha bullosa, most likely, and complete whiteout. The maxillary sinus. This is see in the maxillary sinus. What is this? This is the infraorbital nerve ballooning down. See, as compared to the opposite side, that's the infraorbital nerve on this side. This is ballooning down. Some DNS as well. This is the cribriform olfactory fossa. Not very deep. You can say grade 2. And then as you go behind, that is the, let me go behind. That is the ground lamella, everything white out. That's the ground lamella coming into the picture. That's the ground lamella now inserting onto the lateral wall. And then the posterior cells start. Then the skull base, has become thick. For more details of the understanding, reading the CT scan, you can refer to YouTube videos, the previous ones. And then the sphenoid starts, and both sides onodi situation. See this horizontal septation. Above cells are onodi on both sides. So to prevent injury to the NOD, first of all, you should know that, so that you stay careful and stay in the medial aspect, not to go laterally to injure, optic nerve, assuming it is a sphenoid sinus. So stay medial. You're always away from the NOD. So these are the basic, information about this patient. So we'll show the endoscopic sinus surgery in this particular patient. This will require septal correction as well, some turbinate correction. We'll show at least on one side, and then our next case would be the lined up cases like tympanoplasty, thyroid, and angiofibroma, and cholesteatoma as well. Any questions before we go ahead?
No, I don't think so. We can go ahead, sir.
Okay, so in a couple of minutes, we'll be back with the endoscopic picture now. कौन सा? ये रहा ना? नहीं, उसको बुलाओ, इसको कैसे दिखाएगा? हेलो हेलो हेलो.
Yes, yes.
यस सर.
जी.
So, are you getting endoscopic picture?
Yes, sir, we are.
Hello.
Ji, sir, we can
Are
see,
you
sir.
getting endoscopic
Yes,
picture?
yes, we are.
Okay, sir. So this is the primary picture. I am showing the side with the frontobular cell. You can see this, the division of the nasal septum, the spur there.
Yeah,
Rest of the septum is good.
yeah.
So I am showing the left side, the side with the frontobular cell, and what you see is this all polypoidal tissue. See this polyps? And what we have given, this decongestion is simple, the saline adrenaline with the marrow cell, no infiltration given. We never infiltrate. While doing sinus surgery, you can achieve the same field with a marrow cell and keeping the heart rate towards lower side to reduce the cardiac output. That's it. These are the two maneuvers besides pre-operative preparation of, antibiotic and steroids in such cases. The strategy is to overall reduce the inflammation. See the polyps I am removing coming out of the middle meatus. You have seen once there are polyps, the anatomy is always distorted. See, this is your middle turbinate. What you see here is the uncinate, which is, see, this is polyp of you in the middle meatus. Could you see the middle meatus opening up now? Hello?
Sorry, sir?
Can you see the middle meatus opening up?
Yes, sir.
We saw the turbinate swollen, opacified, complete turbinate opacified, looks like a concha opacified. And see how the turbinate is so swollen up. See this?
Yeah.
So, and see the cell inside the turbinate. See the cell. Can you see the cell? That is the concha bullosa. See, I have opened up the concha. Can you see the cell?
Yes, yes, sir.
That was the cell in the turbinate. See the lining of the cell inside the turbinate. So this turbinate itself was blocking the middle meatus, adding on to the problem further by means of mechanically obstructing the ventilation and drainage. So this is initial, debridement of the polyps, dealing with the turbinate to improve your identification of the landmarks. Now we can identify the landmarks, certain landmarks much better. See, that is your uncinate process. Can you see?
Yes, sir.
The only mobile structure in the entire lateral wall is the uncinate. With polyps, it can get distorted, but still you can pick up by this way. The patient with a pansinusitis, steroid-dependent disease, our goal is to do a full house fast and we'll make sure that our topical steroid solution reaches later on efficiently, and this turbinate sometimes becomes the obstacles, and we'll do some sort of turbinoplasty to this concha also, that it should not fall back laterally to create problems further. So we'll do a partial sort of turbinate resection in this particular case. See this turbinate. This is going to create problems. See this? This is flappy because there was a cell inside. Could you see?
Yes, yes.
So good. So what we'll do, we'll do a sort of anterior wedge resection of this floppy turbinate. See, this is never going to be stabilized otherwise. But I will not remove anything of the upper part. See the purulent disc. See
Yeah,
what is
yeah.
there inside the turbinate.
Yes.
That is what I mentioned on CT scan. The turbinate is full of opacity. See the purulent discharge. That's why this turbinate needed this answer. See now,
Correct.
if we miss this, we would not be able to clear this. And this was the remedy required, but I kept the upper end for identification. This is important. The turbinate is a great landmark. We should not chop it off completely. So I preserve the landmark. In this case, I tell you, we have been using navigation system for almost 15 years. That is Medtronic. And today here for the demonstration, we have another state of the art navigation system with us. That is from Stryker. So scope is from Stryker, and it has some added feature which we will show you. They have already registered. Navigation is useful, all the time to improve your anatomical orientation. That's it. The role of navigation, that will tell you where exactly you want whenever you want to see. And the beauty of this navigation is it can tell you all the time where exactly you are working. And with this particular system, they have a universal adapter by means of which you can navigate any instrument, even my micro debrider being navigated. See, this adapter is attached to the micro debrider. See here.
Yes, sir.
Hello. So even
Yes,
the
yes.
micro debrider can be navigated. So wherever I am using my micro debrider, can you show me the external camera into the PIP? See, my this thing will always tell you where exactly I am by means of चला गया तुम उसको तो पकड़ के रखो यार See, can you see the navigation screen? Hello in PIP?
Yes, yes, sir.
See my debrider is on the septum, you can see in all planes. The cross hatches in all planes on the septum.
Yeah,
If I am going on to the turbinate here, see this cross hatches going to the turbinate. So you
correct.
can navigate every instrument with this universal adapter. That's the beauty from this striker system. That's what I wanted to price. So whenever the need arises, we can take the help that to know where we are. When you go to the frontal, you can orient yourself. Yes, you are going to the frontal. So navigation actually helps you orient much better. This is not substitute. This system has an accuracy of less than a millimeter, but still rely on your own anatomical knowledge. Take the help of navigation in a difficult situation like revision case, multiple revision, all anatomy distorted, close proximity to the vital section. Then you can take the help of navigation, not always. And in our practice, we need navigation once in a while, not always. हल्का वॉश वो धार बनाते हुए. See this? After the initial clearance, handling of the middle turbinate, and now you see the space in the middle meatus. Can you?
Yes, sir.
See, this turbinate was full of purulent secretions and the polypoidal mucosa, which we, did a partial resection, and now the picture is clear in front of you. Okay?
Yes, yes, sir.
Feel free to interrupt me, sir, any point of time you feel like, for any query or suggestions. Now, my sinus surgery starts like as usual with this uncinectomy. See this uncinect process?
Yes, sir.
Only mobile structure. It is the upper part, lower part, upper part. You have to be careful on CT scan if it is going to the skull base. Not in this case. Now I'm using the reverse biting, turn little inferiorly to avoid biting through the nasolacrimal, to stay away from it. And with every bite you progress, take a feel of hard structure if it is taking the nasolacrimal duct. You have seen many a times in our dankers how nasolacrimal duct is in close proximity, just anterior to the uncinate. See this? I have fractured the lower part of the uncinate and see what is pouring out. Purulence. See this?
Yes, sir.
That is opened up. We are grateful to
Sir,
Dr.
which blade are you using at present?
Pardon, sir, this is 40.
Oh, grad 40.
Yeah, depending upon the need of oral topical steroid going inside, if you feel according to the G's load, you can widen the antrostomy to allow more and more steroid going post-operatively. The beauty of the micro debrider is it cuts very sharp rather than pulling anything or peeling of the mucosa. Number one. Number two, but the only thing is you have to keep all the cutting edges all the time in view. All the time in view. Like this. See, this is wide middle meatal antrostomy. Our constant irrigation going on. We didn't inject anything, only topical, this thing. And we have a, I can say, pretty good field as far as the visualization is concerned, which is very, very important in endoscopic surgery. One of the most important factors in preventing complications. This surgery has a low threshold of safety. The vital structures are allowed around in the millimeter distance, the orbit, skull base, carotid artery, optic nerve. The safety concern is very, very important. And this good surgical field is one of the most important factors in adding on to the safety of this surgery in terms of identifying the, the landmarks. So this is one step done. That is, see this, every time you mop with the, marrow cell, your field improves. That is marrow cell mopping. See now, this is upper part of the uncinate. This is a standard teaching. I remember times from Dr. Dharamveer Sethi, who we all know him, who has revolutionized the science of endoscopic sinus surgery in our country by his number of workshops earlier, decades ago, I would say, from 2000 to till 2000, in the middle of the 2020s. He did all over the world and many in our country especially. And this, following many of his concepts, see now, taking away the upper part of the uncinate. This, I would say, is a very, very useful step. See this? First, I fractured with my curate. Could you see?
Yes, sir.
And then I'm taking away with the micro debrider. Why? This part, once you remove this upper part of the uncinate, you come directly onto the medial wall of the orbit.
Correct.
Closest to the medial wall, and this is where your this trajectory starts. Your limits of the endoscopic sinus surgery, the lateral limit starts coming into your view. That is very, very important. That's the, the agar cell. See, that's the medial wall of the orbit there. And below this is the bulla ethmodalis. That's the agar. See, every landmark you have to see properly. Now, this is your turbinate. See, my turbinate is such an important landmark. As long as I don't cross it medially, I generally stay away from the skull base. And now see, this is the wall of the agar cell. This is agar cell. This is orbit. This is bulla. This is middle turbinate. And see, If I go medial to the medial wall of the agar, that is going to take me to the frontal recess. See this one. Medial to the agar, this agar cell goes upwards and insert laterally onto the lamina to give up this space. And that's the, entry to the frontal recess. Depending upon the anatomy of the agar, you get challenges to enter into the frontal. So you must know how to, must know from the CT scan about the details of the agarnegi to improve your surgical course. So one of the standard teachings of Dr. Sethi was to keep the bulla intact and enter into the frontal sinus to add on to your, orientation. As long as the bulla remains intact, you protect the anterethmoidal artery as well. You know your anterior posterior dimension where you are going anterior to it and you can use a 70-degree up anterior to the bulla to enter into the frontal sinus. So it adds on to the box-like configuration of the area where you are working. So that's a very important concept we have always been following. Again, after every step, apply the Merocell. See, after every step, keep improving your field rather than operating in the bloody field, which can spoil your orientation and can end up in complications. Now, having done this, we'll change to 70-degree. This is the time now to change to 70-degree to see up. See now. Now with the 70 degrees, see this hemostasis, you get a more, better way to, identify the area. That is the agar cell. And that is where now we have to go. See the medially turbinate. This is turbinate medially. You're not supposed to. This is the agar cell. That's the medial wall of the agar. And we are going to go behind the agar. We'll fracture it out, anteriorly to get into the frontal outflow. Give me the divider. Just a minute. That's the septation which I want to remove. Yes. Now, see my area is very clear. 120%. See this area we have to go. I just fracture the agar. That is, see this?
Yes, sir. Yes, sir.
And I am going up and medial to it. My anatomy was very clear from the, CT where I am going to. And see, that is the space where I am entering into the frontal. I can see the glimpse of the frontal sinus now. What I maintained in the visualization, see the beauty of 70. It is keeping my both medial and lateral wall in view. See now, how in spite of using the divider, how I ensure the safety. Number one, my lateral wall is in view. If I keep with the 70-degree lateral wall in view all the way, I'm not supposed to cross this limit to enter into the orbit. Similarly, this is my turbinate. See this? All the time keeping the turbinate in view so that I don't cross it medially to give a disaster to enter into the skull base. Similarly, anteriorly is my beak. See this beak?
Yes, sir.
We all know as long as you follow the beak, see this beak?
Yeah.
This beak, this beak ends behind to enter into the frontal. So the beak is a very, very important landmark. See this? See the beak?
Yes, sir.
And how we are entering into the frontal behind the beak. And the fourth important safety we have already kept is this bulla. See this bulla. As long as you remain anterior to the bulla, your anterethmoidal artery remains far behind because your anterethmoidal artery traverses the roof of the skull base in the posterior part of the anterethmoid cavity, anterethmoidal roof, posterior part of the anterethmoidal roof, not anteriorly. with the 70-degree with trajectory going anteriorly, you are automatically leaving the anterothoidal artery behind. And further adding on to it, you are keeping the bulla intact. So by all means, we are adding the safety to it. Now see, we know this bulla and the bullar cell has been the concern in this patient. Give 120. See, now we'll stay anteriorly close to the beak. Let me show you. Once we remove this bulla completely going high up, you will see the widened frontal. Now see, again, I am going close to the beak, absolutely close, just flush to the beak, to show you the glimpse of the frontal. So simple. Beak is one of the best landmark. If you go immediately behind the beak, between your medial and lateral limit, you can't go anywhere but in the frontal. Now see, can you see my frontal there?
Yes, yes,
there.
sir. Yeah, yeah.
What this cell is obstructing the full outflow of the frontal. This cell, see this cell on the posterior wall. This is the bulla which has gone up. Can you see this?
Yes, yes,
So
sir.
high
Yes.
up. And that is what the frontobular cell, that's why I purposely kept this case. We have shown many a time type 3, type 4 frontal cell. And this was adding on to the variety, the frontobular cell. See this? This cell arching so high up. Arching so high up means, let me show you again. Don't forget this anatomy. See this cell which has gone above. See this cell? If I fracture this cell out, my frontal will open up much better. See this? You have to fracture this cell out. See this?
Yes, yes, sir.
You have to fracture this cell out. Give me same. See, let me show you a little bit of the fracture. Just to show you. I don't want to do at this step this thing. See, I just fractured and trying to remove and see how it widens the frontal further. Can you see the frontal opening now?
Yes, sir.
Much better?
Yeah.
So this cell, see this cell is still there on the posterior wall. Can you see?
Yes, yes.
So that is frontobular. Don't get confused with the type 3 and 4 and the frontal cells. Frontal bular cells are posterior cells. See, still the posterior wall is there. That is the posterior wall. Can you see?
Yes, sir.
That is the wall of the frontobular cell. And see, the frontal is above. What an amazing anatomy it is. So let me show you much better this after removal of this bulla. Frontobular cell, why I am purposely showing, but people should not confuse or should not be mistaken with a type 3 cell, otherwise can lead to a disaster if you try to go behind that cell. That is a posterior cell. You are not supposed to go behind that. My frontal is very nicely visible now. See there, but I have to widen it by means of removing this posterior cell completely. See this cell wall. And see now how will I remove this. So this surgery again I dedicate to our teacher, Dr. Dharamveer Sethi. See now this is bulla. Hello?
Yes, sir. Yes, sir.
Now I am going behind the bulla. See what exactly is there. See this behind the bulla. Why I am calling this cell as a posterior cell. Okay. See this, I have broken this cell. Let me remove the bone particle and then I will debride. See carefully what I am trying to say. Yes, give me the debrider. This bulla is attached to the orbit laterally.
Yeah.
So be careful while removing the bulla. Our every instrument is being navigated there. See, this is bulla. See this. Be careful to flush it laterally with the orbit. See that orbital medial wall?
Yes, sir.
That's the medial wall of the orbit where I am flushing off. And see, this is the posterior cell. Let me show you better. That's the posterior cell I am lifting. See, behind it, the skull base. See?
Yes, sir. Yes,
See
yes.
that this is skull base. What I'm this cell. See carefully. See carefully what I'm lifting is this posterior cell. See carefully this cell wall.
Yes, sir.
This is the frontobular cell wall. This one. See this cell wall, I am completely lifting off and see that is the skull base wall. Can you see the skull base now?
Yes, sir.
Giraffe. And see the frontal and the skull base. And see this part of the cell wall, fractured wall. Side wall is push laterally, which I am removing. Yes. This cell wall. Can you see this?
Yes, sir. Yes, sir.
Debrider. 120, 120. And now I will complete this, removal of this cell and see then the widest possible frontal opening could have been given to this patient. You can already see the frontal sinus. So frontobular cell is an amazing anatomy. See, everywhere preserve the mucosa. If you don't preserve the mucosa, inviting problems. So I'm just removing the last part of the, that cell wall, mucosa. To finish that part in the frontal. See that? Just before that, I'll remove the, and this is to further.
So this is 120 rad?
Yes, is 120, definitely. That allows you to go right into the depth. See where I'm working. I want to remove this last piece of the cell wall. Yeah, it has come out. See that?
Yes, sir.
And see how this frontal is opened up so widely. Wash. See that some secretions behind, and see that is going to be flushed out. Yeah, out. Let's see. I think. So this was a very, very interesting anatomy of. See now the secretions flushed out, and now see the size of the frontal. See the last bit of the cell uncovered. Can you see?
Yes, yes. Very nice.
High up with a 70 degree And this requires this kind of a work. Believe me, if you don't uncover this cell, can give persistent problems. See now, that is the complete widest opening to the frontal. This is the shallow supraorbital cell behind. This is the shallow supraorbital cell behind. This one. See, this is orbit. This cell is going above the orbit. And this is important anatomy. The anterothyroidal artery is always behind the supraorbital cell, behind here. See, my bulla was covering right up to there. It's self-protecting the anterothyroidal artery. Could you see?
Yes, yes, sir.
And now see the widest possible frontal sinus in this particular patient. The frontobular cell was the key giving problem, and we could completely removed, preserving all mucosa from there. And this is now your anterothyroidal artery just behind the this cell. This is supraorbital cell, this one, the lower one, and behind that is the anterothyroidal artery. Give me reverse. Let me clear it for you using a so-called adenoid blade, which I just said condemn to use for adenoid. This is skull-based blade. See now, with the 70-degree, it becomes a front face. Can you see?
Yes, sir.
We call it a skull-based blade. And see now, when I made this mucosa, that is the site for anterothyroidal artery. Such a safe blade with a 70-degree, where your all cutting edges are in front of you now. The reverse blade has become the front-facing blade. See this cutting edges. See now the skull base is coming into picture much better. That is the area of the anterothyroidal artery there, here. See that?
Yes, sir.
And once you see the anterothyroidal artery, immediately behind there starts the posthyroidal roof. And this is now, see my job with the 70-degree ends. See my medial limit like a box again. See my medial limit, the turbinate, lateral limit orbit, anterior limit beak, and behind is the skull base. And we use until we uncover the skull base, bulla is our posterior limit to cover the anterothyroidal artery, preventing any damage. It is as simple as that. Now, having done this, I will change to 0-degree back. Never leave any free lying bone or uncovered bone, otherwise the crusting is big problem. It doesn't, it can get necrose as well. Now coming back with the 0-degree, see with the 0-degree or frontal sinus skull base work. See the anterothyroidal artery there behind up.
Yeah.
Can you see the glimpse?
Yes, yes.
Now what is this? We have removed the bulla. This is part of the ground lamella now. Now we are going to finish this side very quickly. The next case is ready. क्या है next? क्या स्टेटस है? खुल गया क्या? रुक जाएगा. See now. Give me the back. See, we have done the maxillary, frontal, anterothyroidal roof work and the treatment of the turbinate as well. See now, after, dealing with the concha, how the turbinate is behaving so well. Can you see?
Yes, sir.
That is important to keep this turbinate along the septum, otherwise it can lead to problem. Now, straight. This is your remnant of the bular shelf of the bulla,
Yeah.
and this is your ground lamella now. The bulla is bigger; it can push the ground lamella behind, and see this wall, the medial orbital angle. Give you the idea of the orbital floor. Can you see that?
Yes, sir.
Roof of the maxilla. That's a very important line, maxillary line. We'll keep in mind when we go behind. To go further, what we are left with, the postsigmoid and sphenoid work. I told you the postsigmoid is not limited to the sphenoid sinus anterior wall. It has gone beyond. We have a ONOD situation. This part of the turbinate, again, it is a boggy, the concha. For part we have already dealt with. See this? The mucosa inside, all disease inside. See this?
Yes.
Turbinate was a big problem in this patient. Now, having done, we have to move into the postsigmoid, and then we have to see at the level of the maxillary line. I am entering into the ground lamella. See this?
Yes, sir.
This is just entry into the ground lamella, which I am little widening. I am not doing any postsigmoidal work until I know where my sphenoid ostium is, because I don't want to go blindly behind. I can hit, this is ONOD cell. I can hit my optic nerve if I don't stay careful here. So this is the time to stay very, very careful and see what I'm taking. This is my superior turbinate. Can you see this?
Yes, sir.
Go behind the superior turbinate. See this? I am taking a lowermost part of the superior turbinate as well. See the turbinate as a cell. Now at the level of the maxillary line, see this maxillary line, roof of maxilla or floor of orbit. Here, along the septum, very, very close to the septum. See this? I am in. Can you see this?
Yes, yes, sir.
This is my sphenoid. This is my sphenoid. Let me widen it a little bit. Just for your orientation, I didn't do postsigmoid first. I am seeking for the sphenoid sinus by going medially to stay in the medial trajectory. The reason is the fear of ONOD, fear of optic nerve. Now, in any given situation, see the sphenoid sinus pushed medially and the ONOD is going far laterally. In any given situation, even if you are going in the ONOD cell, your optic nerve is never going to come far anterior to the level of the sphenoid sinus ostium. Now I can finish my postsigmoidectomy remaining until the sphenoid ostium, not behind that. So my landmark is, for my safety, is the sphenoid ostium. Until the sphenoid ostium, I can go behind until the sphenoid ostium without any fear of optic nerve. This is the cell in the upper part of the turbinate. See again, I am uncovering. This is one of the postsigmoidal cell, flushing the skull base. See this again. This is another postsigmoidal cell. I have flushed here. And see the skull base behind. All skull base. So in next couple of minutes, I'll be through. What I want to show is this sphenoid ostium is a vital landmark. Believe me. The reason is very obvious. As long as in the anteroposterior plane, you work anything onto till the sphenoid ostium, you are 100% safe from the optic nerve. You can damage laterally the optic nerve only when you cross the level of the sphenoid ostium and go laterally behind. So now, keeping the sphenoid ostium, I will work laterally this remaining part of the post-sigmoid without any fear of damaging the optic nerve. As long as I work till the sphenoid ostium, I am pretty safe. Now see the disease, fungus. See that?
Yes, sir.
Can you see behind what is the structure? Let me show you. Can you see there? What is that?
Optic.
Yes. And what is there anterior to this? The best landmark for the post-sigmoidal artery is optic nerve, and see the post-sigmoidal artery up. Few millimeters anterior to it. See that post-sigmoidal artery?
Yes, sir. Yes, sir.
This one.
Yeah, yeah.
And the landmark is optic nerve because optic nerve is almost always visible, and post-sigmoidal artery is few millimeters anterior to it. See, this is how your post-sigmoidal skull base is flushed. This is your anterior-sigmoidal, this is your post-sigmoidal. And then behind is the optic nerve. And see, as long as I am till the level of the ostium, my optic nerve is behind. Can you see?
Yes, sir.
So as long as I am till the level of the ostium, there's a classical example. You can see yourself with your own eyes. Why I am saying so? Your optic nerve is pretty safe. Now I am opening, widening this NOD. See the NOD cell completely opened up.
So there is one question. What is the superior limit for the posterior ethmoid dissection?
Superior limit is skull base all the way. See the skull base coming. Every area, every possible millimeter of the area mucosa lies. See everywhere.
Yes. The
This
NOD
is
cell,
the
the roof is.
key. This is the key for a good, successful sinus surgery to keep the mucosa intact. If you bare the bone, removing every mucosa, it is going to invite a lot of crusting. It is not going to be functional, and then it is not going to be FES, not going to be functional endoscopic sinus surgery. It is going to be a total mess. So never ever remove the mucosa. See, and that is the debrider. It is not pulling out any mucosa. It cuts sharp. Now finally, widening the sphenoid. That's the last part of my surgery. I have come. Rest of the thing you have seen. We are through. How to widen? Let me widen it first laterally until the lateral wall. At the ostium level, not inside. I am not running any debrider inside. Be careful while using micro debrider or any sharp instrument. Inside. See, I have flushed laterally to the lateral wall. Now, this septa I will take with a through biting. That's it, to widen the sphenoid. See, this is the sphenoid, and optic nerve is running in the lateral wall of the ethmoidal cell, that is NOD cell, not in the sphenoid. And how did we know before? By CT scan. CT told us, I showed you again and again. The optic nerve is not running in the sphenoid. Be careful. The sphenoid, the NOD is above. See the mucosa. Can you see? Everywhere mucosa lies. See that everywhere, no bleeding. See the stump of the middle turbinate above.
Yeah.
Identification. It is not going to fall laterally. Everywhere it is mucosa lies. See every of it. See everywhere. So this will invite minimal crusting. And this is my, sinus surgery done on this side. We are not demonstrating on the other side to move on to the other case. And see how it is. Full view. In your OPD, you just see with a 0 degree and everything in front of you. Just train the patient to irrigate in proper position to allow the topical steroid to penetrate deep into the sinus. That's the only thing required. That's the endoscopic sinus surgery of this patient. Any questions, any suggestions, any comments? Opposite side. Opposite. Sure. And thanks to the Striker team for this wonderful navigation system today for the demonstration. The beauty was every instrument was being navigated all the time. Thank you. Camera change kar de.
It was a nice demonstration of removal of the frontal bular cell.
Thank you, sir.
Very well done, sir.
Thank you. And now we move on to the other cases. We have a mastoid tympanoplasty. We may not get time. We have thyroid and we have the angiofibroma. वो कर दिया?
Okay.
Not laptop. Wait a minute. Hello. Hello. You. Hi.
Yes.
Ajaypal. So before we move on, any questions or do we go ahead with the next case?
What is the next case, sir?
Next case is a cholesteatoma, most likely. And we have many a time demonstrated, discussed pros and cons about choosing the right technique, interiorization, exteriorization, because cholesteatoma is something always amazing, every case being different. And the planning, the surgical approach is always a challenge, interesting and everything. So we'll have next case cholesteatoma.
The sphenoid ostia, when you have widened, you would not like to widen it inferiorly also? No need.
Not really, not need to. Otherwise, you can damage the septal branch unnecessarily. If you really want to, if you have a pathology in the floor, you want to expose much more, you have a huge fungus, you want more bigger opening for more, introduction of the topical steroid, you can widen it after elevating the flap anterior to the anterior wall. So that you can protect the vessel to the septum and then you can punch out the bone if you really want. Because this vessel is important nowadays. It's a vessel supplying the most useful flap, workhorse for the skull-based surgery, that is Haddad Basagestagi.
Yeah.
So whenever possible, should be preserved. So we have now the cholesteatoma case almost ready. In a couple of minutes, we are starting. And the concept in cholesteatoma, we have discussed many times. We'll discuss again in brief. Then we'll have a thyroid and then angiofibroma. This time, in contrast to the angiofibromas, we always show, we had a number of requests to show some open approach for angiofibroma. And this is the ideal case today for the maxillary swing approach, which we are going to demonstrate today. For everybody, the regions behind that will tell you, and the kind of approach it is. Everybody must be well versed with the maxillary swing approach as well, besides the endoscopic. Rather, I would say anybody doing endoscopic angiofibroma must know the open approaches also. Amongst the open, one of the most versatile is the maxillary swing one. So in cholesteatoma, there are two techniques, popularly known as intact canal wall and canal wall down. The appropriate functional terminology being interiorization and exteriorization. I'll tell you the reason behind it. Interiorization, when you reconstruct the ear and making it dependent, again like normal situation, dependent on eustachian tube aeration. Exteriorization means you remove the canal wall and exteriorize to the canal wall, outside canal wall, giving a wide meatoplasty. That is exteriorization. Why
But
this
again, the middle ear ventilation will be dependent on eustachian tube only, even when you are exteriorizing.
Yes, but you make the patient safe by exteriorizing the mastoid. Now, in between this, why these two techniques? But this covers all sorts of mastoid surgery. Suppose you remove in a case canal wall and reconstruct it again. Intact canal mastectomy doesn't define this, but here it defines as interiorization, because ultimately you are making it dependent on the eustachian tube function. Now, in cholesteatoma cases, ascertaining the eustachian tube function, the function itself is very, very difficult. How you can gauge by and large? By means of, air pocket in relationship to the eustachian tube anteriorly in the middle ear. If you find that, means your eustachian tube is, you can assume, working well. So, when you are doing interiorization, means the eustachian tube you are dependent upon. And what does eustachian tube do? Normally, it opens every now and then, more than 1,000 times in 24 hours. Constantly, the air pressure in the middle ear is being dropping by means of air being absorbed by the mucosa in the bloodstream. And that constantly leads to drop in air pressure. The moment it falls, the eustachian tube opens and delivers the air into the middle ear. That's how it maintains the ear pressure behind the tympanic membrane with the atmospheric pressure. That is a normal function of the eustachian tube, how it works physiologically. Now, what happens when we are dealing with a cholesteatoma, any unsafe ear, and planning interiorization? First of all, interiorization, exteriorization, both techniques are good, provided you respect the physiology and choose the appropriate approach for the appropriate case. So, when you choose the interiorization, what all is required? The thing which is imperative for an interiorization to be successful is good functioning eustachian tube along with the good amount of mucosa in the middle ear system. The reason being, if there is mucosa, that will allow the air to be absorbed, resulting in drop of pressure and then the role of eustachian tube to deliver the air. If during the course of the surgery, if you happen to remove the entire mucosa from the mastoid, aortic, middle ear, everywhere, and trying to reconstruct, trying to do interiorization, what the air is going to do in the bony trumpet, the bony walls around. Then when there is no mucosa, the Eustachian tube function is of no use. The air is not going to be absorbed by the mucosa, and that physiology between the air absorption and air delivery is never going to be maintained.
That means the dissection has to be between the colostoma and the mucosa. You have to find a plane and remove the colostoma and leave behind the mucosa.
Yes, if you are planning to do interiorization. Interiorization means your mucosa should be there for the air to be absorbed, and then the function that, you know, the synchrony between air absorption and Eustachian tube air delivery is maintained. Then only can work the interiorization successfully. If you do any good interiorization procedure with radical removal of the mucosa, it is not going to be successful in long run, and again the retraction will happen to occur and ultimate failure. And then the blame is on the technique, that is intake canal. It's not the technique which is to be blamed. It is the indication and appropriate execution of the interiorization which is more important. Similarly, why people are, you know, adamant about doing interiorization, avoiding canal down mastectomies or exteriorization? Because of the need of repeated cleaning, you know, to avoid swimming, the need to avoid swimming, the possibility of repeated infection, the, you know, unsightful, I would say, not very cosmetic part, that is the meatoplasty, large meatoplasty not appearing good. All these things people want to avoid. Even the patient want to avoid, the surgeon want to avoid. And that can work very well if it is executed properly, because the proper exteriorization requires a proper exentration of cell, proper lowering of the facial rays, proper clearance of disease from all hidden areas, and then a good meatoplasty lining with the you know, epithelium, and all this thing. A properly executed exteriorization canal down is an amazing procedure, provided executed well for the right indication. So both the techniques are actually equally good in terms of long-term results, in terms of, you know, success, provided chosen for the right patient and executed properly. And that is always a point of discussion, that what technique is to be used for what patients. By and large, exteriorization is the technique of choice once cholesteatoma is there, except interiorization can be done in only those situations when you preserve the adequate mucosa and assume that the Eustachian tube function is good. Then only attempt interiorization, otherwise always exteriorization. And many of the cases, this, you know, the patient is eligible for interiorization, but this final decision is always intraoperative. You have to tell your patient it is always intraoperative. And once you are doing interiorization, you have to make patient always prepared for a second look procedure in case required.
Second look would mean open it all over again.
Interiorization may require, if it fails, a second look. If you are not sometimes happy with the, you know, Eustachian tube function, or some retraction is happening, you have a doubt of leaving cholesteatoma, for many reasons, interiorization may require a second procedure. But yes, with interiorization, if retraction is happening or cholesteatoma is coming back again, there is no doubt about doing an exteriorization as the next procedure rather than repeating the interiorization. That has failed because it failed the criteria of interiorization, and now there is no scope of doing the interiorization again. This is a very, very important decision making to add on to the success of, you know, cholesteatoma surgery.
Can I add a point, Satish?
Yes, sir.
See, the other thing is when you interiorize and you have a doubt, from your teaching, I've learned there is this non-EPI DWI scan with restricted diffusion,
yes, sir,
in which you can detect a residual cholesteatoma.
Absolutely.
And anything suspicious, you can go ahead with a second look.
Yes, sir. Yes,
and you are spot on.
Yes, sir. Your point is valid. Yes,
Yeah.
sir.
And why people hesitate to do exteriorization is also because they need to do a beautiful mastectomy like you do in subtotal petrosectomy. Then the cavity will not leak. And lot of them are not confident of doing a complete, near complete mastectomy, which is why they tend to go more in for interiorization. But interiorization actually is more difficult because you have to preserve the mucosa from the eustachian tube at least up to the auditus and a little beyond. This is what you have taught me.
Sir, absolutely. Your point is very valid. To prevent a second look, like Deepak Haldipur sir said, there are ways. Number one, like he said, a diffusion weighted MRI can pick up the cholesteatoma very well. Rather than re-exploration, you can try a good diffusion weighted MRI with contrast to pick up the cholesteatoma. Whether it is recurring, then obviously you need a second look. Second thing, the endoscope. Endoscopes helps again to know in detail whether some cholesteatoma is happening in the corner somewhere else, which can confirm and need arises, and only the second look is required. That is one thing. Second thing, beside this clear concept of interiorization and exteriorization indication, there are certain caveats, certain biases, I would say, when we are biased towards the interiorization and exteriorization, in spite of defeating the concept. The reason being, like examples like children. Children, we always try to give interiorization, as the cavity problem handling in children is always difficult. And we try our level best to give more and more cases interiorization. Yes, there is a possibility of failure, and along with treatment of the nose and paranasal sinuses simultaneously. In adult patients, elderly patient, we are biased toward doing exteriorization because you may not get a second opportunity for a revision procedure in elderly patient because of the fitness issues and all in future. So just one stage, do exteriorization and get rid of it. What's my point? Only hearing air with cholesteatoma, we are always biased with the exteriorization without doing ossiculoplasty. The reason being, we don't want repeated procedure which can add on to the sensory hearing loss, or any attempted ossiculoplasty can manipulate the ossicle, leading to further sensory hearing loss. So there are biases like children, interiorization, elderly, only hearing ear, patient presenting with complications like extradural abscess, this, that, extensive disease, bias toward exteriorization to monitor in future to prevent further complications. So these are biases defeating the basic rules of selection of interiorization and exteriorization.
Can I add a point, Satish?
Yes, sir, please.
Even patients who have these bad medical conditions where you can't think of a repeat surgery,
Yes.
other general conditions, we would favor exteriorization.
Yes, always. Absolutely. When you don't think a possibility of a second surgery happening because of the medical issues or anything, and the patient is having cholesteatoma, do one stage cholesteatoma exteriorization and get away. Rather than, because in interiorization, you always have to keep an option of a second look. Patients coming from the long distances, not able to come for regular follow-up, because interiorization requires long-term follow-up for any recurrence, retraction, whatever. So patient coming from long distances, from villages, not able to turn up for the follow-up on the regular, better to do exteriorization.
And if all of us can do a mastoid like you, then exteriorization will not give cavity problems.
Yeah. You can reduce the cavity. You can excentrate cells well. You can do a good myotoplasty. You can reduce the cavity by means of partial obliteration using some flap, some other tissue, some cartilage, bone, whatever, and avoid the cavity issues. So that is another issue. The advancement in the surgical technology, we can take the help and avoid those issues. So do we go ahead with the surgical case? We can continue discussion during the case as well. The canal has been opened by our associate. And after this, the next case would be a thyroid and then angiofibroma.
Thank you very much, sir.
हाँ इजने को ले ले एक और ले ले सर हेलो हेलो
Hello.
yes sir can you hear me
Yeah, we can hear you.
yeah are you getting the microscopic picture इसको सही करो ना यार कैमरा सही करो ये लगाओ ये है गंदा ड्राई देना गॉज ड्राई गॉज दो हेलो
Hello.
am I audible sir
Yeah, sir. You are audible.
so for this workshop today I would acknowledge certain people whom I am indebted to. Dr. S.P. Dubey sir, who is the mastermind behind this entire program today. Then Dr. Deepak Haldipur sir, Dr. Sanjay Agarwal sir. These are the people who have done a lot of work behind this workshop for all 2-3 days. It was going on in Bhopal. What an amazing surgical cases demonstrated yesterday. I'm really grateful to them for involving me for this program today and giving this opportunity. I'm rather missing all these guys in Bhopal. I was to go to Bhopal actually and miss the fun.
We are grateful to you, Satish, that you never say no whenever we request you.
I am always grateful, indebted to you, sir. Lifetime. Now, are you getting the picture, sir? Picture क्यों नहीं आ रही साहब?
Yes, sir. We are getting pictures.
Is the picture good?
Yeah, good.
See, this is the.
Picture is good, Satish.
Now I think. So what you see, the mesotympanum. See, some air pocket anteriorly. Can you see?
Yeah.
And some this epithelium plastered to the promontory. Can you see?
Yes.
This is the handle of malleus medialized to the promontory. Then this posterior superior all retraction. Can you see?
Yes.
No incus visible. I think this is oval window depression. No stapes suprastructure at all.
Okay.
And see here, this is what cholesteatoma is. Can you see?
Yeah. Yes.
So the diagnosis is very clear. Cholesteatoma.
Yes. Very clear.
And we have a good air pocket anteriorly, you can see. So again, I am biased towards interiorization so far. I told you my decision would be intraoperative. The final decision will be intraoperative, depending upon the eustachian function and adequacy of the mucosal preservation. Okay?
Yes.
Now, and the moment I find that this is not good for interiorization, I will immediately exturize. Now my first incision is inferiorly, not 7 o'clock, it is almost 6 o'clock there because we will be doing ossiculoplasty later. This one.
Okay.
And my other incision so that I can raise the tympanomeatal flap from entire area of interest. The area of interest is superiorly, posteriorly, and my this other incision is anterosuperiorly flush with the anterior wall.
So presence of anterior pocket, air pocket suggests good eustachian tube function.
That we can assume. That's it. There is no other way.
So that is the only way we can predict that the eustachian tube
Yes,
function
yes,
is
yes,
normal.
yes. And most of the time we are correct.
Okay.
Now
Can
see.
I add a point, Satish?
Yes, yes, please, sir. Always.
Yeah. See, air pocket in the anterior part indicates that in childhood or in younger days, there was a poor eustachian function,
Yeah, which
which
might have
caused this
recovered now.
pathology. It
Yeah.
might have become static now, and the eustachian tube has gained its function
Yes.
between the age of 5.5 and 7.5 years.
Yes.
Or
Whatever.
maybe the adenoids have regressed.
Yes, yes.
Yeah, this is a case where I would also do a diagnostic nasal endoscopy before taking up a surgery.
Yes, always. All it's a dictum. All ear cases, we must look into the nose first. See now this entire tympanomeatal flap, right from the entire superior to the entire posterior wall, we have elevated. So that we can work in this area. That is our area of interest. Got my point?
Okay.
This is simple elevation of this flap. This. And this we elevated till 6 o'clock as we will be needing. I will tell you the kind of ossiculoplasty we'll be doing. That's the annulus.
Yes.
Okay. See this. That is the tympanomeatal flap. Now see inferiorly till where this air pocket is coming. See this?
Yes. Yes.
So here I can enter into the middle ear clearly into this air space much efficiently than superiorly. See this. At this point of time, I will enter into the air space.
Yes. Yes. Yes.
See this, the mucosa of the middle ear?
Yeah. Yeah.
Circle it. That is the middle ear. I've entered. See that?
Yes. Sir.
Because I could easily get the plane here, I could see the air.
So principle is to enter where you have a least resistance.
Yes. And see now, here is the epithelium which is going inside. See this?
Yes. Yes.
And we don't see the end of the epithelium. And see how it is, plaster to the promontory, we can gently elevate in the same plane. See this?
Yes. Yes.
Without breaking anything. See this being elevated?
Yes.
Now, similarly, superiorly, this way. Again, defining my area of interest from inferior to inferiorly, we have defined till the air space.
Yes. Yes.
And superiorly, see, anterior to the malleus is the air space.
Yes.
नमन किधर है? No. Side. See, I am getting into the air space anteriorly as well now. See now, I have already entered issue is to enter into the, by breaking the mucosa inside, behind the epithelium. See, this is epithelium.
Yes, sir.
And see, behind there, I am in the middle ear. See that?
Yes, sir.
So I have seen my limits anteriorly and posteriorly on the mesotympanum. See this
Yes, yes.
very nicely.
In
Now the
fact, watching his movements,
pardon?
we can note two things. Watching your movements, we can learn two things. One is your dissection in the right plane. We have a bloodless field, and because of the bloodless field, your dissection gets even better in the right plane. Both are contributory to each other.
Sir, now see what I am trying to show under little magnification. See, this is our area of interest between these two openings in the middle ear. This is the area which is diseased. So, now I have elevated this atic epithelium to uncover the malleus. See this?
Yes, yes.
And behind is this is the stump of the incus.
Yeah.
Now, this malleus has a handle which is incorporated in the tympanic membrane.
Yes.
See this? If I go between these two, again the middle ear space and the epithelium is intact, I can elevate. See this below.
Yes, yes.
At this point of time, at this point of time, दोनों हो गए क्या? दोनों ही ले लिए. See this. What I am doing, I am segregating this malleus head so that we can inspect the atic better, leaving this handle incorporated in the epithelium, in the tympanic membrane. Can you see this?
In the flap, yeah.
See now?
Very clear.
Very clear. And now this kind of this ossicle I will remove so that I can inspect the atic thoroughly later. See this?
Yes.
In a cholesteatoma case, these ossicles are, see this?
Malleus head.
Yes.
Especially the head of the malleus and the body of the incus.
Yes.
Once you remove,
See
the
this?
ventilation improves by leaps and
See
bounds.
see this cholesteatoma coming out.
Yes, sir.
Push from behind. Similarly, this is the body of the incus. See that?
Yes, yes.
Stapes suprastructures already absent. So this patient for ossiculoplasty also is a challenge now.
Not for Satish Jain.
डायरेक्ट यूट्यूब पे आ रहा है यार.
See, I am using the ball probe as a blunt dissection.
मैं आपको लिंक भेजूं क्या? लिंक तो है ना.
ये YouTube वाली ले लो ना.
Can you see? See the interesting finding. Sir?
Yes, sir.
See, I have elevated this epithelium intact
Yes,
so
sir.
far.
Yeah,
And this is what tendon of tensor tympani. Can you see?
Okay. Yes, sir.
Holding the malleus handle and the entire epithelium. Can you see this now?
Yes, yes.
very,
What we
very
have-
clear.
Now, some important things coming in. See now, just below is the fallopian canal. This is the fallopian canal.
Okay.
And that is the oval window. Can you see the oval window?
Yes, yes. You can see the foot plate.
See, the instrument I am using is the blunt one.
Yes, yes.
Elevating this epithelium from anywhere without traumatizing the mucosa below. Can you see?
Yes, sir. Yes.
So this part of the job done from this side superiorly. Now see what we have done. See the epithelium being elevated from all around.
Yes, sir.
See this? And this is the handle of malleus. Now, what is the area left? The most important, that is posterior superior.
Yes.
And we never know this, how deep this epithelium is going. See this?
Yes, sir.
See how deep this epithelium is going? Can you see here?
Yeah.
Nobody knows. So how will you ascertain? See this area from here to here, between these two instruments.
Yeah, all clear.
See this? Rest is all clear?
Yes, sir.
And to uncover this area, we'll uncover it from anterior and posterior, both aspects.
Okay.
And everywhere we have preserved the mucosa so far. Can you see this?
I have a feeling that
Middle
you
ear
will
mucosa completely preserved.
Yes, sir.
Atraumatic, even the atic area completely
this
preserved.
case.
See this atic mucosa completely preserved. Can you see?
Yes, sir.
Only the intact epithelium sac elevated. So far, this is we have achieved. Now, in order to get this epithelium elevated between this area where it is going deep inside and this area where it is going deep inside, between these two regions, between these two my instruments, the obstacle is this bone. So we'll handle this bone from anterior and posterior both sides, and that will dictate us the removal of this epithelium, completely, and that finally will decide our approach whether we'll go for. So far, we have good, environment for the interiorization section. Agreed?
Yes, sir, I agree.
Can I add a point, Satish?
Yes, sir. Always, please.
Probably this is also an area where endoscope can be used.
Yes, this area you can take the help of endoscope to see the, depth of the pocket. It can give you a reasonably good idea, but endoscope will not take you behind that pocket.
Yes.
You never know what is happening there. So what we'll do, we'll uncover everything. We'll not leave any surprise. Medium size with the diamond. So first of all, I will remove this overhang.
Okay, sir.
And then I'll come from behind, making this canal thin underneath which everything is hidden, and uncover everything intact.
Okay.
What I'm doing, making the ledge of the bone, which we can punch out later. डालता है. Side. See, I am gauging the depth of, the epithelium extent. Accurate. See the round window?
Because this is the area where one is likely to leave epithelium, in which case we can have a residual cholesteatoma.
Yeah, this is very, very important area. You're right. And soon will be uncovered. See the extent of epithelium at this level.
Yes, sir.
Can you see?
Yes.
See very careful. Let me, Let me show you very, very interesting finding here. See, this is our fallopian canal you have seen earlier. Can you?
Yes, sir.
Can you see the sac intact here coming out?
Yes.
This is your oval window area. This is your round window area.
Okay.
Very neat.
See this intact sac coming out.
Yes.
Can you see very clear?
Yes, sir. This is pyramid.
Yeah.
This
See
is
this intact sac, and now I'm opening this mucosa to show you the oval window. See this. Both the windows.
yes, yes. Round window, oval window, both.
Can you see very clear?
Yes, sir.
See oval window and round window both. This is round window. This is oval window. And this is your fallopian canal. Very, very clear.
Yes, sir.
All everywhere the mucosa is intact. This is part of the tympanosclerosis a little bit. See this?
Yes, sir.
Can you see the whole window?
Yes, sir. We can see.
Foot plate?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Hello?
Hello.
See the mobile foot plate.
Yeah, yeah, yeah.
Yeah, yeah, very, very clear.
Hello, everybody.
Yes, sir. Hello.
Hello? Can you hear? Hello? Satish?
Hello, everybody.
We can hear you, sir.
I think he's lost on audio.
Visual.
Speak to Dinesh Pal.
For the elevator. Hello, everybody.
Hello.
I can't hear whether they are connected or not.
Hello? Satish?
उनकी आवाज नहीं आ रही ना कि whether they are connected or not.
Hello?
See the entire promontory. Everywhere the epithelium elevated intact. See this? Hello?
Hello?
Hello.
Somebody speak. Hello?
Hello. Sir, we can hear you, but we cannot, our voice is not going to Dr. Satish Jain, sir.
Yeah, now I can hear you, sir.
Yeah,
Okay.
good, good, good.
So could you see I have elevated the entire epithelium?
Yes,
yeah,
sir.
yeah, yeah.
Let me show
Satish
you
is the
again.
whole window nice little deeper.
Yeah, let me show you again. What
Yeah.
I have done. See this entire tympanic membrane now lifted off.
Yes.
Elevator.
We saw the foot plate beautifully, blue foot plate.
Yeah, yeah. Let me show you again. See this.
Yeah.
And all plastered tympanic membrane lifted off in the right plane. Everywhere the mucosa is intact. Can you see?
Yes, sir. Yes, sir.
Fantastic.
This is oval window, round window, and the fallopian canal. Round window, oval window. See the footplate mobile. See
Yes,
this?
sir. Yeah, yeah.
And this is the
Facial.
facial
Fallopian.
now. So now this part is clear. Now the
Yes.
only area which I have a doubt is this where this epithelium is going
Going.
to certain extent. See this is.
Yes,
And I
yes.
don't know how deep it is going, this one. Like
Right.
Deepak sir said, endoscope can tell you. We can certainly take the help of endoscope, but here I will curate. I will go from behind and see exactly how it is going deep.
Okay. Sir.
What I am observing so far, we have a good amount of mucosa preserved. The eustachian tube function looks good. And so far biased towards the interiorization. So far.
Yeah, it looks like it may do well with interiorization. The way you have dissected.
Yeah. So now this pocket going deep towards the adductor. See this?
Yes.
This
Yes.
pocket.
Yes, sir.
I will not excise here at this point of time. I will come from behind. Give me a cotton ball. Because we will assess is how deep it is going and try to remove it under vision. So far, anybody, any questions? We have very, very experienced Dr. Haldipur sir with us.
The most experienced student of Satish Jain.
No, you are amazing. Periosteum, we'll open from behind. We'll look into the atic as well. And like Deepak sir said, the endoscope can really be very, very helpful in these situations, bipolar. Now, I hope the picture is good.
Yes, sir.
Now, let's open from behind. Suppose this pocket or this cholesteatoma going deeply into this region, posterior superior region, and not your you're not happy with the kind of removal from both sides, and rest is all okay and good candidate for interiorization. What you can do? Remove this part of the canal wall from here to there, whatever that particular area, and get the same exposure for cholesteatoma removal like canal down. And once you are done, after the cholesteatoma removal and you fulfill the criteria of mucosal preservation and eustachian function for interiorization, you can reconstruct the canal back. So take the advantage of canal down, but avoid the canal down. What's my point?
Yes, sir.
So never get biased with the extent of cholesteatoma towards canal down. Any cholesteatoma can be removed, keeping the canal intact, or taking a part of the canal down, you can reconstruct it back. Don't get biased towards the approach with this fact only. Don't sit down, Lapani. See, I can take the guide of the dural plate. Can you see?
Yes, sir.
Change in
Pink.
colors.
Yes, yes. So you're just opening the antrum first.
Not entering, I'll go to the place where the sac is going behind. Antrum will automatically come that way. But
Satish,
aim is not antrum. Yeah, yes, sir.
Arshad Hussain has a question. Dr. Arshad,
Yes.
he says, could you have gone inside out to check the attic?
Pardon?
Could you have gone inside out? Instead of going to the mastoid this way,
Yeah.
post, could you have done this?
Yes,
Yeah.
yes. I could go inside out. The aim is same.
Yeah.
Aim is same to follow the cholesteatoma.
Yeah.
Now, how you handle this canal? Remove
Yes.
that, thin that, replace that is all variation in the technique.
Yeah.
Inside out or outside in, the aim is same.
Yes.
But here, this way, I want to preserve the original integrity of the canal wall. That's it.
Okay. Okay.
If you do inside out again, you can reconstruct the same way with the cartilage. Right, sclerosed mastoid. See the thick mucosa. Can you see?
Yes, sir.
See behind the mucosa, which I am leaving intact. See, this is thick mucosa.
Yes, sir.
Can you see the thick mucosa? And this
Yes,
mucosa
yes.
being intact, I don't want to damage this vital mucosa. See this? So good.
Yeah.
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 And sac is not coming right beyond this.
Mm-hmm.
You know?
Yes, sir.
Sac is not coming beyond this. The mucosa is good. Posteriorly, mucosa is good. Anteriorly, everywhere mucosa is good. So I'm
So
more and
we
more
become
biased towards,
interior decorators.
yes, more and more now, almost certainly biased towards interiorization. Because now removal of the sac is secondary by canal down or up. If I have anybody having any doubts about cholesteatoma removal at this phase with fulfilling all criteria of interiorization, you can take this canal down. There's no harm in this. Take this down and reconstruct with the cartilage.
Yes, sir.
See all thick mucosa. एक side छोटे दे बस. See, I'm going towards the editus.
Yes, sir.
पतला गया. Bur size.
Yes, yesterday evening we had a good case, Satish.
Sir.
Canal wall down.
Okay, great. You demonstrated?
Yeah.
Oh, great. I will see in the recordings. See, now you have no incus. You know it.
Yes, we have removed.
Now I can see my sac coming. See this with this tilt. I could see the glimpse of the sac coming behind. This. Can you see?
Yes.
See the sac below? Can you?
Yes.
Intact sac around?
Yes.
See, this is the sac.
Yes. Push it.
See, I just elevated and kept it intact.
Yeah.
See the good mucosa below. Can you see the editus opened up?
Yeah.
Push the sac little bit anteriorly.
Yeah.
Anybody, any doubts, please feel free to interrupt me. Now see again, far anteriorly. Can you see the sac?
Yes.
What I will do, as I told you, will remove it intact so as not to leave any chances of. Now, give me a cotton ball. Long, थोड़ी लंबी सी. पतली. See this. I will little push from here without rubbing the mucosa, without damaging the mucosa. All the way mucosa is intact in the medial wall. See that?
Yes, sir.
Gently push the anteriorly and let's remove the sac from front now to complete the disease removal. Can you see my sac coming?
Yes.
See this?
Yes.
Can you see?
Yes.
All intact?
Yeah. Great, sir. Great.
That is the disease removal now. And see, from there it is going behind. See this?
Yes.
Sharp scissors. I will cut away and give a perforation there. See that?
Yes.
Now everything intact. Deepak sir,
Yeah, Satish.
sir, could
Tell
you
me,
see the
Satish.
sac came out?
I'm watching everything.
It came out
Sac came out
intact.
beautifully. Yeah, beautifully.
I
Yes.
pulled it
Yes, Satish.
with a slight traction so
Yeah,
as to avoid the
yeah.
break in the continuity.
And the mucosa is intact. You can
Yes, see
now go ahead with
everywhere. See the
interiorization.
mucosa in the atic floor.
Yeah.
See the mucosal vessels everywhere. Fallopian. My entire cholesteatoma came out intact.
Fantastic.
Mucosa. And this is a ideal case for interiorization. Now I can say. I can use this word. Now we have a perforation as we excise the neck of the sac. See, now what is left for us to reconstruct the tympanic membrane and the ossicle? Agreed?
Yes, sir.
Deepak sir? See now, we have this.
Hello.
Deepak sir? Deepak sir?
Yeah, Satish, tell me.
Would you do anything differently?
Not at all.
Do you
Except
agree?
nowadays
agree?
I use the endoscope, Satish.
Yeah,
30-degree scope with the camera.
but now see, we
Yeah,
have directly seen from both sides,
yeah,
removed intact under vision by thinning the canal wall behind,
yeah.
by coming from behind everywhere and came the sac intact.
Dr.
Now we
Vishwas
have this-
Vijaydev had got two such cases. I used the endoscope in both the
Yeah,
cases.
that's a good
I
idea.
didn't use the mastoid. Yeah, 30-degree scope with the
Had
camera.
I not
Yeah.
been able to remove it intact,
Yeah,
I would certainly,
Yeah.
see. But now the way it has come out, there is no doubt about, any epithelium leaving behind.
yeah, Satish.
Now this is the final chance because what I want to convey, this is the ideal case for interiorization. Right. In spite of having cholesteatoma with such a good mucosa, good cells, why to sacrifice those innocent areas? See this. Now, why I am raising inferiorly? So that I can do my cartilage tympanoplasty. I follow this again for years together, the technique proposed by Dr. ABR Desai sir. And we'll be using the cartilage and the graft now to reconstruct. That's it, and then we'll move on to the other case. So what I'm going to do for this, I'm going to use a cartilage right from the foot plate to the inferior annulus. What's my point?
Yes, sir.
To stabilize at both ends. For ossiculoplasty, there are certain things important. Number one, and the most important, is the aeration. For any ossiculoplasty to be successful, the aeration is the key factor. And second is stability. See, I'm making this a small facet on the inferior annulus. See this?
Yes, sir.
To stabilize one end of the cartilage. See this? Fine.
Yes, sir.
Now we have to harvest the cartilage and the graft and finish it off. The next case is ready. That is a thyroid, the flap being already being elevated, and then would be the angiofibroma to finish. Now, can you see the tragal cartilage?
Yes, sir.
So our choice of material is mostly tragal cartilage. It has its inherent curvature as well. and good thickness. And what I'm doing is making an incision, leaving the, the lateral part of the tragus which has a cosmetic value. See this?
Yes, sir.
It's a good cartilage. And we'll be leaving the periosteum, which is tightly tethered to the cartilage on both sides. Should be there at least on one side. See this?
Yes, sir.
And then on the other side, you can easily harvest the cartilage. You can use scissors also. That is again a good alternative. Whatever way you are comfortable with. See, this is the good length of the tragus, which I want. And this will be enough for me, what I believe. See this long piece of cartilage.
Yes, sir.
This is too much, I would believe. I believe this, I will refashion it. See how big the cartilage is.
Yes, sir.
And finally, we'll harvest the graft once I reshape this cartilage. Side. वो देना elevator. See how big the cartilage is. We want our cartilage, we have a good mobile foot plate from there to the inferior annulus. From the foot plate to the inferior annulus, and this is a good, I want a bigger piece so that I can reshape it now. There. Cartilage has distinct advantages. First of all, body's own tissue, and with the perichondrium, see both sides perichondrium intact.
Yes, sir.
It sustains so well, it acquires vascularity so well. Yes, this is a good size cartilage now. This, this is for the facet. And this is for the oval window side. And we'll make it we'll make a joint in it. I'll show you how this cartilage will make sure that it moves like a joint.
Okay, sir.
Let's recheck the dimensions. See where it is going to. See the facet there?
Yes, sir.
Number one, it is most stable assembly one can think of, which is stabilized at both ends. See this? Number two, it is malleable. It's not a strut which can push the footplate inside. Even with the pressure, it is malleable. It is not going to push the footplate crack down. Okay?
Okay, sir.
Number three, I will give it a shape. Number three, it remains in contact with the drum all the way. So that is good for the long-term results.
Okay, sir.
Number four, it maintains the middle ear space underneath. You don't need any silastic or anything in case you have some roery or the promontory. Nothing is required. It won't allow adhesions. What's my point?
Yes, sir.
So that is the beauty of this, and what I'm going to do now. I will give it a height and then partially cut through to give like a joint. And that is amazing. That is the ossiculoplasty we like most. See this. For this strut, this is like a vertical strut, you know.
Yes,
It's
sir.
a good height to be very effective. What's my point?
Yes, sir.
Hello.
Yes, sir.
Hello.
Hello, sir. Can you hear us, sir? Hello.
Hello, can you hear me, sir? Yes.
Hello.
Hello,
Sir,
can
can
you
you
hear
hear
me?
us? Yes, we can hear you, sir.
Hello.
Sir, we can hear you. Hello.
मेरी अरे आवाज तो वहां से नहीं आ रही है मेरी बैटरी क्या करेगी पागल हो गए तुम तो उनकी आवाज नहीं आ रही यार सॉल्व दैट प्रॉब्लम चलो ये भी चेंज कर दो हेलो
Hello.
हेलो
Sir, we can hear you.
हेलो
Sir, we can hear you.
यस कैन यू हियर मी
Yes, sir, we can hear you.
हेलो
Yes, sir.
कैन यू हियर मी
Yes, we can hear you, sir.
आर यू गेटिंग द पिक्चर एज वेल
Yes, sir.
सी व्हाट आई हैव गिवन व्हाट आई हैव डन सी
So
आई
where you have given the incision over the strut?
या पार्शियल
Where means?
completely so the integrity of the cartilage spring is still there.
Yes, sir.
See, to give it a height. Now my
Yeah, yeah.
strut is vertical like a steppies, you know.
Yeah, yes.
And this cartilage all the way is going to remain in contact with the drum and give it. See, once the eardrum moves in, the cartilage is moved like this.
Yes, yes.
Cartilage is going to move like this. Can you see this?
Yes, sir.
And it will be like an assembly, ossicular chain. Can you see this?
Yes, sir.
I am pushing this and how the steppage is moving like this.
Okay.
See how stable it is.
Yes, sir.
How high it is. See the level of the facial canal. which is normally the height of the stapes is close to that, and see how high it is. See the
Yes, sir.
level of the medial canal wall. Can you see this?
Yes, sir.
That is the height of this strut.
Okay.
And it is so befitting into the oval window. Can you see?
Yes, sir.
So
There is
stable.
no need to cover the oval window.
No need to. And see how stable it is.
Yes, sir.
Everybody,
Yes.
this is our preferred osteoplasty for these situations.
Sir, the anterior end of this strut is lateral to the sulcus.
Yes. And I can see a good, see the round window reflex?
Yes, 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 yes.
Can you see or not?
Yeah, we can see, sir.
See the round window reflex, everybody.
Yes, yes.
This is very safe, very simple, zero cost, maintains the middle ear space, never going to reject, and most stable osteoplasty, I can say.
Excuse me, sir. If the fallopian canal has been dehiscent in such a case, what?
No problem. Cartilage never, gives problem.
But it is able.
Even if it touches the facial nerve,
Okay.
if it doesn't give problem.
Thank you.
I hope you understood what I did in this cartilage.
Yes, yes.
Not through and through, the cartilage spring is intact. See that?
Sir, centralized picture.
Is Dr. Haldipur sir there? Hello?
Hello.
Yes, sir. We can understand, sir.
Dubey sir?
Yes, sir.
Good morning, sir.
Good morning. Good morning.
It's all because of you only.
No, sir. It's all because of you. Everybody was waiting for this only. And what a wonderful things you have shown. Unnecessarily wasting time in buying a different ossicular prosthesis. And you have made such
See
a
the
nice.
ossicular chain, you can say.
Yes. The way you have
Yeah.
made the cut.
Partial
the
cut
way-
into the cartilage, partial
Yeah.
cut, keeping
Yeah.
good height of the strut, good height.
Yes.
Quite
Amazing.
higher than the regular stapes. And see this movement.
Yeah.
That too
This-
through the cartilage spring.
Right.
So partly the cartilage is intact to transmit the, the energy
Sound.
coming to it.
Though I don't do it, I am always amazed to see Satish doing this. Because
No,
I
it
use
is-
Madhavaya's technique. But Satish does this boomerang cartilage thing fantastic.
Boomerang. Yes. It is just like looking like a boomerang. You are absolutely right.
Yeah. So we have given this partial cut and it works like a chain. Amazing. And the hearing level it gives is really amazing.
And the medial space is also maintained, as you
Yes,
say.
very well.
And there will not be any adhesion, no need to put expensive gel film and everything.
Nothing is required.
Right, sir.
Now, lastly, the graft which I am going to harvest as a fresh graft, we need a little bit of the underlay support. That's it. Nothing much. And then replace the cartilage back underneath. That's it. And then move to the next case. So this
Great
is
show, Satish.
this
Very
is a
good
poor,
show.
believe me, poor man's osteoplasty and works very well.
And see, extrusion and rejections are almost zero.
Never with the cartilage. See, it is
Yeah.
so well supported at both ends.
Yes.
See, in osteoplasty, the thing which matters most is the stability.
Yeah.
You're putting a torp or PORP, you'll always, struggle with the stability.
Stability.
There's no question. It is, at both ends, it is fixed. Fixed means support, and it acts like a spring between both the ends. And to that spring, that cartilage cut in the middle after the height acts as a chain. So all together, it works very well. And in our hands, we have done thousands of such osteoplasty. It works like anything. This is our preferred osteoplasty when you don't have stapes, suprastructure, incus, anything. You don't need malleus also into this osteoplasty.
Right.
And zero cost. That's why I call it poor man's osteoplasty.
And what is your experience of post-op conductive closure?
Post?
I mean, post-op results in terms of AB gap?
More than 85 to 90% patient within 20 decibel.
Very good. Excellent.
Satish boss.
Yeah, yes, sir.
Yeah, I'm Dr. Devang Gupta from Ahmedabad.
Yes, sir.
How are you?
How, Devangi, how are you?
All okay, boss. One my question.
Yes, please.
Sir, we have drilled lateral attic wall and scutum, right? So do you want to reconstruct before putting?
Not really. We didn't remove much, first of all.
Right,
Number two, our aeration looks so nice.
Yes.
See, all these problems come when you have a faulty aeration.
Right.
Once you have a faulty aeration, you reconstruct whatever, it will retract.
Right.
Nothing can stop that. So it is the aeration which matters most.
Right.
Had I removed very significant part, like I said, I can remove the canal wall also, partly, then I would definitely reconstruct. See my fresh graft.
Yes.
Bed to bed. Revert it and place to the new bed. I will just put an underlay graft. See, so vascular it looks like.
Yes, sir. And sir, is there any study? Hello?
Yes.
Is there any study stating the rate of contraction, difference of contraction after putting graft within first 24 hours between temporalis fascia, fascia lata, and tragal cartilage with perichondrium?
To me, all are good. I am not aware of any such study. All are good. All are good, but by and large, suiting to the thickness of the tympanic membrane and the structure of the tympanic membrane.
Yes.
And the number of cases done worldwide, the temporalis fascia has been a all-time favorite. Time tested, you can say something.
Yes.
And works well. So there is no second thought about it.
Right.
But yes, even the perichondrium we have used a couple of times. Very well. Fascia lata, never, I would say. But perichondrium we have used a couple of times without any problem. See the underlay graft. See the fresh graft follows our instructions so well. Patla. Great to see Devang today. Part of the workshop. Devang is very highly academically oriented all the time. And we have always enjoyed his company.
Yeah, thank you, sir.
See, this is just an underlay patching, nothing else. Because we have, perforation at one place where the, this was going, which I am going to cover, and another was a tear. And now to this graft, we have a great support of the cartilage underneath, so you don't need to worry. See that some redundant epithelium. It will settle down. So now, no perforation, you can see. See this?
Yes.
Everywhere, good middle space, good graft below. Can you see this? Everywhere?
Yeah. Perfect.
And finally, take this again our spring. Simplest ossiculoplasty I can tell you for this most complex situation where no ossicle present. Sikal.
And one more question, boss.
Please.
So, in your hands, what is the indication for canal wall down surgery?
I have already mentioned several times
Okay.
that if you don't canal wall down is the number one procedure for cholesteatoma. Canal wall intact, I will do only if it fulfills the criteria of interiorization.
Okay.
That is, like in this case, a good appearing eustachian tube function. And second is preservation of the mucosa.
Okay.
If I'm able to justify these two things, then up, otherwise down.
Okay.
So there is no fight between these two.
No, no, no.
Yeah, see both ends. Let me sickle. Lower end is fixed. Now it is the upper end, which I want to stabilize. Except some biases, I told you. Biases means besides the principles, we are biased sometimes towards some approach. Like canal wall up, we are always biased when we are operating upon children. See the round window?
Yeah, perfect.
The beauty is this entire graft, the cartilage is going to remain in contact with the TM.
Yes, sir. But have you come across some cases where there is, after putting this graft on the oval window? Hello?
Yes, please.
You haven't, you are not getting round window reflex. Have you come across this kind of situations?
When not getting the round window reflex?
Yeah.
Generally we get, sometimes we are not able to see, sometimes the round window is not very well exposed. That is a different situation. But yes, when it is exposed, you always look for the round window reflex. Now I'm putting something to fix it. The other end. Round window reflex is something you must look for, I would say.
It's a physiological integrity.
Yeah, in case you have some mucosa in the round window,
okay,
or something you are not able to see, that is different. The round window overhang, something like that. There are conditions where you are not able to see is different.
Yeah.
See, this cartilage is so befitting. You have to adjust, fine tune to the level that it remains befitting. No, gel form.
Boss.
Yes, please.
What are your views regarding slicing of cartilage before putting it as a reconstruction? Do you ever do slicing of the cartilage or a full thickness?
For tympanic membrane reconstruction?
No, for this kind of, ossicular reconstruction.
Slicing? Why slicing?
Okay, not required?
Not really.
Okay, full thickness always, right?
Yeah, because we are using tragal.
Yeah.
Tragal is always, you can say, befitting in terms of thickness. This is to support the other end of the cartilage.
Yeah. For tympanic membrane reconstruction, you need to slice, right? Because it's too thick. Then.
Yes, yeah. If you are doing that.
Yeah.
But most of the time we have fascia, so.
Yeah, got it. And boss, one another question that I have not found any study stating the rate of epithelialization and mucosalization after grafting. Is there any you have come across?
Rate of epithelialization and mucosalization.
Mucosalization after grafting.
Yeah.
Because the graft acts as a matrix, right? Scaffold.
Yes.
There is epithelialization and mucosalization on either side.
Yes.
To form the neotympanum, right?
Yes, obviously.
Yeah. So the rate of epithelialization or mucosalization, have you come across some study?
See, when you call it as a graft take-up, when the perforation is sealed,
yes,
and no raw surface found. No raw
Yeah.
surface means the graft which was exposed earlier
Yeah.
has been epithelialized.
Right.
Then only you are not left with the raw surface. So when graft is taken up, means it will only be considered or only be possible only when it is the surface is covered with the epithelium. Until and unless it will not be taken up, it may acquire infection and reject. So, as far as studies are concerned, the success is only, implied when there is epithelialization. Otherwise,
Yes,
you can't call it successful.
Yes, yes.
See, now I am stabilizing on both sides. See, this is how it looks elevated to give a pressure effect. Cartilage, I have purposely taken a little more height.
Right.
This is a vertical strut, you can say, but in a different way. So this will keep a pressure effect on the foot plate, and it settles down as it, becomes the part, merges with the tympanic membrane. Believe me, once done, it is one of the most stable assembly you can think of.
Yes, yes. And even post-operative hearing is also good in most of the cases.
Yeah, most of the cases it works so well.
Yes, yes.
The thing is the simplicity. One can easily do it.
Yeah. And cost effective.
See this?
Yes, yes.
See this? How stable it is.
Perfect.
Unlike oscillator chain.
Yeah.
And see the height.
Very good medullary space.
Yes.
And boss, this is cost effective as well, now, because TORP cost not less than 9,000.
There is no cost in this.
Yeah, of course.
So that's the final picture. See my edge to edge flap. See this?
Any special post-op instructions?
Nothing. It is like any regular tympanoplasty. See the aeration from behind. Wonderful. Our cartilage is stable. Our tympanic membrane is constructed for the graft. Nothing else is required.
Yeah, almost physiological, right?
That is what interiorization is.
Yeah.
So quickly now, last two cases. The thyroid, which is a special request by Dubey sir.
Yes, because more and more ENT surgeon wants to get into the microscopic thyroid and parotid. And me and Dr. Haldipur definitely learn doing thyroid with Dr. Satish Jain's inspiration. And I think more and more young ENT surgeons should opt for
ये
it.
वॉल्यूम कराओ ले लो फटाफट
Sir, even being a ENT surgeon, hello, Dubey sir.
Yes, I am listening.
Being an ENT surgeon, we are used to use the microscope routinely, no? So in thyroid also, it is very easy to identify all the structures.
Yes.
Like
That
the
is
branch.
what
Yeah. Amazing.
popularized all over India.
Priceless. Yeah.
Hello.
Yes, sir.
Yes, sir. So in couple of minutes we are starting thyroid. It's already the flap has been raised, and meantime we can take questions. So नीचे करो.
Dr. Satish,
Yes, sir.
for this conference, our Chief Minister has given us blessings.
Oh, great.
So it's a 1 minute blessing. We can play that video and you can watch.
Yes, sir.
Please play that video. So, but very soon we are going to have call you physically in Bhopal.
Yes, sir. Looking forward to.
Because you see, Saturday night we missed you a lot.
I miss the fun.
Jaskaran was there. Satish was. Dr. Deepak and Ghaisas. We all were there. We were just missing you. So very soon, if Omicron is not there, then within 1 or 2 months, we are going to keep a very good live surgical workshop with Dr. Satish Jain. And I think he will definitely grace the occasion.
100%. I am looking forward. There is no question of saying no ever.
And you are very kind. And everybody talks about this only. You can listen that.
Sir.
Chalao bhai, Bhatni sahab.
डेमो बोल कॉल करके बोल दो
So just some technical difficulty.
Okay.
वो कुछ आ रहा है ना हाँ that's what I'm waiting for.
Dr. Bhatni, if it is not working, then we can go ahead with surgery. We can show that afterwards.
Just a second. It's being telecasted now.
Okay.
शरीर स्वस्थ होना चाहिए, स्वस्थ शरीर में स्वस्थ मन निवास करना। इसी उद्देश्य से आज दिव्य एडवांस ENT क्लिनिक का 4 बार करें। धर्म साधनम, शरीर माध्यम है सब धर्मों का पालन करने का। शरीर स्वस्थ होना चाहिए, स्वस्थ शरीर में ही स्वस्थ मन निवास करता है। इसी उद्देश्य से आज दिव्य एडवांस्ड ENT क्लिनिक का 11वां सर्जिकल वर्कशॉप प्रारंभ हो रहा है। 2 दिवसीय इस वर्कशॉप में मुझे प्रसन्नता है, देश के प्रसिद्ध ENT सर्जन जुड़ेंगे। मैं उनका मध्य प्रदेश की राजधानी भोपाल में हृदय से स्वागत करता हूं। ऐसे वर्कशॉप से गंभीर मरीजों को बड़े शहर में जाने के बजाय उनका इलाज प्रदेश में ही संभव हो सकेगा। मैं डॉक्टर SP दुबे सहित सभी डॉक्टर्स को बधाई देता हूं जो इस कार्यशाला में जुटकर नाक, कान, गले की गंभीर बीमारियों के निदान हेतु मंथन करेंगे। मैं एक बार फिर ENT सर्जिकल वर्कशॉप की सफलता के लिए बहुत बहुत शुभकामनाएं देता हूं। धन्यवाद। शरीर माध्यम
सतीश भाई
सर, सो ग्रेट।
और मैंने उनको बताया था कि जयपुर से हमारे डॉक्टर सतीश जैन जुड़ेंगे, जिन्होंने म्यूकरमाइकोसिस के इलाज के लिए पूरे इंडिया नहीं पूरे कंट्री में सब जगह सबको टीचिंग दी, जिसके दम पर सब लोगों ने म्यूकरमाइकोसिस की सर्जरी करी। तो जल्दी आप जब आओगे तो वी विल बी इन पर्सनल कांटेक्ट। थैंक यू वेरी मच सतीश फॉर ऑल। प्लीज गो अहेड विद द सर्जरी।
Sir. All thanks to you, and your blessings are always helpful, sir. Thank you so much. I am indeed
Please, sir.
indebted to you for all your blessings.
Your greatness. You can go ahead with surgery, sir.
Sir. So this particular case, her nodule, middle-aged female, nodule more than 5 centimeter probably, and on ultrasound, it was not very suspicious of having any malignancy. See, in workup, we need to ensure that what cases required surgery, and those are the cases who have a possibility of developing into malignancy. So we have to pick up all those nodules. All nodules are not malignant. All nodules need not be operated. If it is too big, sometimes patients get scared and they want surgery to get rid of it. So in workup, the best investigation in order besides the hormonal test is the ultrasound. And ultrasound is ultimate investigation, and it is operator dependent. So in your team, we should have a good ultrasonologist. That is the number one priority, because ultrasound can show certain features which are suggestive of or likelihood of malignancy. So ultrasound is one of the main investigation, I would say. And
how you placed FNAC?
FNAC we order after the ultrasound.
Okay.
Because ultrasound, if shows some suspicious features and some part of the nodule,
Okay.
anywhere, we
Then we
would
go for
take the aspirate from that suspicious part only. And to
Right.
increase the sensitivity of the FNAC, many times we get ultrasound directed, so that we get the aspirate from the right area to be more representative, to be more sensitive from the FNAC point of view. So to increase the sensitivity of FNAC, increase the overall yield of investigation, it is best to be done after ultrasound. Sometimes you have multiple nodules, all nodules looking benign. If some nodule is showing some suspicious feature, you can always take ultrasound directed, FNAC. So FNAC should be followed after the ultrasound, looking at the ultrasound features and to increase the sensitivity of FNAC. So this particular patient, we are going to discuss the surgical aspect, the details, how the thyroidectomy is done. We'll be doing hemithyroidectomy on this side, the left side. What I can show here to orient you, this is under microscope, so I will keep changing the position to orient you all the time. This is superior, you can see. Can you see?
Yes, sir.
This is inferior. that is the right side, and this is the disease side that is on the left side. So this is superior, this is inferior, this is left side, and here it is the midline. Can you see?
You are standing on the left side.
Yes, I am standing on the left side. And we have already raised the flap. And now
Dr. Satish.
Yes, sir.
Sir, can you tell us about your incision and can you tell us about your incision and the flap raising a little bit?
Okay, that is important. Though we have already raised, didn't show to save the time. So incision is important, and mostly the incision is placed, say around 2 finger or so above the external end, external joint, or at the most prominent part of the swelling, you can say.
Yeah.
For a smaller swelling, the incision may not be required, a too big one, and right from one sternomastoid to another sternomastoid can be a good, enough incision, or you can extend more on the disease side to get more exposure. A little bit of the extra incision we don't mind, because the exposure is key to prevent complications. Why we are operating this patient open? To prevent complications, because this surgery is not all about the nodule removal. It's all about the safety to preserve certain critical structures like recurrent laryngeal nerve, parathyroids, the superior external branch of the superior nerve. All these things can be preserved best with a good exposure. A lot of people have been trying now with a robotic, endoscopic, retroauricular, vestibular incision, so many things, struggling with the exposure. Only thing is struggling with the exposure. And those all techniques are, destined for benign, small benign lesions, which are mostly sometimes do not require surgery even. For malignancy, for preserving all this structure, for adding on neck dissection, you have to resort to open approach. All those approaches are not standard of care. And overall, the chances of, when you struggle with the exposure, the chances of complications are always more. So, in order to add on to the safety, in order to do a complete job, in order to do a required neck dissection, anything, you need an open approach. That is standard of the care. So, incision, a 2 finger breadth above the mediastinal notch, or the most prominent part of the swelling from sternomastoid to sternomastoid. You can extend little bit more towards the, if the swelling is too big, towards the swelling side. Then the flap has to be raised in the subplatysmal plane. Any neck surgery, it's a principle to or the advice to raise in the subplatysmal plane, which is a relatively avascular plane, and which prevents the flap necrosis as well as it gives strength to the flap with its vascularity. So this incision was raised, and see the upper level of the incision is right to the thyroid notch, and lower level utilizing completely to the mediastinal notch, so you can have full exposure of everywhere.
So do you inject some Jalocan adrenaline or saline adrenaline before the incision?
Yes, always. Now see what I'm doing. I am raising flap in the midline. See both anterior jugular veins. Can you see?
Yeah.
And see there's some interconnecting vessels as well. So I am raising the flap in the midline between the anterior jugulars. It is always better to protect anterior jugular. Sometimes we have to sacrifice to improve our exposure. Otherwise, it is better. It prevents the edema later on in this region. See now, elevate this soft tissue. Reason being, I want to get into the midline raphe. See, I am getting into the midline raphe here. How you can get into the midline raphe? Elevate this subcutaneous soft tissue. And see the spray cutting. It will automatically take you to the midline raphe rather than unnecessarily damaging the muscle. This lateral muscle here, is the sternohyoid.
Yeah.
Once you have taken this incision right from lower to the upper part of the exposure, utilize the full exposure. See this midline raphe. Hello?
Hello.
Sir, we are not getting
We are-
picture over here in Bhopal.
Not getting?
This picture is not
No. I think whenever he is getting cautery on, picture is gone.
okay.
Really?
Okay.
Yeah. In between, whenever you have used cautery, there is a loss of picture because his cautery is not coming. Right now, we are seeing the picture. As soon as you use the cautery, picture will go.
Okay, I will minimize the cautery use. What I'll do right now, a little bit of the flap, let me elevate this midline ref and then, no. Cautery, yeah, cautery leg. And then I'll not use much.
Sir, how often do you cut these muscles to get better exposure?
Yeah, if you have a very large, nodule, large, the goiter is too big, to improve the exposure, you can cut the muscle. But whenever you cut the muscle, suppose I cut the muscle for this side, more exposure, cut it superiorly and suture it back.
Okay.
The reason being, the nerve supply to this muscle comes from the lower end through the branches of ANSA.
Yeah.
From the lower loop of the ANSA, all these muscles are supplied. So to keep the integrity, the nerve supply, cut from above and resuture later on.
Yeah.
See, so whenever you're using the separating in the midline, take the advantage of the full exposure right from top to bottom, elevate completely. See this?
Yeah.
Now the first muscle coming, this muscle, see this? The most lateral one where I am elevating. See this? This is what? Stenohyoid. Can you see?
No, picture is gone right now.
Picture is actually waxing and waning.
No, why
Or
is it happening?
if you can do something,
Let's wait for a minute. He is doing something.
please let them adjust.
What happened here?
Now picture is there.
Now picture is there.
Yes, picture is there right now.
Most important thing here is the midline.
Hello?
The most important thing here is the midline.
Yes, always. Always in the midline. See this. And this lateral most muscle.
Yeah.
This is stenohyoid. And medial to this, a fan-shaped muscle, this is sternothyroid. Can you see this?
Yeah.
And underneath the sternothyroid here, see the plane?
Yeah.
Is the thyroid lobe. Can you see?
Yeah. Yes.
See now what I'm doing. Let me tell you, this is the simple technique. See, push your finger, make a plane underneath this sternothyroid. Can you see?
Yeah.
And what I'm trying to do with a blunt dissection, keeping your finger apart.
You deliver the thyroid out.
This is the right plane
Yeah.
where you can go in and get immediately into the, see this paratracheal avascular gutter.
Yeah.
See now?
Yeah.
This is very, you can say relatively avascular plane.
Yeah.
I hope it is clear.
Yeah, it's clear.
See, my lobe is elevated with a blunt dissection, and what you see laterally, the great vessels. See the carotid artery there and the jugular vein. Can you see the great vessels?
We can see.
Yes, I need not to, open up the plane here, but you can see very well.
Now the question is, which pedicle to be tied first, medial thyroid vein, middle thyroid vein, or superior thyroid artery?
Yes. So middle thyroid vein is never constant, number one. If it is, it drains directly into IJV, so it has to be ligated. If it is. So middle thyroid vein, if there, has to be ligated. Sometimes it is small. Let me show you.
My question is, which is to be ligated first, according to you? Do you like?
First, you will come across the middle thyroid only.
Okay.
And see, laterally, you will come across the veins. The arteries are always deeper. See this small vein laterally?
Yeah.
This small vein I can take. Now, as I mentioned, we are supposed to be there in this avascular gutter. See this?
Yeah.
See, I am opening up the facial planes more and more with a blunt dissection. The beauty of this avascular gutter is once you are in the right plane, you need not to look for many of the structures, they automatically come in your view. Many of these structures, they automatically come in your view. See this avascular plane, paratracheal.
Yeah.
Yeah, this some part of the strap muscle I can take. This is quite lateral. Just to improve the inferior exposure. Now we have a full exposure of this paratracheal region.
Yeah.
Anatomy is very important. Anatomical variations are also not uncommon. We should be able to identify and save those structures. Now, this is the avascular paratracheal gutter. Let me open up a little bit more. And see, in this plane, you will identify all important structures coming. I already mentioned about the important structures, the most important being the recurrent laryngeal nerve. Now the next thing, what you need to look horizontally before the nerves even. See, this is carotid artery here. Hello?
Yes, sir.
In the horizontal plane, the plane which I am opening up mostly runs the inferior thyroid artery. There is some vessel, this is too small a vessel to be labeled as inferior thyroid. Inferior thyroid artery is a branch of thyrocervical trunk, which is given off from the first part of the subclavian artery in the lower part of the neck, then ascends deep to carotid sheath, and in the middle of the neck, it turns medially towards the thyroid. But you know, the anatomy is so variable. You never know. See this?
Yeah.
I can't see any major trunk of the inferior thyroid in this particular situation. And this happens many a time. So the variations are so common. Now see, we don't see any inferior thyroid artery so far, but what I can see in this plane, see this avascular plane. This is trachea. See this?
Yeah, trachea.
This is esophagus.
Yeah.
And see, when you are in the right plane, you come across the recurrent laryngeal
Recurrent
nerve
laryngeal
in
nerve.
no time. See this?
Yeah. Yes, we can see.
Yes.
Left side, it is almost always in the TO groove
Yes.
because it ascends from the lower part, quite lower down in the thorax, winging around the aortic arch. Inferior thyroid artery is a useful landmark if it has a close relationship with the
Recurrent.
recurrent also. It helps you identifying the parathyroid also.
Parathyroid.
So, but you never know. See this, no inferior thyroid artery could be seen as a major trunk there. in focus.
You always try to identify recurrent.
Always. And if you are in the right paratracheal plane, it comes off automatically. You don't need to struggle for it. See, it came automatically.
Yeah.
And it ascends towards the larynx. And as it ascends up, it divides into branches very often.
Yeah.
See this?
Yeah.
Now, the most important thing as far as the thyroid surgery is concerned, as far as the morbidity is concerned, is to identify and save parathyroids.
Parathyroid, yes.
In a total thyroidectomy, if you happen to damage all four parathyroids and patient ultimately developing permanent hypoparathyroidism, is a disaster.
Now, how to identify parathyroid?
Yeah, that is the biggest,
Yeah.
question, and it is not always so easy because their anatomy is so variable.
Yeah.
Parathyroid descending from the embryo, they happen to be, the descent can be stopped at any point of time, right from the, upper part of the neck to the mediastinum, anywhere. Superior are more constant than the inferior ones. Inferior are more difficult to, identify. I will show you. I will try to see at the most common area. But otherwise, we have seen in the thyroid gland itself, sometime in the thymus, sometime in the mediastinum. You never know. And sometimes, in spite of having a full search, you're not able to identify. So parathyroids are always challenging. So, but I'll tell you the most common area where the parathyroids are identified. See the size of the nodule. Can you see?
Yes.
It's more than 5 centimeter, I told you. So the most common location of the parathyroid and the biggest challenge with the parathyroid is identification. Reason being, the color is variable. Normally, in young, it is caramel colored. As the patient grows older, it becomes more and more light with the more fat content. It is so variable in color, very small in size, difficult to differentiate from the thyroid tissue sometimes, from lymph node, from fat. You can assume anything as a parathyroid if you're lost.
There was some articles on using methylene blue to identify parathyroid.
Yes. Many things have been tried, a lot of fluorescent material, methylene blue. See, the idea behind that is methylene blue is good, safe, but it is, it gives patient a dangerous look. It lines the entire patient blue.
Yeah.
What you can do, you can inject methylene blue an hour before surgery, half an hour before, IV.
Yeah.
Can give 5 milligram or so per ml IV, and it is taken up by the parathyroid very well. So moment, had there been methylene blue injected, we would have seen parathyroid by now, appearing as a purple blue.
Any local application of methylene blue helpful?
No, local will not help. It is taken up by the gland from circulation.
Yeah.
So this is this. Why we are, what area we have to stay careful regarding the parathyroids? Let me tell you. Similarly, to the, methylene blue, many other, fluorescent materials have been tried.
Yeah.
No standard of care so far. And bottom line is your clinical sense. This microscopic surgery helps you a lot in identifying parathyroid, because many a time, day before I demonstrated, I could show a vessel coming from the inferior thyroid artery directly to the parathyroid. Following that vessel in the microscope led to identification of the parathyroid. By and large, yes, this is the area. This is the parathyroid. Let me show you. By and large, the inferior parathyroids are inferior to inferior thyroid artery. We don't see inferior thyroid artery here, very clear. And anterior to the plane of the recurrent laryngeal nerve. And their most definitive identification is when you find a vessel going to the parathyroid. Number two, they are submerged in the fatty tissue, and there is always a vascular plexus on the surface,
Yeah.
That is the most important for their identification, and that is what I have identified.
Incidentally, if you got it out, then you have to transplant it.
Yes, sir. See this first. Can you see this recurrent lesion now?
Yeah.
I have enlarged the magnification to show you something. A small structure. Can you see here with plexus of vessels over it? This one.
Yeah.
See the vessel.
Yeah.
See the bunch of vessels over it. That is the parathyroid. I'm quite sure here. These are the vessels going above it. And this is the network of vessel above it. And this is parathyroid. Anterior to the recurrent. And see the vessels going. So this, and I would prefer to stay away from this region as I'm doing only hemithyroidectomy for this, rather than fiddling into it to preserve the parathyroid. This is my parathyroid. So what happens, like you asked, if you have happened to damage the blood supply to the parathyroid, mostly what you do, you avoid catching the inferior thyroid artery at the trunk level laterally to avoid damage to the blood supply. Mostly, here you never see the parathyroid. I don't know how it is coming from. There are many network of vessels. But see this vessel going in this bunch, going in this one. This is parathyroid for sure, boss. This is all vessels are converging here.
Yeah.
That's a parathyroid.
Yeah.
Again. So, in case you have happened to damage this, what happens? It turns black.
Yeah.
And then you have the best way, if you are doing a total thyroidectomy damage, you're not seeing other parathyroid damage someone, you can transplant. And the principle is first confirm by frozen section that what you are transplanting is a parathyroid per se. When the pathologist confirms, yes, this is parathyroid, then only you can go ahead with the transplant. And what you can do, mince into small pieces like liquid. Cut into very small pieces under microscope, load in the syringe, and then inject into any of the forearm muscles, brachioradialis, any big muscle. Rather than inject, we prefer not to inject in the neck in the same field because it may require some treatment in the future if malignancy, some other things. So avoid injecting into the stenomastoid, but rather away from our field.
Okay. So do you get every day, every time when you operate serum calcium in the evening?
Yes, there are ways to monitor the hypoparathyroidism. And one of the ways is to monitor the parathyroid level, particularly if you are doing a total thyroidectomy. Intraoperative parathyroid level immediately just after the thyroidectomy, if they drop down significantly, can give you an idea about the injury to the parathyroid. See now, capsular dissection.
Yeah.
This is superiorly. To protect my superior parathyroid, I'll give you the location where the superior parathyroid is behind the plane of the recurrent laryngeal. This is recurrent laryngeal now. It is behind the plane. Submerged in the fat again. And mostly at the level of the trichotracheal joint. Say this is trachea. Trachea, I can feel the trachea. Yes, that is the joint.
Yeah.
That is the lower level of the trichotracheal joint, and behind that joint, in that close vicinity, is most of the time you see this fat. See this collection of fat. Collection of fat there. Lot of vessels converging here. just in this capsular dissection, leave this thing behind and elevate your gland to preserve the parathyroid. That's my point?
Yeah. Some people are only doing the capsular dissection and not ligating the
Yeah, this is one of the ways. I told you.
inferior, particularly inferior thyroid artery. They are very close to the capsule and they avoid touching it, the inferior thyroid. Rather, they are more through the capsule.
The reason is to preserve the parathyroid. This is one of the strategy.
Yeah.
See, this is my gland. Everything out I have preserved.
Yeah.
So it prevents you from damaging the parathyroid indirectly.
Yeah.
So I don't deny that is a good technique, I would say. Because these are so small structures, sometimes you may not be able to identify positively. You have to resort to all those maneuvers to preserve the integrity indirectly. See my recurrent in view?
Yeah. Can you please centralize the picture a little bit and turn it 90 degree?
Now?
Yes, better.
See? That's
you
the
are
recurrent,
going.
that's the recurrent laryngeal now going.
Yeah.
And our thyroid has been elevated far off. See this now?
Yeah.
From where it is entering into the larynx. See? And
Yeah,
therefore it is dividing into two branches.
Yeah.
See these two branches?
Yes, sir.
Very often it divides into branches, and that is behind the cricothyroid joint. It enters into the larynx. This is recurrent laryngeal now. How it enters into the larynx. We have already elevated the capsule. We have done a extra capsular dissection here just to save the parathyroids. Just for the sake of parathyroids. And now this inferior part I can elevate. These are some veins here. I can better take a clamp. These always drain in. These always drain into left brachiocephalic.
Yeah.
There is no right brachiocephalic. So
how much is the microscope helping you in doing the surgery?
a lot. It helps you many a times in finding the blood supply, small vessels going to the parathyroid, identification of parathyroid, identification of nerves. It helps you a lot.
Because you are using in parotid too the same microscope.
All parathyroid, parotid, thyroid, submandibular. Microscope adds on to your visibility, illumination, magnification. It helps by all means.
Have you used a harmonic scalpel for the thyroid?
Yes, many a times, very often. And it's good. It expedites your procedure, you can say. I'll show some time. It expedites. See now, the last thing. We have seen the recurrent, we have seen the area of the paras and parathyroids. We have seen the trachea there.
Yeah.
See this?
Yeah.
And now is the time to identify and preserve the
external laryngeal.
External laryngeal. See what I am doing.
Yeah, you are dissecting.
Okay. Here is the external laryngeal. See this.
Yeah,
Let me show you. Give me webcock. No.
The standard teaching is that you tie close to the thyroid.
Yes, as close as possible so that the nerve remains above. See, just understand the anatomy, how this nerve comes. It is a branch of superior laryngeal nerve which is given off from the vagus, in the upper part of the neck, just below the jugular foramen there.
Yeah.
And the superior laryngeal turns deep to the carotid artery like this, medially and down. And just before the thyroid membrane, it divides into two. The internal one pierces the thyroid membrane to supply the supraglottic, that's a sensory branch. And this external runs along the superior pole vessels.
Yeah.
See this? See the superior pole vessels coming?
Yeah.
And when this vessel enter into the thyroid, just before the upper pole of the thyroid takes a medial turn towards the cricothyroid muscle. And that is what we need to pick up. So to pick up, we retracted the thyroid on the same side.
Yeah.
To open up this anatomy. See the superior pole vessels?
Yeah.
And see this nerve. See this nerve taking a medial turn.
Yeah.
See this now?
Yes.
We have many a times followed this nerve right down. Let me follow this now to show you to some extent. Halka. Halka, halka. Bas. Cut with the scissors. Scissors. Let me show you some course of this nerve. See, this nerve is coming from above like this. See this now? I'm taking a turn here. See, coming from above?
Yeah.
I'm taking a turn. Can you see both the things?
Yeah.
Very clear or not?
Yes, sir.
Yes, absolutely right.
This is the external branch of the superior laryngeal nerve, which is taking the turn here. See this?
Yeah.
See, the best way to preserve some structure is identify positively, rather than relying on the indirect thing. See this now, the entire course.
Yeah.
And once it leaves medially, now you can take the superior pole. See that?
Yes, I can see.
So there is a classification for this proposed by the great Brazilian surgeon, that relationship of the external branch to the pole of the thyroid. If it lies within, say, this is the pole of the thyroid. If this lies within less than a centimeter distance from the pole of the thyroid, this is difficult to, preserve. You have to be very, very careful in dissection. If it lies more than that, it is more simple. See this? And this was the simplest situation.
Yeah.
And now keeping the nerve in vision. See, I am taking this. What my point?
Yeah. But you always dissect medially.
Yes, medially, so that you can see the nerve turning medially to the destination. And this is important nerve, small nerve. You may not appreciate the voice change in some people, even in spite of you damage this. But in a professional voice user, he cannot raise the pitch of the voice, and that's a disaster for him. So always make a habit to preserve this.
Yeah.
See this now going there below, is like it. I've taken the superior pole now.
Yeah.
And what all you can do intraoperatively, suppose you happen to injure this nerve. This nerve supplies the cricothyroid, the muscle extending from the thyroid to the cricoid cartilage.
Yeah.
That's my point? And the contraction of that muscle pulls the thyroid cartilage below towards the cricoid. What's my point?
Yeah.
That stretch tenses the vocal cord.
Yeah.
So what happens once this muscle is gone? The tension, to increase the pitch of the voice is difficult. So what you can do intraoperatively? See first of all this now before you move. See this now going medially.
Yeah.
Can you see this now very clear?
Yeah, we can see.
Going into the muscle, and this is cricothyroid muscle. See this.
Yeah.
See the clear nerves. This is the recurrent laryngeal nerve. You can see here. Let me see the angle. That is the recurrent laryngeal nerve, and this is the external branch. See this?
Yeah.
So what happens in, suppose you have injured this now, what all you can do most, take a suture. See this. Thyroid cartilage you can feel very well. See this, here is the thyroid notch.
Yeah.
That's the lower end of the thyroid cartilage, and this is the cricoid cartilage. Take two sutures, medial and both sides laterally. take the full thickness of the thyroid cartilage and pull it down to suture to the cricoid on both sides to raise the pitch of the voice to keep the vocal cord tense. But that cannot replace the nerve function, but it, at least helps the patient. Somehow, patient do not appreciate any change on voice initially unless they are very professional voice users. See now, last part. We are away from the nerves now.
Yeah.
आपको कॉस्ट्यूम कौन से सीट की दी हुई है?
That's it. So what we could achieve, part of the capsule. See, what we could achieve is a removal of the disease along with preservation of the recurrent, preservation of the external
area.
and
Yeah.
see here, that is the bad bunch of fat. Can you see again?
Yeah.
For the superior thyroid, again, the same thing I showed for the inferior one. See the bunch of vessels.
Superior parathyroid.
See the bunch of vessels. That's how you can see this. Let me show you. Why I always consider that.
Yeah.
See the bunch of here. See the bunch of vessels here. There, here.
Yeah.
Into this fat. Don't mingle into it. And see the vessels?
Yeah.
And this is the region of the parathyroid. This is the parathyroid, I can say. This one.
Yeah.
So this is superior. The inferior was below. The external and the recurrent branch. And we could remove the lesion. See the lesion?
Yeah. Now it's out.
Any other questions we can take always?
Now you are going to put a drain?
Corrugated. For a
Corrugated.
day or two. Yeah.
That Romovec.
No. See, hardly any bleeding. Where is the bleeding?
Yeah.
No bleeding at all. Not a single drop.
Yeah.
But still we'll put a corrugated drain. Again, see the recurrent laryngeal now there?
Yeah.
See both the nerves in same field.
Yeah.
Recurrent going there and the external branch going from there. And they both have almost an angle of 135 degrees to each other. So thyroid is preservation of structures. It's not about clamp and cut. Earlier, a lot of general surgeons would do this clamp and cut without looking at the, structures per se. But now with the advancement in the understanding of anatomy, surgical technique, microscope, you can pick up every small microstructure very well and prevent all those morbidity.
Yeah. You are going to put a lateral drain or through this incision, the drain will be coming?
Yes, through the incision, not another incision unnecessarily. Thank you, sir.
Thank you very much, sir. It was a real great watching you here at Bhopal.
Oh, thank you. All thanks to Dubey, sir.
Yes, sir. We feel obliged to you.
And now we move on to another important session. The last case of the today's demonstration. ये volume बढ़ा ना? Hello.
Yes, sir.
Yeah. You हटा देना camera. And the case is ready. That's a case of the young male patient with a massive JNA.
Yeah.
And some characteristic features I tell you. See, JNA is always diagnosed on the basis of clinical grounds. So the young male patient with bleeding mass in the nasopharynx, history of bleeding, nasal obstruction, all those. And this particular patient, first of all, I'll share the, imaging. ये जोड़ दो. इसको बुलाओ. डीएसए वाली सीडी, वाइंजोग्राफ वाली. कल वाली. और पूछ क्या? कल वाली. हेलो.
Yes, sir.
Yes, sir. So do we go ahead to the next case or any questions?
So please continue with the next case.
Okay. This particular patient has a massive lesion. You can easily identify or diagnose the situation.
Yes, sir.
This is the case. Massive lesion with contrast enhancement, with a lot of vascular channels, abnormal vascular channels as compared to a regular JNA.
Yes, sir.
And see the extension right from the beginning of the nose. See the most anterior part of the nose. Can you see?
Yes, sir.
With no space to put even an endoscope.
Yeah.
What's my point?
Yes, sir.
There is no scope, no space even to put your endoscope.
Yeah.
How will you go endoscopically? That too in a vascular lesion like this.
Yeah.
You need some space to maneuver your endoscope and equipments to deal with. And
Have you
here,
embolized this?
yes, I'll tell you the reason behind that. And look at the axial and other aspect of the lesion. See the three-dimensionally how big it is and where it is going. Now, right from the anterior to posterior, can you see?
Yeah.
No space in the nasal cavity at all. So, number one thing which goes against the endoscopy, that too to deal with such a big lesion, that too with such an abnormal vascularity with lot of intratumoral arteriovenous malformations. So this is the lesion. Now, number two, the extensions. See this lesion, if I come from anterior to posterior, see the vessels inside the lesion, can you see?
Yeah.
Huge vessels, I'll show you where these are coming from. Lot of arteriovascular malformations, abnormal malformations in the tumor. Adding on to the vascularity. And see how it is extending everywhere. And this is the region of the temporal fossa at the brain, the middle cranial fossa, where it is going towards. See the intratumoral arteriovenous malformations. Then we got the CT angiogram done. First of all, let me tell you. See, there are so many things which decides which patient to be embolized. We always discuss which patient require endoscopy and which require open approach. It's not the size which matters. Any patient, primary patient can be done endoscopically, whether it is going intracranial doesn't make any difference, except some exceptions. So let me show you the angiogram first. This is CT angiogram. Can you see the vascularity of the lesion?
Yeah.
Nothing but the big vessels inside the tumor. Lot of arteriovenous malformations. This is all about this tumor. With no place to negotiate your endoscope, with this much of vascularity, not regular vascularity from the internal maxillary or some other vessel, but a huge one with AB malformation. Now look at where the blood supply is coming from. See where all the blood supply is coming. This is the neck. Now this is common carotid dividing into internal and external. See, this is all the branches of the external carotid now emerging. This is ascending pharyngeal. This is another branch. And you go high up. Oh, sorry. Branch, and you go high up. Follow these vessels.
Yes,
Follow
sir.
this vessel. Follow this vessel. See this giving bunch of vessels to the tumor. This is from ascending pharyngeal.
Yes, sir.
Now this is the carotid which is going behind the mandible. See here, dividing into internal and external. See into the internal maxillary and superficial temporal. Getting abnormal multiple vessels emerging from the internal maxillary.
Yes, sir.
Then if I come back, we did a DSA also of this patient, and this patient has a huge blood supply from the facial artery branches.
Yes, sir.
So these cannot be tackled endoscopically, number one. All these requires embolization. This embolization may not be that much effective because it has a lot of dangerous anastomosis with the internal carotid branches.
Yes, sir.
And adding on to the blood supply and a lot of AB malformation. See this AB malformations within the tumor.
Yes, sir.
So our intervention radiologist did a DSA. What he found, which I am telling, a lot of AB malformation, dangerous anastomosis, huge vascularity even coming from the opposite internal maxillary. This opposite internal maxillary even was supplying to this tumor. This one here. See this tumor?
Yes,
and
sir.
this blood supply was coming from the opposite internal maxillary. Had 15% of the total blood supply coming from the internal carotid system, from the petrous and cavernous branches. And then the good part was good cross flow from the opposite side. That is a big relief in any case, because the disease I'll show you is in close proximity to the carotid.
Yes,
and
sir.
the skull base. So anything which is in close proximity to the carotid you are removing, you have to have a good information about the, the cross flow studies. And this patient has a good cross flow. I can show you here, but in the DSA also, where they did a balloon test and found to be very good. See this. This is both anterior communicating arteries forming A2. There's a good communication there. This is the posterior cerebral and giving this the posterior communicating vessel, communicating this carotid to the basilar system. See, this is posterior communicating artery.
Yes, sir.
So here, this patient has a good cross flow by and large, and with a good cross flow, that is a big relief to us in case some untoward happens. We can think of sacrificing the vessel at any point of time.
Yes, sir.
And the best way is to coil the parent artery in case required, in case ruptures, in case lacerates, in case gives a lot of problems, you can do that. So this particular tumor had a blood supply ascending pharyngeal, opposite side, internal carotid branches, then facial artery, and some of the distal internal maxillary branches. Internal maxillary has almost right from its origin till, sphenopalatine, more than 12 branches. Out of them 12 branches, most of the branches are feeding to this tumor everywhere. So this is not a simple tumor where you can catch the internal maxillary endoscopically and go ahead like we always demonstrate. This is
Yes,
the
sir.
ideal case for the open approach where you can deal with these vessels much better. Got this embolized as much as they could do it safely. They use the glue also as a liquid close to the dangerous anastomosis so that it doesn't flow in the internal carotid system and give complications. So overall, it's a complex situation for which we choose the maxillary swing. Now, looking at the extension of the tumor, right from here, see all these branches, the tumor is extending to the infratemporal fossa like anything you can see.
Yes, sir.
Nasal cavity, all paranasal sinuses,
Yes, sir.
down, and now see in the sphenoid sinus. See the sphenoid sinus, see the carotid artery there.
Yes, sir.
I will show you the course of the carotid and this tumor going laterally into the temporal fossa, the middle canal fossa. See this
Yes.
tumor, see the normal middle canal fossa on the opposite side and see the middle canal fossa on this side. So do you see?
Yes. Yes, sir.
So tumor, but it still looks extradural, let me tell you. See this? See, this is T2 weighted imaging and see the brain parenchyma.
Yes,
You
sir.
see, that is the level of the temporal floor. See the level of the temporal bone and what is this tumor done? Elevated the dura. Not
Yes, sir.
penetrated the dura, but elevated the dura. Can you see very clear?
Yes, sir.
Number two, see the carotid artery. This carotid artery, let me show you, bigger one. Carotid artery on T2 looks like a phloid. See the phloid, the normal carotid on this side.
Yes, sir.
Look at the carotid artery. See this carotid passing. This is the tumor medial to it in the sphenoid sinus. And this is the carotid becoming the petrous carotid. And above and lateral to the carotid towards the temporal fossa, this is the tumor which is going towards the middle canal fossa. Can you see it very clear?
Yes, sir.
That is a very, very critical part of the tumor. See this tumor everywhere with huge lake of blood vessels supplying the tumor everywhere, and on these grounds, multiple regions, tumor coming anteriorly, huge abnormal vascularity, internal external communication, AB malformation, multiple vessels contributing to the blood supply, including facial artery and other opposite side. On this merit was the case selected for open approach, and for this central and paramedian skull base, the fastest approach which can take you in no time is the maxillary swing. There are 2 or 3 open approaches everybody should be aware of. The lateral rhinotomy, the left foot osteotomy type 1 is a good approach. You can, in left foot, you can disarticulate the maxilla, from the rest of the skull base and elevate, pull it down, and you can see the skull base directly in front of you, and you can repair it very well with 2 or 3 plates. So that is
Yes,
again
sir.
a very fast approach. But since the tumor being so big, see how lateral it is going. See the
Yes, sir.
dimension of the tumor dimension, and that too, see the blood supply. See this 6 centimeter,
By 6.
more than 5.5 on both sides. And
Yes, sir.
that too is a very, very big tumor. And on this basis, this was selected for an open approach, and that was good for demonstration as well, as we rarely get opportunity to demonstrate open approach. Always for endoscopic, and this is the ideal situation for the open approach. Any questions? Zubair sir?
No, sir.
Any suggestions? Open approach is faster also.
How often you discuss the case with your radiologist, such cases?
Not regularly, earlier more, but nowadays less and less, unless I have some special doubt, because nowadays we read on our own and get on information. But yes, in doubts, we do discuss on the slightest doubt, but not on a very regular basis now, I can say.
So which external approach you will going to perform in this case?
Maxillary swing, straightforward.
Okay.
The moment you swing the maxilla,
Yeah.
it opens up like a book.
Right. And
You can remove the entire tumor in 10 minutes.
and embolization has been done.
Yes, because of such dangerous situation of anastomosis and multiple vessels contributing to it.
You will be using coagulator.
Now the role of coagulator is hardly anything. Since it is open approach, we can use our cautery directly.
Okay.
So this is the case, and because of its unusual extensions and unusual blood supply and no space in the nose, this was chosen as a preferred approach by us. Now, I always tell, in such tumors, what is the role of diffusion weighted? I always rate this investigation as number one to differentiate between benign and malignant. Many times, this month only we have a lot of examples when the patient came with the diagnosis of angiofibroma and turned out to be a malignancy. Diffusion will tell us exactly the diffusion of water molecules in the magnetic field. More water content, more diffusion.
And with this history of epistaxis.
Yes. See this. See on diffusion, such a bright with hardly any restriction in diffusion. That means more water content. It cannot be benign. It cannot be malignant. Had this been malignant, it would have been completely dark. So this is never a malignant tumor. Our diagnosis is correct. This is definitely JNA, no doubt about it. Diffusion will correctly differentiate or rule out a malignant tumor. That much I can say.
Any blood transfusion have been arranged for this case?
Yes, we have arranged.
Regularly have some blood ready or?
JNA endoscopically when we do, we generally keep 1 unit. Always, this case I have kept 2 units because this is something unusual. So 2 units. Let's see. More fast you go, see this is a very fast approach. As far as tumor removal is concerned, we'll be finishing most likely within 10 minutes. So faster you do, overall blood loss is less. So let's hope we'll not lose that much of blood, needing more transfusion. We can continue discussion, sir. Do we go ahead?
Yeah.
ऊपर का भी करता हाँ फ्लैप उतार लेते हैं मारता हूँ 2 मिनट इसको ना सूचर कर दें
Are you ready?
इसको लगाओ कैमरा, टेबल नीचे करना है। जारी पिक्चर। हेलो हेलो।
Yes, sir, we are getting the picture.
Okay, this is
The
through the
question-
microscope.
This is through the microscope. The thing is this, that how you have positioned the patient, head and up or some.
Neutral position. Patient is in neutral position.
Yeah. Any instruction or request to the anesthetics for anesthesia?
Hypotensive. Hypotensive anesthesia. That's the only requirement in this patient. So this is all arterial bleeding. Now this is through the microscope. I want to show you so that I can show you much better inside. Okay?
Yes, sir.
Hello?
Yes.
क्या कर दिए उसे लगा So we'll start with the skin incision.
Yeah.
My team has already given a palatal incision inside. Now see, this is our lip splitting incision.
Yeah.
Hello.
Yeah.
So this is a very, nothing new for anybody.
The same for Weber Ferguson.
Yes, yes. Oh, ये लाए मत यार. You can do your own way according to the convenience.
Yeah.
This is how I do.
You always use cautery for the skin incision for such kind of cases?
Yes, yes. Doesn't make any difference. See the field.
Yeah. You said you are going to be very fast.
The tumor removal is, the approach itself is fast. See, in maxillary swing, you are going to leave this, flap attached to the maxilla.
Yeah.
For the vascularity. When you deposit the maxilla back, it will be requiring vascularity, and that is always maintained with the flap with the facial artery in it.
Okay.
See the angular artery?
Yes.
This is the subciliary incision.
Yeah.
This is a deep infratemporal fossa extension.
Yeah.
There are sites of osteotomies, we all know.
Yeah.
For like maxillectomy.
Yeah.
See, this is the that is the frontomaxillary process. That's the frontomaxillary process.
Yeah.
That is one site of osteotomy. See this?
Yeah.
Then coming to the towards the zygoma, you know. See on the superior part of the maxilla, that is on the orbital plate.
Yeah.
See this orbital ridge?
Yeah.
See this? Periosteum intact, periosteum intact. Try to keep the periosteum intact. See this orbital process?
Yeah.
This is another site for osteotomy. See this?
Yeah.
And in between, we'll connect these two osteotomy with the floor of the, you know, that is infraorbital fissure. See the bulge of the tumor?
Yeah.
See, we'll connect this. See this, this, and this. Okay?
Yeah.
Then we have alveolar osteotomy. And here I will make one more for the zygoma. ये कर नहीं हूँ. This is additional I am doing. All we have to, you know, at the time of closure, either you have to do a plating or wiring, whatever.
Yeah.
That is for zygoma. आप कर. Mouth retractor there. Mouth retractor. Now see, our inside incision already been given.
Yes, sir.
I told you our team had started. And what we have given is just this palatal incision. See this?
Yes, sir.
Only this palatal incision. See? See how the tumor was popping out. See this?
Yes, sir.
Why this palatal flap is elevated? So that you don't sacrifice this palatal, you know, mycoperiosteum. When we break in the midline, you don't sacrifice this palatal periosteum.
You will be saving it.
Pardon?
You will be saving that palatal flap.
Yes.
Yes.
That is very important to prevent palatal fistula.
Yeah.
now our osteotomy starts. You can start anyway. पतला देना आगे दे. Or you can use a fine, burr as well.
Yeah.
Gentle. Otherwise, you will use a burr. Let's see. The bone should not be broken, as you have to reconstruct. See this?
Yeah.
With a very sharp osteotome. Halka. See, separated?
Yeah.
It should be very, very sharp. पहले इसको ले ले. Slowly. Okay, go on. I hope you are oriented.
Yes. Can you focus and make it central?
Okay. Now.
Yeah.
Better?
Yeah.
Better, sir?
Yes, sir.
Slow. See, this is a very sharp osteotome.
Yeah.
और थोड़ा. Disconnected. Now we'll connect with through the infraorbital fissure. These two together. See, already gone. See, the fissure is already gone.
Yeah.
पकड़ना suction नहीं है. Suction. Yeah. Yes. See, mobilize.
Yeah.
Again, mobilize. The last is this alveolus. See the flap. Let me see. See, the flap is already separated.
Yeah.
Through and through.
Yeah.
And then towards the pterygoid. Let's see if it is separated. Can you see the maxilla being
Yeah, yeah.
कटिंग से करना है यार सक्शन एक जना see how the maxilla is swung.
Yeah,
Can you see?
yeah.
And what you see there is just tumor.
Yes.
Can you appreciate?
Yes, yes, we can see the tumor.
Cut kar. That's a part of the turbinate there.
Hmm.
बढ़ा देना तो वो दे बॉन में ब्लर और कुछ ये हमेशा चालू रख दो now see cut now see the tumor in front of you.
Yes, sir.
Suction मत करना that वो कहीं पे भी and this being a huge tumor, see this.
Yeah.
See, I'm just pushing my fingers around to assess the adhesions around. See the tumor all around. Cut इसको. Yes. Now, I hope the picture is very clear. See the big tumor?
Yeah.
ऊपर से दो tumor. नहीं वो मोटी वाली. So I can see my tumor extension. We have seen that. And it is always a blunt dissection, you know.
Yes, sir.
See, this tumor grows circumferentially. And same way you have to pull this tumor. यहाँ लगा दे कुछ. दबा के रख ले. यूँ दबा के रख ले. This is the infratemporal part of the tumor.
Yes, sir.
See, this is all. This is the entire infratemporal part of the tumor. Yes. पकड़. See how vascular the tumor is. Under microscope, you may appreciate more bleeding. It may look more
Yeah.
because the field is magnified. Yes. See this. How to pull the tumor. Yes, these are the tumor extensions. See the big vessels,
Yeah.
all those big vessels coming to the tumor. Now, see this. That is the dura, that is the skull base. Section. See this? This is the tumor which we want to lift off. See this?
Yeah.
It is again the very, I would say, calculated pull. See, calculated traction, pull from the critical area. See, that is the dura. Can you see?
Yes, sir.
It was just, I told you, pushing the dura. Pull. Yes. See now?
Yes, sir.
Yes, sir.
Tumor coming from the greater wing. He is such a huge component.
Yeah.
Cut. Wait, this one broken. Always pull. This is all, malformation kind of a thing. This is all bad bone. Cut. Oh. See, inside is good.
Yeah.
And I have a microscopic vision.
You are using
Pull. It's all, deeply buried in the infratemporal fossa.
Yeah.
This is so bad. Yeah. So the last part which is coming out. See this?
Yeah.
You have seen so many endoscopic demonstrations of angiofibroma.
Yeah.
Open surgery is altogether different. It cannot match the, elegance of endoscopic surgery.
before endoscope, we used to do with
Yeah.
one technique only.
No. So by and large, see, that's the skull base. See the exposure to the skull base.
Yeah.
See the exposure to the dura, skull base everywhere.
Yeah.
With this approach, we are directly at the skull base. Not much. That was the dural, a little bit of the ooze. That will be controlled, not a big deal. That's the pharynx. Can you see?
Yeah.
Like that. Once we ensure the hemostasis back there, completely we'll assess each and every area thoroughly. Just wait for a minute. See now, tumor is almost out. This is the maxilla which was swung. And see this, we will replace it back without any issues. Okay?
Yeah. Yes.
That is not a big issue. But the moment you elevated the maxilla, see how the tumor came out. See where the big tumor was. Could you see?
Yeah.
Bipolar. Some infratemporal fossa oozing. See what I can see in infratemporal fossa limits. This is my mandible. This is temporalis muscle. The lateral limit दबा के रख. ये दबा के रख. So this is the temporalis muscle, the lateral limit. Now what I can feel with my finger. See, this is our palatal flap which we have preserved. Could you see?
Yeah. Yes, sir.
Venous bleeding in the pterygoid is, fossa. एक और दे दो बड़ा वाला section. Now what we'll do? Yeah, I can see. Full कर दे यार. See, these are all muscular bleeding. From venous bleeding, there is no tumor here.
Yes, sir.
I can feel the tumor if it is with my finger. It has come out. Only this venous and muscular bleeding. Yeah. How many abnormal vessels supplying in you? And this bleeding will stop in no time. It's hardly anything. So this area is good now.
Yes, sir.
See, this area is good now. We'll control this.
Yes, sir.
दूसरा देना और दूसरा दे बड़ा दे सर थोड़ा तो बड़ा दे. And this we have packed this with a Sergi cell. Now coming in the midline. The brighter. Now I will look into the sinuses. Part of the rostrum.
Yes, sir.
see the sphenoid sinus?
Yes, sir.
And this was another component. See this?
Yes, sir.
Don't cut, don't cut. Let it come completely. See the interior of the sphenoid.
Yes, sir.
So now, see, this was a tumor invading laterally. See this tumor, how it invade the bone.
Yes, sir.
See, pulled out. Always pull.
Yes, sir.
इसको काट दो, nerve अभी. Now I'm at the critical area here,
Yes, sir.
and this is the deepest part of the extension which has come out.
Yes, sir.
Now this is just venous bleeding. That signifies our job is done.
Yes, sir.
Little bit into the pterygoid bone here. See, there's a little bit tumor in the pterygoid bone.
Yes, sir.
This all bone has this tumor. So this bone is invaded by tumor. रुक जा हटा सक्षम क्यों बंद कर दिया? So I am right at the pterygoid base. दूसरी फंसी थी. And this part of the tumor has blood supply we saw on the angiogram coming from the internal carotid system. पकड़ो. Okay. We are in the close vicinity of the carotid there. इसको करना है. That's the region of the cavernous sinus. See, this is sphenoid.
Yeah.
That's the carotid artery.
Yeah.
I will show with the Doppler. What a massive tumor it was. See, I have scrutinized the carotid, will show you. Cord enough for sure. Cord for sure. Cord for sure. God. All skull base bone. पकड़ना है इसको पकड़ इसको पकड़ लो. See, this is just from the skull base bones. Oh, let's now. This I am removing from the sphenoid floor. See, that's the opposite U-second tube there. And that is the sphenoid base. All this, cancellous bone I've been removing. All this cancellous bone was affected. This cancellous bone, yes, a bit thoroughly assess ये carotid है. Very good. Soon I am going to show you the carotid. Can you see the carotid? Can you see the carotid? Hello?
Yes, sir. Yes, sir. We are seeing.
You can hear the Doppler.
Yeah, we can hear.
This is, see the bare carotid.
Yeah, yeah.
We knew, and see this was the sphenoid sinus, the cancellous bone involved.
Yeah.
That is the carotid, and lateral to carotid from where we remove the tumor is this temporal dura. That's the temporal dura. This is very clear now. Everything clear here. This carotid goes behind as a petrous from here.
Yeah.
Now give me bipolar. Bipolar. See, the tumor was right up to the wall of the carotid. Abhi se matlab.
Sir, here is a question from the audience that even if it is a benign tumor, if you chemo radiate it, whether it will be helpful.
Chemo radiated.
There is a question from our audience.
See, these are young patients.
Any debulking will be done by the radiation or
No,
chemotherapy.
radiation is never the answer to the surgical clearance.
Okay.
That is reserved for most, remote situations, not for a regular use. Radiation is not free of complications. These are
Yeah.
not elderly patients, young patients. They have to live long.
Yeah.
Now I am happy with the clearance. वो तो gauze. See how deep the skull base extension was. Everybody, you can see this is your carotid artery, this is your dura. See, can you see everything flushed?
Yeah, yeah.
Now give me drill. Drill, yes.
Side saying to supply.
See now?
Yes.
Hello?
Yes, sir.
This is my high-speed drill to all skull base spongy bone. See all this cancellous bone.
Yeah.
इसको कर लेना यार तो venous bleeding, I am least bothered, you know.
Yeah.
That is good. When the tumor comes out, you know what our aim is to give 5 minutes, but it was so deeply, extended.
Yeah.
The pterygoid completely destroyed. Bipolar. No. See, all this is dural. No. This area, if I see one by one, let me show you last. Before we close, wash. See, one by one. This is your nasopharynx. This is your sphenoid. Can you see?
Yeah. Yes, sir.
Like this. Right there. So that's the pack in sphenoid and nasopharynx. Now coming to this. See, most important. That's the carotid. That's the dura, and this is a little bit of the venous oozing, surgical, which now we will be controlling this with the surgical and pack over it. Surgical. So all skull-based surfaces So pack with the Surgicel as a layer, first layer. Yes, this Surgicel and this pack 5 minutes, and then we'll remove one final pack. बड़ा देना यार, इसका आधा कर. See, this is to apply Surgicel everywhere. That will control everything. So now will be we have ensured each and every area for the tumor, and this is to leave the Surgicel in place for some time. After 5-10 minutes, दबा कर. That's it. That's it. And in the closure, just we'll leave the pack for 3-4 days there.
We'll remove the pack after 3 or 4 days.
Yes, yes. हटाओ. Yes, yes, after 3 or 4 days. So that is the final aspect. We'll pack in 10 minutes time. Meantime, we'll keep it like this. Yes. Okay, so after 10 minutes, we'll remove this, put a pack and the outside sutures, and all these 4 osteotomies we'll put a plate. Okay?
Yes, sir.
Any questions? We have crossed the time limits, I know.
There is a question from the audience. Any local application of anything for control of the capillary oozing which is occurring there while during the surgery? Local or does it work?
Not really. Nothing works.
Yes.
Yeah, the Surgicel will stop in no time. No problem. Yeah, Very.
The external carotid ligation is better or the embolization is better?
No. External carotid. See, the proximal ligation of vessel is never going to work. It is even if you embolize, it is the embolization at the microvascular level.
Yes, sir.
Which works. Big vessel embolization is never going to work.
Yeah. No, sir, ligation. He's asking external carotid ligation.
And doesn't make any difference. Oh, छूट गया. जल्दी कर. No. So it is the embolization which can help you if it is done properly by the good, experienced intervention radiologist.
Yeah.
And that too, right to the microvascular level.
Yes.
So the bleeding has almost stopped. We'll keep the pack for 5-10 minutes.
Yeah.
Then we'll leave our, until the surgeon sticks there, we'll leave our pack. We could see the dura, everything, the entire skull base was so clearly visible.
Yeah.
How deep a tumor was avoiding everything. This was never a good case for endoscopic. You can understand now.
Yeah.
So this is the ideal case for this, and finally we drilled the bone. The carotid was involved as I shown on the scan, all from both sides.
Yeah.
Preserved. So once we remove the pack after 10 minutes, then we'll put a final pack. Any questions, anything you want meantime?
Yes, sir.
Bada. I'm waiting for the pack to be removed.
Very important.
Oh. Like. So this swing is a very good approach for such extensive lesions.
Sir.
These are most challenging cases. Endoscopy would take very long and
Sir.
It would be very, very tedious and too much of blood loss. This being the fast approach,
Sir.
is best for the patient for such situations. So in next 2 minutes, we'll remove the pack and then finally show you the final picture.
Sir.
Can we remove? Okay, let's remove the pack.
Sir.
Hello?
Ji, sir.
Yes.
तो अंदर बैठे थे अंदर बैठो अभी आपको भेजा था अब क्यों बाहर आए सर
Serious?
तो अंदर चलिए ना जूता उतारिए बाहर क्यों बैठे अंदर
Hello?
Sir. Sir.
Yeah, the field is good with little bit of the
Sir.
venous, yeah, little pack here. That's it. So by and large, you have a good field to pack now.
Sir, bleeding भी control हो गई.
Pardon?
Bleeding भी control हो गई मैंने कहा.
Yeah, everything. It has to come under control.
Sir.
That's the advantage of open approach.
Sir.
Okay, so we'll pack it.
Yes.
And finally we'll suture it. That is need not to be shown.
Sir.
But the field is very good now.
Sir.
What an extensive tumor it was.
Yes, sir.
What an extensive bipolar color. And what we have ensured is a. So, any other thing you want us?
Sir.
You will close.
Sir.
Close कर देना. Pack कर देना.
Thank you, Dr. Satish.
Sir, all thanks to you.
No, it's really a pleasure. And I was really amazed by your energy and enthusiasm. This is the continuous third day you are demonstrating across the India, first Jharkhand, then Karnataka, and then subsequently, at my request, at a very small Mayadevya Advanced ENT clinic, you have obliged us, definitely.
Thank you, Dr. Satish. It was a pleasure watching you. It is always pleasure watching a lesion. Like if you are watching Sachin Tendulkar playing, you will always be feeling that you are playing yourself. That is same we experience here. as we were operating, and it was very nice communication. The tips and tricks of the surgery you have always given during the your this workshop.
And it is rightly said that Satish Jain is the only true all-rounder of the ENT field.
Yes.
Sir. Thank you all once again. See you soon. Thank you.
Satish bhai, hoping soon to have you physically in Bhopal.
100%.
We will have a drink along with you. Then only our wish will be fulfilled.
Yes, sir.
Sure, sir. Sure,
Want
sir.
you here?
Thank you, dear.
Thank you. Thank you very much, sir.
Thank you, sir. Thank you.
हो गया ना
Recording stopped.